आप रिफ्रेश करना पड़ेगा. Okay, fine. Thank you, and I hope I am live. So what I'll do is you can disconnect the call and drop out. And if there are any issues, I mean, you have the access to the system anyway. Take care, man. Bye-bye. Hi guys, a very good morning. Another day at work, and today I would request you to come to page number 148, where we are going to discuss a lot of interesting stuff, especially with respect to electrolytes, which is again something which they love to ask in the exam. So I think we're good to go. I'll just check whether the audio and the visual part is fine, and then we can start going. So I hope that you had a good night's sleep and were able to practice the notes as well. And yeah, I mean, there is always a charm in making self-made handwritten notes, because then you're able to understand things. Because if you're using somebody else's handwriting, or if it's pre-printed notes, at least I really don't enjoy the process, because everybody has their own style of taking notes. And reading and analyzing somebody else's handwriting is always a challenge for me. But yeah, I mean, that is like on person to person. If you are comfortable with somebody else's note, I'm perfectly okay with it. And yep, yeah, should load up in any second from now. Fine, guys. So I think we are sorted and good to go. And the couple of names that just went up in the chat immediately, so I was not able to greet everybody. The topic of interest is electrolytes. I would request you to come to page number 148 onwards, and I'll teach you regarding electrolyte imbalances in kidney disease. The reason for that is that every time the kidney would be affected, there would be hyperkalemia occurring. Hi, Nadeem, Govind, and a couple of other young doctors, Yashika, Neeraj, where the names just went up. Okay, fine. So normal potassium in the body is 3.5 to 5.5, and let us understand what will happen if the potassium levels in the body will begin to spike. The first and the foremost thing that I want you to remember is that there would be an increase in the vertical height of the T wave. Now, T wave normal height is about less than 5 millimeter, and some of this information, hi Kevin, would always be a repetition, but it's a good idea to repeat it, because these are like the oft favorite aspects of our examiners. So the way or the hack is like, how in 1 minute can you remember, is what I'll try to do the activity here. Potassium is directly related to the height of the T wave. So the initial ECG finding that you get in the patient is tall tented T wave. And then I would like to say that ST segment का खुद का दिमाग नहीं होता, it doesn't have a brain of its own. The ST segment will always by default follow the T wave. So as you can see in the figure, the T wave is going up. So when T will go up, the ST will also be going up in this case. And therefore, the second finding that you have to note down in the handout is ST segment elevation. The last time I spoke about ST segment elevation was lots of causes, but I hope you can remember one important cause, myocardial infarction. The second important cause that I wanted to remember is acute pericarditis, and the third one is a angina. This angina is the only angina having a ST elevation, that is called as variant angina. So now, though I mentioned a lot of causes, I expect you to remember minimum 4. MI, acute pericarditis, take care, not constrictive pericarditis. That will be having low voltage ECG due to calcification. Variant angina and hyperkalemia are the causes which are responsible. Hi Tabrez, hi Pranav, hi Nadeem. Yeah, Nadeem, you have a good point there, but it was little preemptive, because now potassium is rising. So what will happen is that the T wave and the ST will go up, but the first wave of the ECG will become chotu. That will smaller. छोटा होना शुरू हो जाता है. जो डीपोलराइजेशन का करंट है ना, वो कम हो जाता है, और रीपोलराइजेशन करंट विल आल्सो बिकम रिलेटिवली टॉलर. द पॉइंट ऑफ द कॉन्सेप्ट इज फ्रॉम फिजियोलॉजी that depolarization current will become less and the repolarization current will be more. So यहाँ पे third ECG finding that will come up in the patient will be that the P wave in the patient will become smaller and will become absent. Now, what is that medical condition where the P wave will become absent? Then one of the conditions is atrial fibrillation. Another cause can be where the SA node stops firing. SA node बूढ़ा हो गया है and it has stopped firing. That is called as sick sinus syndrome. And third condition is obviously the topic of interest, that is hyperkalemia. So I am also making you revise some of the ECG findings so that this becomes long-term memory for you guys. SSS basically means sick sinus syndrome, as somebody had commented. And now comes the fact which somebody had commented already, but for others, I would like to ask you, the statement of mine is And I would like everybody to comment on this on basis of my statement. Potassium makes the conduction through the Purkinje fiber slower. I did not say the word slow. I said slower. पहले से speed कम हो जाती है. So अगर पहले से speed कम हो जाएगी, if the speed will be slower, what will happen to the QRS complex in ECG of hyperkalemia? The question is, the speed is becoming slower. So what will happen to QRS complex? Will it be narrow or will it be wide? Yes, it will be wide. Yeah, the PR prolongation will also be there, but my question was specifically for the QRS. So yes, I think everybody answered very rightly. Broad QRS complex would be occurring, or wide QRS complex would be occurring, which is of a duration more than 100 milliseconds. As I explained to you, normal is in a range of 80 to 100 milliseconds. Now, I want you to stop noting for a second and look at me. I know I'm looking a little smaller in the screen, but look at me. First wave of the ECG is Chotu. So imagine it has disappeared. QRS is becoming broad, and there is a tall tented T wave. I'll say that again. First wave of the ECG, Gaya. QRS is broad, and this broad QRS will merge with the tall tented T wave. The broad QRS will merge with the tall tented T wave, and it will result in development of a pattern that does not even look like that of ECG. I mean, we never draw ECG like this now. I mean, this is not how ECG looks like. This is few minutes away from death. This is few minutes away from death, and this is called as sine wave pattern. It is mainly for this word that I had to go into this long repetitive monologue of saying tall tented T wave. आप कह रहे हो क्या सर, ये तो पता है हमारे को, but I wanted to introduce the word sine wave pattern. This is usually seen when potassium will be hitting usually a value of 8 millicoulombs, which is, I said, something very close to death. When the value of potassium is hitting something like 7, then the P wave of the patient is beginning to disappear. So if you notice hyperkalemia patient is having absence of P wave, that means it's only 1 millicoulombs away from death, possible death. Obviously, we will not let that death happen. That's obviously sure. We will intervene. But then suppose patients come late, or if the patient is not monitored properly, then potassium will slow down the heart and will result in development of a cardiac arrest in the patient of the diastolic variety. So unfortunately, we may even lose our patient. Now, since I have explained to you at the moment what are the ECG findings of hyperkalemia, I will also use the opportunity to quickly revise regarding what is the first step to be given in this patient. The first step is, as you all know, this time I will not be asking you because we have already discussed this, so I'll be a little quick. We will be giving 10 ml of 10% calcium gluconate bolus to the patient. We can give it mixed with normal saline 250 ml over 10 minutes. The rationale for this is antagonism. Like, what will calcium do? Calcium will cause a contraction and potassium will cause a relaxation. So it will not lower the value of potassium. All it is doing is, it is doing a antagonism. Antagonism काट है. हिंदी में जैसे बोलते हैं ना कि भाई एक बदमाश आया तो उसकी जगह दूसरा बदमाश भेज दे, राइट? दोनों आपस में लड़ रहे हैं, जैसे होम मिनिस्टर साहब कर रहे हैं अभी आजकल इलेक्शंस में. सो एंटागनिज्म. सो डायस्टोलिक कार्डियक अरेस्ट, 10% calcium gluconate. Now, what you will do in the patient is use a separate IV line and start a drip. You will be starting the drip of regular insulin. This regular insulin is usually like 10 units, which is mixed with 25 to 50% dextrose. One of the reasons why you would like to give 25 to 50% dextrose is because you're giving insulin to a normoglycemic person, so sugar can fall. So I don't want that to happen. So it is 10 units with 25 to 50% dextrose, and it is given in the form of an infusion. Now the advantage of infusion is that at least वो पहुंचेगा तो सही. 10 units is so small that if you just give IV, it will remain in the cannula only. But when you give it in the form of infusion, it's going to go back there. So infusion is what is going to happen in the patient. That is gradual lowering that will be happening. Potassium in the body of the patient will begin to get lowered. How much will be the fall? How much will be the fall? Because this is one of the most effective drugs to lower the value of potassium. It is 0.5 to 1 millicoulombs per hour fall of potassium that we want to achieve. It is a 0.1 to 1 millicoulomb fall per hour that I want to achieve by giving regular insulin infusion to the patient. And what does insulin do? It will cause a potassium influx. As you all know, it will result in development of redistribution of potassium. The next thing that we will do is start the patient on nebulization with salbutamol. Though I have explained this earlier and even yesterday I spoke about it, but I would like to say this once again, because the query of a lot of students is, sir, salbutamol is used in severe acute asthma and you are using in hyperkalemia. Then what salbutamol also does is it causes potassium influx, it causes redistribution of potassium and sends potassium inside the cells. That is why patients after salbutamol nebulization complain of weakness. You know, a lot of patients, if you have an asthmatic in the family, they will say, if I take nebulization, I feel so weak. That is because if potassium will go inside the cells, the muscles will become like relatively weak. Here, obviously, it is advantage because potassium in the blood is relatively elevated. And then you will be giving a injection of IV Lasix, that is furosemide. Normally, we give furosemide to those patients who are having heart failure. But today, my objective is caliuria. Caliuria means that I want is basically a loss. It is a caliuria that I basically want in the patient. That is how I will be able to stabilize the potassium values in the patient. That is caliuria basically needs to be done. So these are like the initial steps that we are using, 1, 2, 3, 4 that I've highlighted. And then even yesterday I had said that if the person is having refractory hyperkalemia, refractory means that आप सब कुछ दवाई यूज कर लिए, then we will go for dialysis. In fact, before that, one more point I would like to also mention is of the potassium binding resins. Like potassium binding resins also you have answered me. Potassium binders are like patyroma, sodium zirconate and all those molecules that we had discussed earlier. So we will be able to stabilize the potassium values. But in spite of all the hard work that we have done, if he specifically says the word refractory hyperkalemia, then obviously my job would be to initiate a hemodialysis in a patient. So this is a standard approach that I basically wanted to say. The add-on, why I went into this once again is because I want to say that sometimes in multiple choice questions, instead of writing the word calcium gluconate, he may write the word calcium chloride. So that is okay. Calcium chloride can also be used. Calcium chloride can also be used. So it can be calcium gluconate or it can be calcium chloride. But sometimes he will say which of the following is not to be used in the patient, and not to be used is calcium gluconate, because calcium gluconate what is not to be given to the patient is calcium carbonate. Calcium carbonate is a oral drug, it cannot be given intravenously. So what is not given in the patient is calcium carbonate. What can be used is, instead of calcium gluconate, calcium chloride. That is one aspect that I basically wanted to say. Another aspect which I want to say is the question will say that which of the following drugs is not routinely used. The question will say which of the following drugs is not routinely used for management of hyperkalemia. So because like not routinely used in hyperkalemia, that is why this is not in the list. It is not in this list. So can I have comments here? Not routinely used in hyperkalemia. Can I have comments here for this, please? The most effective drug is obviously insulin. The most effective drug part, I don't think so anybody would be having, because most effective to lower elevated potassium is obviously like, insulin drug that everybody knows. So I did not ask you. Yes, guys. Yes, boys and girls. Which drug would be used? Yes, that is soda bicarbonate. So soda bicarbonate is the one which will be we don't use it routinely for management of hyperkalemia. So these are like those very classical questions that would be asked in a question from the perspective of potassium management. And once I have taken care of this, now I will move up in the slide and I will be comparing the ECG findings of hypokalemia. And all you need to do is use English. Use English. What I mean by using English is that now potassium is going down. So the T wave in this patient will also be going down. So when you check out this ECG, you will notice that instead of like arrow going up, now the arrow is going down. So when you are anytime, this is the reflex I want you to have, that anytime in your life, if you read the word hypokalemia, your thought process should be कि ECG में क्या हो रहा होगा, T wave inversion हो रहा होगा. And then ST का खुद का दिमाग तो है नहीं, वो तो बड़ा पैसिव सा है. ST is the isoelectric segment. उसका खुद का दिमाग है नहीं, इज अ पैसिव पर्सन. सो वो जो भी कोई दूसरा करता है नकलची बंदर टाइप्स, राइट. तो वो क्या कहता है, अच्छा तू जा रहा, अच्छा मैं भी कर लेता हूँ. So with the T wave inversion, what will happen in the patient is development of ST depression. So the findings in this patient, if somebody will practice hyperkalemia properly, then it is not possible that the doctor will not be able to get the question of hypokalemia correct, because you just need to use English and work out the information. Like for this particular case, now what will happen is there would be increase in the vertical height of the P. Initially, the P wave in hyperkalemia was become chotu and was disappearing. Here the P wave will increase in height. This increase in the height of the P wave, is called as pseudo P pulmonale. Though I had mentioned the statement in one of my earlier ECG discussions also, but it will make more sense now. Why the word pseudo? Because there is no chamber enlargement of the heart. Na? Normally, the P pulmonale is seen in patients of pulmonary artery hypertension, where the right ventricle and the right atria will become bigger. Oh, it is not a chamber enlargement. It is electrolyte imbalance. That is why the name is pseudo P pulmonale. Very, very classical. And then will come an ECG finding, which is called as prominent U wave. The moment you read this word prominent U wave, this is again like important from the perspective कि normal आदमी की ECG में भी, please comment in the chat box, क्या normal आदमी की ECG में U wave होती है? You just have to comment yes or no, Y or N. Can you tell me, do you have U wave present in ECG of a normal person? Yes, we do have U wave present in ECG of normal person. It is a yes, guys. It's a vocal yes. Here it is a prominent U wave present. So I will also write down separately what is the reason for the U wave. I can use a finer font to highlight that. If he just says to you, generally speaking, what is the cause of the U wave in the ECG? What is the cause of U wave in the ECG? Your answer will be it occurs due to delayed repolarization. It occurs due to delayed repolarization of the papillary muscles. This is a physiology question of your exam. What is the cause of the U wave? It is delayed repolarization of the papillary muscles. I'll just bring that to focus now. U waves are due to delayed repolarization of the papillary muscles, but prominent U wave is not normal. Prominent U wave is abnormal. Then what we will do in the question is, he will write the phrase specifically prolonged QU interval. He will want that you think that it is some spelling mistake, because traditionally we read about QT, but here it is QU interval. So prolonged QU interval is gonna be a very specific finding that would be seen. Prolonged QU interval is a technical term to be remembered for patients of hypokalemia. And after that, like usually, because the values will usually be going very, very low. Normal is 3.5 to 5.5. Suppose it is less than 1.5, the person can die also. So here if he says what is the reason for death, then the answer will be not answered as cardiac arrest. The cause of death in this case would be answered by you as diaphragmatic paralysis, that is type 2 respiratory failure. It is possible that in the MCQ, instead of writing the word diaphragm failure, because if diaphragm will fail, then CO2 will rise now. CO2 will rise now. So he may deliberately write the word type 2 respiratory failure. And for hypokalemia, he will not be very vocal about the treatment part, because it is simple that you need to give KCL to the patient. But obviously KCL should not be given directly in the central line, otherwise it will stop the heart. So you will add KCL to the bottle of IV fluid. Like if you remember the discussion of diabetic ketoacidosis, I had said that to the bottle of normal saline, I'll be adding 40 millicoulomb per liter of KCL to be administered to the patient. It is never ever given in the central line of the patient. The reason being that it can cause a cardiac arrest. Then a question will say which is a common ECG finding of both of them. तो आपने ऐसा एरो बना के लिखना है. A common ECG finding in both of them is PR interval prolongation. The rationale I can give for this is that whether potassium is more or less, you need normal potassium for AV nodal conduction. AV node कहता है भाई मुझे नॉर्मल वैल्यूज चाहिए, कम हो या ज्यादा हो मुझे नहीं पता, अगर मुझे नॉर्मल एनवायरनमेंट नहीं मिला मैं काम नहीं करूँ. Like we all operate in thermoneutral environment, like 24 degrees Celsius, we operate best when AC is running. Suppose it is very hot, हम कहते हैं हम काम नहीं करेंगे. Suppose it is very cold, again, we are shivering and we don't want to work. So similar kind of example here, like a normal human being will want a comfortable environment to work. AV node कहता है भाई I will work in comfortable environment. You make it too hot, I will not work. You make it too cold, I will not work. Similar spirit here, hyper and hypo, abnormal environment. So the AV node says, sir, I am not gonna work. So this is a common ECG finding that is seen. The question will say which of the following is not gonna help in discriminate between hyper and hypokalemia. Then it is a PR interval prolongation. This is a common finding present in both of them. The rationale is the AV node needs normal environment for functioning. And just in case the normal environment for functioning is not there, the AV node says कि भाई मैं काम नहीं करने वाला. So what this is a one pager, guys, super important topic that they always asked in the exam. Hyper and hypokalemia I've summarized in a single pager, and every word that I have said can be a question that can be asked to you. So you need to have a visual memory of every terminology, every word which is currently on the screen, and the sequence of hyperkalemia is anyway asked. Now we will talk about a disorder by the name of RTA, that is called as renal tubular acidosis. In renal tubular acidosis, there are different varieties which are responsible, but usually they will first ask you causes. There are a large number of causes, but what you are supposed to remember for the exam is only two. Cause number one to be remembered is the disorder in which you get dry eyes and dry mouth. You are aware of this autoimmune disorder that we will study in the evening. Dry eyes and dry mouth is Sjogren syndrome. And Sjogren syndrome is one of the causes where the fibrosis due to Sjogren can involve the distal convoluted tubule as well. And second cause for this is amphotericin B. So these are two causes which are worth remembering. And now let us look at what is the problem in this patient. Like he will say, what is the problem? So in the distal tubule of the kidney, there are two cells. One is called as alpha intercalated cell. Second is called as beta intercalated cells. हमारे जो डिस्टल ट्यूब्यूल होता है उसमें दो सेल्स होते हैं, उनका नाम अल्फा और बीटा इंटरकेलेटेड सेल्स होता है. इंटरकैलेटेड, ये इंटरकैलेटेड सेल्स क्या करते हैं? जो अल्फा होता है, इट कॉजेस हाइड्रोजन एक्सक्रीशन. they basically help in maintenance of the pH. So alpha cells क्या करते हैं in the distal tubule? वो hydrogen excretion करते हैं. And what do the beta cells do? They basically cause a bicarbonate excretion. So there is always a balance. There is always a balance. Like body will be losing equal hydrogen, equal bicarbonate to maintain the pH in the range of 7.35 to 4.5. But suppose somebody has acidosis, then alpha cells will become activated. And suppose somebody has metabolic alkalosis, then beta cells will become elevated. I will give an example. Like in the pancreas, we have alpha cells producing glucagon and beta cells producing insulin. अब आपने दो गुलाब जामुन खाए, if you eat lot of sugar, then beta cells will be activated. And suppose like your sugar is dropping, you've not eaten anything for since last lunch you had, and after that you've not eaten anything, and you studied the whole day, then you did some workout in the gym also. So your sugar at the moment is dropping, then alpha cells will come. So just like you are understanding that pancreas के alpha beta cells balance maintain करते हैं, sugar maintain करते हैं, वैसे ही distal tubule के alpha और beta cells जो होते हैं वो pH maintain करते हैं. और अगर ये खराब हो जाए due to the reasons which I have mentioned as Sjogren syndrome, then the most important thing will be that there is a enzyme which is operating here, H potassium ATPase. Because H potassium ATPase will not be functioning. I mean, I was saying no, hydrogen excretion. So let me just draw a line diagram like this. Suppose you can draw this also. You can imagine this is a alpha intercalated cell which is responsible for hydrogen excretion. So this is how it will operate in the tubule. In the tubule, it will be excreting hydrogen. In the lumen of the tubule, it is excreting hydrogen. But if you are losing one positive charge, body का काम होता है maintenance of electron neutrality. One of the functions of the human body is maintenance of electron neutrality. If you will lose one positive charge, the body will gain one positive charge in the form of potassium. के भी लेन देन चल रहा है, आदान प्रदान जिसको बोलते हैं, barter system जिसको बोलते हैं. You lose positive charge, there's one more positive charge coming back in the body. So this is normal function. Now due to Sjogren, if this is damaged, then you can see hydrogen will not be excreted. So one of the classical terminologies that will always be written will be this phrase, inability to acidify the urine. If you just look at the line diagram here, hydrogen is not getting lost now. If hydrogen will not be lost, निकलेगा ही नहीं बॉडी से, तो बॉडी में बढ़ता रहेगा. हाइड्रोजन जब बढ़ जाता है तो मेटाबॉलिक एसिडोसिस हो जाता है. सो इनएबिलिटी टू एसिडिफाई द यूरिन, which means that the urine pH of this patient will go towards alkaline. The urine pH of this patient will usually be 5.5, and in a NEET PG MCQ the urine pH was 9.4. मैं 9.4 लिख के इरेज कर दूंगा. I just want to say that for all of you who are like sitting for NEET PG, he gave a question case scenario where the urine pH was 9.4 and patient was having metabolic acid. ABG report was given, pH less, PCO2 less, bicarb less. Urine pH was 9.4, and then he also mentioned something related to Sjogren, but a lot of students said something देखा ही नहीं. हमने देखा metabolic acidosis है and the urine pH was going towards alkaline. I marked it as RTA1. I said yeah, I mean absolutely fine. So I will remove that value of 9.4 because if you will read the question subsequently, like, you know, notes, maybe that 9.4 will cause a discrimination or error in your mind. But like, I just wanted to share that old MCQ of your exam. And the message is any patient having ABG report saying pH, PCO2 bicarbonate less and urine pH going towards alkaline, because acidification नहीं हो सकती तो towards alkaline चला जाएगा. If acidification, so just a value has to be remembered that these patients would be having urinary pH more than 5.5. So that's first aspect that I would like you to remember in this patient. Second, what they have also found is that these patients tend to have low urinary citrate. He says in the same part of the kidney, there are transporters जो कि citrate release करते हैं. Citrate basically binds to calcium. Now what will happen is this, he has not mentioned the name of those transporters. He's just mentioned that the kidney's distal tubule is also responsible for excretion of citrate. Citrate क्या करेगा? Calcium को bind कर देगा. So it is a inbuilt system to protect kidney stones. You know, citrate and calcium आपस में bind करके, तो calcium is like the badmash. Remember in multiple myeloma yesterday, calcium was damaging the kidney. There was a renal failure that was happening. Calcium is the badmash that we are little worried about. So we send in a security system called as citrate. Now if citrate will not be there, then the badmash is free. and that Badmash, that bad guy will now damage the kidney. And how will it damage the kidney? It will result in development of nephrocalcinosis. So that is one another aspect that I want to remember, that kidney stones in these patients would be affected. In fact, I can explain it one more way. I want you to just not note down, just listen to me. Another theory says that there is one more transporter present here. Like, if I just draw this diagram once again, like he says, there's one more transporter present here in that I've shown in blue. And this transporter is called as CASR. It is called as calcium sensitive receptor. The function of this calcium sensitive receptor is, it is again responsible for reabsorption of calcium. Now I will put a cross here to say that ये भी काम नहीं करेगा due to Sjogren syndrome damaging, तो calcium का loss होगा ना. तो मैंने दो तरीके से समझाया. Why is calcium more in the urine of these patients? Why is calcium more in the ultrafiltrate? One is the CASR, calcium sensitive receptor. CASR क्या होता है? Calcium sensitive receptor. काम नहीं कर रहा, उसका काम है calcium खींचना. Now it will not be able to work, so more calcium in the urine. That is one theory. Second theory says low urinary citrate. Ultimately, आपको theories याद नहीं करनी. That is just an explanation, because that is how you can remember things. कि भाई why is the calcium more? I would have said simply stones हो जाते हैं. आप बोलते सर ऐसे कैसे हो गया? So I tried to give you two reasons for that. One, the textbook says CASR का खराबी. Second, he says CASR, फिर से बोल रहा हूँ, calcium sensitive receptor is malfunctioning. So calcium is not getting absorbed. As a result of it, more calcium will be going in. And second is low urinary citrate. But he will not ask you theory in exam. It is not like why. He is asking you what is going to happen in the patient. It will be a metabolic acidosis patient with alkaline urine. Metabolic alkalosis patient with alkaline urine with recurrent hospitalizations due to kidney stones. That will be the history that would be given in this patient. And an additional point which I would also like to say for these patients is that you can also see potassium will not be absorbed. Potassium will also not be absorbed. If potassium is not absorbed, potassium is also lost. The question will also say that the person is having muscle cramps, he's having weakness, he's having caliuria. So I want you to remember कि जितने भी RTAs होते हैं, by default याद रखना, all renal tubular acidosis will always be having hypokalemia. The only aspect is one will be having hyperkalemia, that I will teach you after a few minutes from now. At the moment, the data to be remembered is all varieties of renal tubular acidosis. All varieties of renal tubular acidosis will be responsible for causing development of hypokalemia, except one that will be discussed subsequently. The point to be understood is that alpha intercalated cells are the main poor fellows which got affected. Let's do a recap. याद क्या करना है? याद पहले तो दो कॉज करने याद हो गए होंगे, आई थिंक, Sjogren syndrome, and second cause is liposomal amphotericin B. Now, what will happen? Alpha intercalated cells damage, because of which inability to acidify the urine, and because urine में hydrogen जाएगा नहीं, तो it will be alkaline urine. That is, urine pH will be more than 5.5 in these patients. Usually in the exam it was 9.4. Then is CASR will malfunction, calcium sensitive receptor. So more calcium in the urine, nephrocalcinosis, and patient will be having muscle cramps also. These are three features of renal tubular acidosis that you need to remember. And now I will move on to renal tubular acidosis type 2, जो कि इससे भी ज़्यादा simple है, इससे भी ज़्यादा simple है. Renal tubular acidosis type 2, where is the problem present? The damage is not present in the distal part of the kidney. Like here, the defect is in the alpha intercalated cells. It is the distal converted tubule that is getting affected, distal part of the kidney getting affected. But now it is the damage in the proximal tubule of the kidney. It is PCT, proximal tubule of the kidney, that is getting involved. तो ऐसे कुछ आप cells बना लेना. Like let me say these are the normal cells in the proximal tubule and they are responsible for various functions. What are the various functions? One of the basic functions would be they'll be responsible for like absorption of amino acids. They are responsible for absorption of phosphate. They will help you in absorption of bicarbonate. Like good things are getting absorbed. Like the kidney will always be trying to maintain a balance. So proximal tubule helps in reabsorption of large number of substances. And now a villain in the form of copper is coming. The villain in the form of copper is coming. So I'm just symbolically showing copper, the bad guy is coming. This is copper ions traveling through the proximal tubule. You all know what is the disease of copper toxicity? Wilson disease. So usually the question will revolve around a person who's having like liver damage and basal ganglia damage. Like the question will give you clinical information also. So it will be a damage to the basal ganglia. And in this patient of basal ganglia, the copper which is more, you can imagine this, ये हरे वाला जो copper ions है, these copper ions are destroying this particular part of the kidney. If the copper ions will be destroying this particular part of the kidney, the manifestations that will be written in this patient will be very, very characteristic. what will be written in the question that will immediately tell you that this is renal tubular acidosis type 2. You will start reading words like metabolic acidosis, to obviously dega hi. ABG like pH, PCO2 and bicarbonate will be less. But he will say patient on examination on urine was having amino aciduria. There was presence of phosphaturia. And obviously, like the main reason why the person is having metabolic acidosis is bicarbonature. Bicarbonate is being lost in the urine of the patient. ये phrase आप अपनी पूरी life में और कहीं पे भी नहीं पढ़ेंगे. You will read it only for renal tubular acidosis type 2 bicarbonature. Though it is very clear, please comment in the chat box. I would everybody to say that if you lose alkali from the body, what will you develop? Metabolic alkalosis or metabolic acidosis? Can you quickly comment on the chat box, please? I know you know the answer, but still, just for reinforcement, just for manifesting the disease, you are losing alkali. Chemistry, no MBBS here. You are losing alkali, man. There is no MBBS here. You lose alkali from the body, you get a metabolic acidosis in the patient. So this is renal tubular acidosis type 2. And an additional point which I want to say is that in these patients, there would also be inability to absorb the salt. Salt is also absorbed from the proximal tubule. Now, if you have read physiology, the physiology book will say 65% of salt absorption occurs in the proximal tubule. 65% of the salt is lost from 65% of the salt is absorbed from the proximal tubule. That is what happens in you and me. In this person, salt की absorption नहीं होगी. If you will be having salt loss from the body, तो compensation में aldosterone की मात्रा बढ़ जाएगी. If you are losing salt, इतना तो मानते हो, if you lose salt from the body, like आपको गर्मी में पसीना आ रहा है, अगर आपके शरीर से सॉल्ट निकलेगा तो बॉडी क्या करेगी? कॉम्पेंसेशन के लिए एल्डोस्टेरोन बढ़ा देगी. यहाँ पे आई एम नॉट सेइंग पसीना, आई एम नॉट सेइंग स्वेटिंग, आई एम सेइंग द गाय इज लूजिंग सॉल्ट फ्रॉम द किडनी. सो आई कैन से द वर्ड सॉल्ट वेस्टिंग आल्सो, बट इंस्टेड ऑफ सॉल्ट वेस्टिंग आई एम जस्ट सेइंग पेशेंट इज हैविंग हाई यूरिनरी सोडियम. Reason I'll say again. Let me explain again. Suppose you are having lot of sweating, so you will lose salt in the sweat and you will be dehydrated and there will be more aldosterone in the body. Same spirit, in this guy it is not sweat. It is in the urine that the salt is getting absorbed. The salt is getting lost because copper is destroying these cells. Now, copper is destroying these cells, so the absorption of salt will not happen. If you lose salt from the body, what happens to aldosterone? Hyperaldosteronism occurs, and because of this hyperaldosteronism, I have explained the mechanism of action of aldosterone multiple times to you. It causes salt and water retention for compensation. That compensation can never override the pathology. Compensation will minimize the deficit. It will not balance the deficit that is occurring in the body, and at the same time it will also cause caliuria, because aldosterone क्या करता है, वो caliuria करता है ना, it causes loss of potassium in the urine of the patient. So the reason यहाँ पे potassium की कमी होती है is not directly because there is potassium loss from the tubules. You know, I have went into this is to say, एक तो मैं बोलता भी याद कर लो, potassium hypokalemia seen in all types of RTA. But now I wanted to give an explanation that caliuria is not a manifestation or direct problem of the tubule. It is a secondary manifestation. It's a secondary manifestation of hyperaldosteronism. The rationale for this is salt loss. And obviously textbook में वो classical से लिखता है increased distal sodium delivery. So that could be written in MCQ also. मैं तो simplify करा ना कि यार शरीर से salt निकल गया तो क्या होगा? Aldosterone बढ़ जाएगा तो caliuria होगा. But like in the MCQ you might say increased distal sodium delivery. This is manifestations of type 2 renal tubular acidosis, where the specific words to be remembered are amino aciduria, phosphaturia, bicarbonature. Salt wasting word को लिखना थोड़ा सा अवॉइड करता है, जो उससे तो ना बंदा अंदाजा लगा लेता है कि अरे यार ये तो प्रॉक्सिमल ट्यूब्यूल की खराबी होगी. अगर वो सीधा बोल देना सॉल्ट वेस्टिंग, एवरीबडी इज लाइक ऑन टू इट, अरे यार ये तो आरटीए का क्वेश्चन है, बिकॉज सॉल्ट वेस्टिंग दो ही बार पढ़ रहे हैं, एडिसन डिजीज. And in this particular condition that we're discussing, you know, salt wasting, traditionally we are reading at like Addison disease is like with hypotension and all those things, right? What we have discussed, but I'll write it separately also. But I hope everybody remembers salt wasting is a feature of salt wasting, salt craving is a feature of Addison disease. And second time we are reading salt wasting for this particular patient also. So the manifestations are very characteristic. The main word minimum, अगर आप बोलते हो कि सर एक वर्ड बता दो क्या याद करना है, the main word to be remembered for this particular condition would be that you will say that I'm dealing with a patient of bicarbonature. That's the word I wanted to remember, bicarbonature. And now we reach to RTA4. Renal tubular acidosis type 4 is coming up on the agenda. The problem in RTA4 in the patient is that high sugar, diabetes. What is the most common cause for it? You need to remember it is diabetic nephropathy. Most common cause for RTA4 is diabetic nephropathy. The high sugar will damage the juxtaglomerular apparatus. Now, what is the function of the juxtaglomerular apparatus? It is supposed to produce a chemical by the name of renin, and renin production will be less in the patient. Second, there will also be tubulointerstitial fibrosis that will damage the principal cells. Now, I'm not talking about alpha intercalated cells. I'm saying principal cells, which are the area where the aldosterone will be acting. Yes, there is no RTA3, thankfully. I mean, though some books will mention about that RTA3 also, but then the point is renin will decrease. And the second problem is the cells which are getting damaged in this condition, नाम लिख लेना principal cells. What is the function of principal cells in the collecting duct of the kidney? The function of this principal cells in the ये junction पे होते हैं, collecting duct and distal tubule के junction पे principal cells are present. This is the site of action of aldosterone. This is site of action of aldosterone, and in this condition these principal cells are damaged, so therefore you have a aldosterone resistance in the patient. Aldosterone will not be able to work. Now let me draw the diagram here and we can practice this straightforward. This is epithelial sodium channel. It is located in a cell called as principal cell. It is responsible for salt and water ka reabsorption, and it is responsible for potassium and hydrogen ka excretion. And now I'm saying there is a resistance. I'm putting a cross to say कि काम ही नहीं कर रहा है, because the diabetes induced damage, because renin is also less, and at the same time renin कम होने से क्या होगा, aldosterone will become less. You know why did I say is renin is less means that there is aldosterone being less, and secondly there is a aldosterone resistance also. So the combination of the two, दो चीजें मैंने बोली, एक तो aldosterone की कमी है और दूसरी aldosterone resistance है. Due to combination of the two, this channel will not work, and I hope everybody will now agree to the fact that if this channel will not work, hydrogen निकलेगा नहीं. There would be impaired hydrogen excretion. That will be written in the MCQ as inability to acidify the urine. He will deliberately write the same statement which is present in RTA1 also. RTA1 may be same issue hota hai, inability to acidify the urine. Here also it is the same thing, but obviously the reasons are different. Here ENaC is not able to function properly. I would like everybody to comment in the chat box. Please help me. I need your help. What will happen to potassium in the body? Hydrogen नहीं निकलेगा तो potassium भी नहीं निकलेगा ना. Can you please comment in the chat box quickly what is going to happen to the potassium in RTA4, because that is one of the common questions that will be asked to you. Reason being that in RTA1 there is a hypokalemia, RTA2 there is a hypokalemia, but in RTA4 there will be a hyperkalemia in the patient. Yes guys, you don't need to be lazy. Comment in the chat box, write the word whether hypo or hyperkalemia will be occurring. Yes, it is increase in the values of potassium. So a large number of questions that come on this topic will simply focus on this much fact only, that what happens to potassium in this patient. Why? Because this is different from the others, and there is a hyperkalemia manifestation occurring. The reason for this is aldosterone resistance with inability to acidify the urine, but there will be no nephrocalcinosis present in this patient. Great. Now I would like you to note down a statement, then we will do a summary. All causes of RTA have NAGMA. I'll explain to you what is NAGMA also, but at the moment, right, by default, all causes of RTA by default will be having normal unengap metabolic acidosis. So I've given one pager for you to basically study renal tubular acidosis. Please note down the word, then I will do a summary. We will do that on the miscellaneous slides, the additional notes page. All causes of RTA result in NAGMA, that is normal unengap metabolic acidosis. And now let us go for summary. Let us look at how any doctor, I want you to move pages. I want you to come down to page number, I want you to come down to page number 154 and do this activity with me. That is, we will write down the types of renal tubular acidosis as 1 to 4. तो ऐसा table बना लो guys फटाफट से. Just make a quick table on page number 154, 153 के बाद में 154 पे. Just make a quick table with respect to what are you supposed to remember for renal tubular acidosis, the three varieties, and there are three agendas which are to be remembered. First, he will ask you what is the causes. So the cause to be remembered here is Sjogren syndrome, and the second is liposomal amphotericin B. For the second one, you need to remember where there was high copper, that is Wilson. And then I would like to mention regarding expiry date tetracycline. I did not say it earlier, but I want to introduce now that कोई भी एंटीबायोटिक अगर एक्सपायर हो जाता है तो अगर आपने मान लो सिप्रोफ्लॉक्सासिन एक्सपायरी डेट का खाया, सपोज द एक्सपायरी डेट इज टुडे 30th April, एक्सपायरी डेट इज देयर एंड यू आर ईटिंग एन एंटीबायोटिक, व्हाट विल हैपन? Only thing is efficacy of antibiotic will become less. Like suppose you are having requirement of ciprofloxacin, ofloxacin for any GI illness, then what will happen if you would take it on the expiry date? Efficacy of antibiotic will become less by 50%. That is all. But it will not kill the person. It will not damage your kidney. But tetracycline, if it is expired, must always be discarded. All that will happen if you eat any expiry date antibiotic like Ciplox, Norflox, whatever. Only thing that will happen is कि भाई आपका efficacy कम हो जाता है. That's it. So I mean we should avoid taking medicine near the expiry date. But tetracycline is a drug which causes damage to the proximal tubule. So expiry date tetracycline must always be discarded. Must always be discarded. And another term which I want to introduce here is called as Fanconi's syndrome. Not the word Fanconi's anemia, but Fanconi's syndrome. If you ever read this word Fanconi syndrome, it means it is a disease of renal tubular acidosis type 2. The cause for RTA4 to be noticed is diabetic nephropathy. So I've added 2 points to the causes at the moment for RTA2, and the remaining causes remain the same. Now let's write down the cause, manifestations. यहाँ पे distal tubule में damage, यहाँ पे proximal tubule में damage है, और यहाँ पे जो डैमेज है वो कलेक्टिंग डक्ट एंड डिस्टल ट्यूब्यूल के जंक्शन पे है. सिंगल बेस्ट आंसर इज कलेक्टिंग डक्ट इज गेटिंग अफेक्टेड, स्पेशली द सेल्स विच आर इन्वॉल्व हियर. तो बोले हुए अब फिजियोलॉजी, क्योंकि आजकल तो इंटीग्रेटेड क्वेश्चंस आते हैं ना, तो ही विल आस्क यू व्हाट सेल्स आर अफेक्टेड. योर आंसर इज प्रिंसिपल सेल्स. हियर इट इज अल्फा इंटरकेलेटेड सेल्स, and in the middle if he says what, then it is the lining of the proximal tubule. लिखा ही हुआ PCT damage, so lining of the proximal convoluted tubule will be affected in the patient. So one, what I've highlighted before you is the causes, and second what I've highlighted is what is the area getting affected. Alpha intercalated cell, principal cell, and in PCT there's no special name of the cell. Lining of the PCT gets affected. Now comes the manifestations. So let's write down the manifestations. In RTA1, he will say inability to acidify the urine. Inability to acidify the urine, the reason for this would be primarily based on the fact that hydrogen potassium ATPase, जो हाइड्रोजन पोटेशियम ATPase होता है वो हमारी दो जगह पे होता है. एक तो स्टमक में होता है ना, जो PPIs होते हैं वो कैसे काम करते हैं, they block that. So one is that inability to acidify the urine is a feature that we usually see with respect to like any person who is inability to acidify the urine is a specific feature that is present in RTA1 and is also present in RTA4, though the reasons were slightly different. I will enumerate the reasons also. Like the reasons with respect to RTA4 was that it was a, इसको separate color में लिखना, यहाँ पे it is the epithelial sodium channel malfunction which is contributing to inability to acidify the urine. I drew the diagram before you of the epithelial sodium channel. So epithelial sodium channel is not working, that is inability to acidify the urine. But when it comes to RTA1, when it comes to renal tubular acidosis type 1, then the specific reason why it is happening is that the alpha intercalated cells, ये मैंने बताया था ना, ये हाइड्रोजन को एक्सक्रीट करते हैं. Both of them, the reasons are different. It is different reasons for both of them, but the common manifestation is there. Inability to acidify urine means more protons in the body. But now is the difference. What is the difference? You will note with a separate color. The separate color will be nephrocalcinosis, kidney ka involvement with stones will be given only for this condition with hypokalemia. Whereas here there will be no mention of nephrocalcinosis and hyperkalemia as a manifestation will be there. And for the middle तो मुझे लगता है कि आपको अगर ना भी नोट करो ना फिर भी याद हो जाता है. Amino aciduria, caliuria, phosphaturia are the various manifestations that can be seen in these patients. The urea word, I don't think so I needed to write the middle part, but still, like, towards the middle, what I did was I decided to just explain this aspect to you. So at this particular junction, at this particular point of time, this is the information to be remembered for RTA 1, 2, and 4. That would be the manifestations that I've currently explained to you. I hope it is clear, guys. Please let me know if it is clear. I need to, like, I think I've tried to be as simple as possible explaining this. But in case there is any issues, बाकी देखो verbatim ये सारे वाले issues तो आपको याद करने ही है, right? I hope it's clear, guys. Let me know. The topic covered is RTA 1, 2, and 4 that I've explained. And okay, fine, great. Now I will mention mnemonic for HAGMA and NAGMA. Anion gap कैसे calculate करते हैं? I have done that activity earlier. I will do it again also. But this is an activity which is again to be done by you, and this is again a very super important topic which is asked in the exam, HAGMA and NAGMA. HAGMA के लिए जो causes है ना वो same है जो कि मैंने आपको metabolic acidosis के लिए बताए थे, that is CULT. हैगमा इज हाई एनन गैप मेटाबॉलिक एसिडोसिस, नैगमा इज नॉर्मल एनन गैप मेटाबॉलिक एसिडोसिस। सिर्फ हमारी जिंदगी मुश्किल बनाने के लिए उन्होंने ये टर्म्स क्रिएट किए हुए हैं। तो आप परेशान मत होना कि सर हैगमा नैगमा सर ये क्या हो गया। तो हैगमा नैगमा is simple terms to make our life a little difficult. Yeah, salt loss can be seen even in patients of RTA4 also. But yeah, the compensatory part would not happen now because salt loss is occurring from the distal tubule. Salt loss in RTA1 was occurring from the proximal tubule. RTA, like Vipin, you had a point. Salt loss in RTA2 will be seen from the proximal tubule, but salt loss in RTA4 would be distal. Coming back to the agenda, it is ketoacidosis, as already explained to you. For uremia, he will write terms like acute tubular necrosis, acute glomerulonephritis, acute kidney injury, chronic kidney disease. वो उसकी सिरदर्दी है कि वो कोई सा भी टर्म लिखे, वो पैथो का टर्म डाल दे, acute glomerulonephritis, acute kidney injury, chronic kidney disease. Alphabet L is for lactic acidosis and T is for toxins. I've explained the toxins to you already, like methanol poisoning, etc. So I don't need to do this again. And now is the mnemonic for NAGMA, which is called as Dr. Fuse. This is a question that is like all except variety. This is a question which is all except variety. So let us practice the NAGMA component. Alphabet D will stand for diarrhea. Though in USMLE books there are various mnemonics like mud piles, etc., but they're not relevant actually. Half the time whatever they are saying is actually not relevant. So I decided to not go by telling you some USMLE book data. I decided to create one myself, that is diarrhea. And now comes the most important statement. So hear me out. किडनी की जितनी भी बीमारियां होती हैं, किडनी के जितने भी डिजीजेस होते हैं, all cause high anion gap metabolic acidosis except renal tubular acidosis. What is the statement to be remembered? All kidney parenchymal disorders and vascular disorders. All kidney parenchymal disorders and vascular disorders. Like even if we raise renal artery stenosis, you would still say high anion gap metabolic acidosis. He says diabetic nephropathy, you will say high anion gap metabolic acidosis in a patient. But if there is RTA 1, 2 or 4 written in the question, the words are specific. Diabetic nephropathy लिखा है तो high anion gap बोलना. But if diabetic nephropathy is causing damage to the collecting duct of the patient, it is causing damage to the principal cells, then the word we use is RTA4, for which we get normal anion gap metabolic acidosis. Then F is easier, fistula. Fistula can be due to Crohn's or can be due to surgery, and use mnemonic is for ureterosigmoidostomy. ये एक diversion procedure होता है. Ureterosigmoidostomy is a diversion procedure which is done after carcinoma bladder stage 4. Like what we do is we will divert the urine into the colon. In ureterosigmoidostomy, you will divert urine into the colon. Ureterosigmoidostomy is divert urine into the colon of the patient. So the message at this moment is ureterosigmoidostomy is the word to be remembered. Divert urine into the colon. उससे क्या होगा? Diarrhea हो जाएगा भाई. If you divert urine into the colon, urine will cause damage to the bacteria of the GI tract and it will cause diarrhea. And the diarrhea, it's diarrhea को ही घुमा फिरा के क्या लिख रहा है? Ureterosigmoidostomy. यू कैन अंडरस्टैंड ना द साइकी ऑफ द एग्जामिनर क्या कह रहा है कि भाई मैं तुम्हारे को ना ओवरवेल्म कर दूंगा, आपके सेंसेस को ओवरवेल्म कर दूंगा. द फैंसी वर्ड इज ureterosigmoidostomy. What are you doing? Carcinoma stage 4, the guy cannot urinate. You divert the urine into the colon. It kills the bacteria. Therefore, the imbalance of bacteria in the gut causes development of diarrhea. And in diarrhea, you lose electrolytes. You lose water, you get circulatory failure. So metabolic acidosis will occur in a patient, but the number of positive charges and number of negative charges lost will be identical. What is anion gap? What is anion gap? It is the difference of the positive and the negative charges in the body. The positive charges are sodium. Even in the MCQ, deliberately mention potassium. Don't incorporate potassium in the MCQ. I mean, don't include it in the calculation. It will be given in the theory, but don't include it. Don't include it in the calculation. Anion gap is positive and negative charges. What I want to say at the moment is, in diarrhea, positive charges will also become less and negative charges will also become less. If mathematically sodium decreases by 5 points and bicarbonate decreases by 5 points. Now no MBBS, only like chemistry, only like maths. If sodium decreases by 5 points and bicarbonate decreases by 5 points, what will happen to anion gap? it will remain the same. It is perfectly normal. So the point is diarrhea may it is equal amount of positive and negative charges lost. Similarly in RTA, kidney maintains electron neutrality. So positive and negative charges net loss is found to be equal, and that is why we get normal anion gap in this patient. And even if you don't remember this explanation to the end, koi farak nahi padta. What matters is the mnemonic cult versus Dr. Fuse, because it is a all except MCQ. And for those of you who did not listen maybe yesterday properly or maybe missed it, on the ABG section, I will just do this activity again. Sodium is 140. Chloride approximately is 106, bicarbonate is about 24. So if we will do this calculation, the anion gap of a normal person like you and me will be about 10 milliequivalents. How much is the normal anion gap of a person? Your answer is 6 to 12 milliequivalents per liter. It is a mathematical term that is used to differentiate the two types of acidosis that may be seen, where equal positive negative charges are lost and an imbalance is present. So Hagma and Nagma are just terminology which you need to remember as cult versus Dr. Fuse. And now we are sorted for the topic of renal tubular acidosis from the perspective. And that was what I said. All varieties of renal tubular acidosis by default will always result in development of normal anion gap metabolic acidosis. But potassium issues are different. That potassium will be more in RTA4 in the patient. So that is like some of the technical inputs that I've said. थोड़ा chemistry वाला component ज़्यादा हो गया. You know, a lot of doctors hate chemistry and physics and stuff like that. तो कहते क्या सर इसको भी पढ़ना पड़ेगा. तो हाँ, एक बारी सिर्फ जिंदगी में एक बारी ध्यान से आपने इसको सुनना. Just once. And then the mnemonics would basically help you analyze this information better. Now we are in a good position to study regarding another electrolyte imbalance, that is going to be sodium hyponatremia. I would like to put a question to you guys to see whether you have read this topic previously or not. Suppose अभी किसी ने Airtel marathon run किया, like you know in March, April, most of the time the Airtel marathon is run, and the guy is having sweating and he's having hyponatremia, and the guy collapses at the finish line and having seizures. So for this person, you are giving 3% saline. This guy, he ran a half marathon or full marathon in a hot Delhi environment, and at the finish line he collapsed. Then he had a seizure in the ambulance. Sodium was 120, so you gave 3% saline. Would you like to give fast correction of sodium, or would you like to give a slow correction of sodium? I would like you to comment in the chat box. Marathon runner collapsed at the finish line. Sodium is 120. Guy had convulsions. Labs are done. Will you comment in the chat box, please? Fast correction of sodium, slow correction of sodium, and then we will subsequently work out the data. Yes, guys. Waiting for inputs here for the question that I raised. Person has collapsed at the finish line. Sodium is being given. You can give normal saline also. If you don't in the emergency have 3% saline, you give normal saline. Would you like to give a fast correction, or would you like to give a slow correction? I'm just waiting for the inputs here. Okay. Yes, guys, keep commenting. I just want to see, you know, if I see I have a lot around about 700 people at the moment, the comments are hardly maybe, you know, 40, 50 comments, maybe increasing to 60 at the moment. So yes, guys, fast correction, slow correction. Okay. No. I don't want explanations. I just want answer. Fast correction, slow correction. Okay, fine. Now it is my turn. Let me do the talking now. Yes. Ayush was immediately picking it up. Some people have picked it up very beautifully. So let me explain. If hyponatremia is of acute onset, and sodium is 120 to 120 whatever, you will be giving fast correction to the patient. If hyponatremia is of acute onset, like this guy is a healthy person, he just participated in a hot run in the month of May, or I mean, like marathon races are held in the spring season most of the time. It's very hot in Delhi, very hot in most of the cities of India. 100 hottest cities of the world are in India. No, person will be requiring a fast correction. Guys, if it is a chronic onset hyponatremia, how will you write the word chronic onset? He will not write chronic onset. He will give you a situation. What will be the situation given to you? He will say it is a known case of lung cancer. He is having gradual onset confusion, disorientation. Or he will give you a situation of a pneumonia patient. He's admitted in the hospital for previous 2-3 days. He's receiving IV antibiotics. Or he may say the patient is having carcinoid tumor and the person is being admitted for diagnostic workup. if it is chronic conditions given in a question, lung cancer, legionella. I mean, legionella is obviously, I understand, is an acute illness, but guy has been admitted for 2-3 days, no? Like in marathon running, it is over few hours. By acute onset, I mean development over few hours. And in chronic, I mean development over days. By chronic, I mean development over days. So first you have to be clear that if it is chronic onset hyponatremia, we give a slow correction. This is the commonest mistake that students make, that they by default think that hyponatremia में कभी भी fast correction नहीं देना होता है. We give fast correction in those patients who are having few hours का onset. Like अगर भाई दौरे पड़ गए तो यार fast correction देके ठीक कर लेंगे उसको. But if it is a chronic onset, then there is a problem. That is what the notes begin with. आपको नोट से बायस नहीं होना है, उसमें देखो लिखा भी है fast onset of chronic hyponatremia. Fast correction of chronic hyponatremia leads to stroke-like manifestations called as osmotic demyelination syndrome. Instead of writing the word osmotic demyelination, he may also use an old term that is called as central pontine myelinosis. But at this moment, I want to be very, very clear about the fact that it is chronic that will be causing this manifestation. Now, what will be those stroke-like manifestations? They will themselves appear after 2 to 6 days after the correction. It is not immediately after the correction. He will give you a case कि निमोनिया का केस था, इसका सोडियम कम था, हमने इसको करेक्शन दिया, करेक्शन देके पेशेंट ठीक हो गया. But then after 48 hours, there is a worsening. It's not immediate. It is like after 48 hours, there is a worsening in the patient, that is osmotic demyelination syndrome. And what will be the manifestation? Stroke-like features. Initially, though, he will waste your time, confusion, dysarthria, dysphagia, which is present. But then, because of demyelination of the corticospinal pathway, there would be quadriparesis because the demyelination is affecting the corticospinal pathway. So he will start giving you upper motor neuron manifestations like spasticity, like quadriparesis. If the brainstem gets involved, the guy will get cranial nerve palsy in a patient, like pseudobulbar palsy. Pseudobulbar palsy means demyelination of the corticobulbar fibers that supply 8, 9, 10th and the 12th nerves. The manifestations will be can't speak. Whenever brainstem is involved, no, can't speak, can't eat, can't drink. Those are the kind of features that are seen with respect to pseudobulbar palsy. Pseudobulbar palsy is upper motor neuron lesion of the cranial nerves. Suppose if cranial nerve directly is involved, we say lower motor. That is bulbar palsy. Why the word pseudo is given is because features will be identical. But it is not a damage to the cranial nerve, it is damage to the corticobulbar fibers that innervate the cranial nerves of a patient. That is, can't speak, can't eat and can't drink would be occurring. Locked in syndrome again. Locked in syndrome matlab the person will be totally paralyzed. Usko sunai de raha hai. He can hear what is going on, but he is not able to move the body. So locked in syndrome, jakad diya usko patient ko, conscious but cannot move the limbs because of the quadriparesis manifestation. But even if you don't remember these manifestations, chalega, what you have to understand is that in chronic onset hyponatremia, when you do a fast correction, there is always going to be a problem of osmotic demyelination syndrome. To assist you, he might give a MRI finding. The MRI में वो त्रिशूल बन जाएगा यहाँ पे. That त्रिशूल of demyelination is what is going to be called as the trident sign that might be seen on a MRI in the patient. Then we might be able to identify MRI finding of osmotic demyelination syndrome called as trident sign because brain stem will start getting involved in the patient. And now let us just quickly look at the same kind of presentation. Now I think you guys will be able to understand this better. This male collapses at the finish line of the full marathon that was conducted in a hot weather, and there was GTCS in the emergency department, and then he's given the vitals. He also mentions that the guy was not consuming electrolytes while running. He was consuming only plain water during the race. If you will only drink water and not that Gatorade or electrolyte rich solutions, obviously the sodium in the body will begin to fall because of excessive sweating. Because when you run, you tend to lose. You see, running in the air conditioned gym and running on the road are totally different things. In the treadmill, there is also cushion, so your knees don't get impacted. When you run on the road, then it causes a lot of stress on the knees. Most Indians, when they do run, because see, Gora people run on the roads in the morning. Roads are clean. You guys, a lot of you have been abroad, you would see Gora people, they put on that iPhone on the arm and they start running in the morning, and all of them do by default, boys and girls, and nobody disturbs anybody. Right? Because the body is used to running on hard road, concrete road for young age. बचपन से दौड़ते हैं तो घुटनों में भी दर्द नहीं होती. आप और मैं तो सर ट्रेडमिल पे तो कर लेंगे. सड़क पे दौड़ते हैं ना 2 दिन में सर चला नहीं जाता. Our knees hurt now because you take a lot of strain on the asphalt road. Your knees take a lot of impact. So most Indians fall sick. They're not able to. Running on a treadmill is different ball game, man. Running on the road is totally different. So most of we Indians are, we are not used to that from a young age. हम क्या भाई गंदगी है बाहर कौन दौड़ेगा, तो ट्रेडमिल पे दौड़ लेते हैं. But like the guy was now running on the road, so his knees are giving away, and at the same time, there's excessive sweating that is happening. The sodium in this patient is very, very low. He's mentioning serum and urine osmolality also, that I'll explain to you subsequently. But I hope I've been able to explain to you that this case presentation is of acute onset electrolyte imbalance. This presentation is of acute onset hyponatremic seizures. Considering that the person is having CNS manifestation, it is not a necessity that all questions will mention seizures. Some may say confusion and disorientation. If CNS manifestations are given, I want to highlight that don't always say कि सर सीजर नहीं लिखा था इसलिए मैंने मेंशन नहीं किया. भाई CNS features, अगर वो बोलता है कि बंदा ड्राउजी हो गया, if he says the fact person is not recognizing family member, we will not wait for the seizure to happen. It might be just around the 10 minutes down the line, it will seizure also. So don't wait for the seizures to occur, and you will be giving 3% hypertonic saline to the patient in the form of bolus over 10 minutes. This is the correct answer which everybody has answered. But suppose I change my situation and it was chronic onset, then yeah, my answer would have been option number C, that is slow correction at 6 millicuries per 24 hours. If I change this question to chronic onset lung cancer patient, confusion, disorientation, option C will be answered. So I hope now the concept is clear that for acute onset hyponatremia, we do not do a slow correction. We go for like fast correction, bolus shot to be given. Thore rokne hai yaar, otherwise the guy will die. I mean, even if he's not having seizures, he will develop seizures. So we want to prevent this from happening. So this is sorted at the moment. Beta, I have explained. Yes, C is for chronic. C is for chronic. Option number C, slow correction. Here the answer is option number B. And now, once I've explained this situation to you, let's move forward and give you another case. A chronic smoker presents with fatigue, headache, and progressive increasing confusion for 10 days. So because smoker is also given and 10 days is also given. So one, anytime you read about a smoker, either it's going to be a COPD case or it's going to be a lung malignancy. I don't know what is the lung malignancy. That will depend on the report that will come subsequently on the doing a bronchoscopy or a CT guided biopsy. But it is malignancy. Why? Because person has lost weight also. You know, cachexia, weight loss are again manifestations. There is decreased breath sounds over the right upper field, upper lung field. So there is some lung mass also. No, he's trying, because he's saying decreased breath sounds over the right. That means where is the possible malignancy present? The lung malignancy is present in the right upper lobe. It is causing lung consolidation or it is causing a collapse of the lung. You know, lung mass will block the bronchus. The lung mass can block the bronchus, so there can be collapse of the lung segments. That is why this auscultatory finding is given. And then the patient is disoriented, sodium is low. Serum and urine osmolality also, the concept I will explain to you. But at this moment, considering that there is a lung mass given and he says, what will you do? I hope I've been able to explain to you that this particular patient is a case of SIADH, syndrome of inappropriate ADH secretion due to a lung mass. Probably the lung mass is oat cell cancer. He has not given me oat cell cancer word in the question, obviously, because if he will give it, I will give an answer early. So he tried to bluff his way across. Your answer of everybody is correct. I hope you are appreciating. Don't wait for oat cell cancer word to be written. Don't wait for that slide of crushed nuclei that I was telling you. जो crushed nuclei वाली slide दिखाई थी ना, वो don't wait for that. It could be carcinoid. Carcinoid could be having that salt and pepper chromatin. So he might give a biopsy report there also. But now because there is a SIADH, SIADH will be causing a development of extra, like ADH will always cause excess of water in the body. And this excess water in the body will cause drop in the sodium values in the patient. And this is chronic hyponatremia. This is chronic hyponatremia. Now your answers are 100% right, that I will be doing a correction, but this correction will be relatively slow, not exceeding. He has asked this mathematical value also. Kitna correction karenge? Suppose the sodium is 118. So I will increase from 118 to 6 points. That would be 124 in 24 hours. Then from here, I will increase, like mathematics of mine is bad. 8 is like 6 plus 6 is not 124. 118 plus 8 is I think 126 right now. This is bad. So I'll not get into that. We have to increase slowly. Imagine करो 120 था, right? Just for reference, like 120 था, तो 120 से 126, 126, 126 से 132, 138. Over 72 hours, I will discharge. After 72 hours, I'll discharge the patient. So the answer to this particular question is option number B. And well done, everybody. I think I've been able to successfully communicate how to manage hyponatremia of acute and chronic onset. And this is a question of INISET that came, and let's practice this. He said lung cancer patient is admitted for workup of seizures. Sodium is low, potassium is also low, maybe because he's eating less. Calcium is a little high. Lung cancer, no, 9 to 11. No, calcium is normal, not elevated, thankfully. Calcium is normal. Weight is 60. He says, how much is the correction given to this patient over the next 24 hours? Over the next 24 hours. So this is a case of chronic hyponatremia. In a chronic hyponatremia case, I will be giving a slow correction, and the rise I will be achieving is something like 6 milliequivalents, right? So 6 milliequivalents would be the increment that is required in this patient. So I will first write down the formula. Desired value minus actual value. My mathematics is bad, so I will do +5 mathematics in front of you. Desired value minus actual value into total body water, into total body water. Now, what is the actual value in this question? Actual value is 120, and what is the desired? Something like 126, It's a range only 6 to 8, so I'm taking lower side. Desired is how much? 120. This is the value given in the question. Just add 6 point to that. Whatever be the value. Suppose it was 110, then you will want 116. If it is 130, just add 6 points to that. That's what I'm trying to say. Now comes the concept of total body water. So TBW is another concept that I now want to add to your knowledge base. How do you calculate total body water? Total body water is weight of the person multiplied by a multiplication factor. This multiplication factor is gender sensitive. Like you will be multiplying by 0.6 for a male patient, and you will be multiplying by 0.5 for a female patient. Way to remember is that women have more fat in the body and men have more water in the body. The way to remember is women have more fat in the body and men will be having men will be having more water in the body. So total body water is weight into 0.6. So now I will do calculation 6 into the weight is also given 60. And the multiplication factor in this patient will be like, I think it's a male patient, female, and any gender given. 55-year-old patient is worked. Okay, so it's not given the gender. So I have the flexibility of selecting 0.5 here. Like there's no gender. Maths will become easy. Maths will become easy for me. So 60 into 0.5 will be, 60 into 0.5 will be, thoda sa difference aega male or female ka. So because gender is not given, so I'm taking the flexibility of multiplying by 0.5. Obviously, if he says male patient, you will multiply by 0.6 in this patient. So in this particular patient, the value will be 30 into 6. That would be 180. This is the correction that I want to do in this patient. The answer is 180 milliequivalents to be given over the next 24 hours in this patient. The answer is option number A. Now I will be changing the question. Now I will be changing this question, and I will not say over the 24 hours. I will delete the word over the next 24 hours. I want you to use a marker, preferably in your notebook, and show that this 24-hour word is not given. And mention the fact that 24-hour word is not given. The question can change into what is the total correction to be given to the patient. The point is, if I change this to how much is the total correction, that means over 3 days, how much will be giving. So one, I can multiply this into 3. Or the other way is, I will do the calculation once again. I'm using a black color now. This is version 1 of the MCQ. At this moment, what we are discussing is a mathematical question. This is version 1, one-step calculation. How is version 2 of the MCQ? What is version 2 of the MCQ? In version 2, we are discussing whatever is the total correction to be given to the patient. Not in 24 hours, but obviously the patient will be staying with me till the values become normal. So what is the desired value I want to obtain? Our desired value I want to obtain is like 140. The reason why I'm saying desired of 140 is because, see, normal is 135 to 145. So average will be 140. When it is 140, I will say, okay, now shift to general ward. I want a desired value of 140. Then I will say, okay, shift to general ward. I will not send the patient home, right? ICU, then ward, then home. Nobody goes directly home from ICU. Na? Any patient in ICU, we first shift to the ward, monitor for 1 day, then back. So the value desired is 126 se बढ़ा के 140 करना है. Actual value is 120 in the patient, and then is 60 into 0.5. I'm still taking the liberty of incorporating that gender of 0.5 because it makes calculation easy for me. So now it will be 20 into 30, and that will be a value of 600, as most guys have commented very, very rightly. Then the answer will change over to option number C. I hope I've been able to communicate to you that how do you go for correction of sodium in the patient? It is one-step multiplication. It is one-step multiplication. इफ यू आर एन एफएमजी स्टूडेंट, आपने एक बार सुनना है इसको एंड देन जस्ट लेट इट गो. If you're an FMG student, just listen to this once and let it go. If you're a NEET PG student, you need to imbibe this even more. You need to imbibe this even more, that depending on whether it is 24 hours or whether it is the total correction. The PYQ that actually came in the paper, some people said, sir, it was total correction. Some people said, sir, total over 24 hours likha. Right? Differences of opinion. One word will change. Inset is like this only, na. That is why you see in the recall session, some platforms say A, some say D, and then fun is being made out. कि भाई प्लेटफॉर्म कोई नहीं पता, तो भाई पेपर तो यार हमने नहीं दिया ना, बस पेपर तो आप लोग देते हो. आपके इनपुट पे पता चलेगा ना. अगर मेरे पास पेशेंट आया तो पेशेंट की प्रेजेंटेशन के बेसिस पे तो मैं आंसर दूंगा ना सर आपको. Right, so it becomes a joke on Instagram and everywhere else. Oh, this guy is saying, this guy is saying, this is all useless. No man, medical science is science. क्या होती है? Unpredictable. What is medical science? No rules. You and me are those people who are fighting disease which doesn't want to fight rule. We are trying to fight no rules guy with algorithm. That is what medical science is. No, disease does not follow any rules. यार cancer कोई rule follow थोड़ी ना करता. Cancer is like, anyway, I'm gonna spread, I'm gonna cause problem. And you and me have algorithms which are designed in this particular. Value of 90 we will target for 96. Yeah, use the lower side. Use the lower side, Priyesh. That's the only answer in this case. So I hope I've been able to explain to you this mathematical status at the moment. And now what I will do is I will talk about a disease by the name of SIADH, syndrome of inappropriate ADH secretion. And the causes of SIADH, the common ones that I want you to remember once again are, one is a malignancy. I'm writing that again and again, Oat cell cancer. Don't be surprised if it turns out to be carcinoid tumor. The slide will decide. It is the bronchoscopic biopsy of the patient that will be deciding this. Then is a bacteria by the name of Legionella pneumophila. But right next, I have not said this earlier. I'm saying it for first time. All CNS infections. By default, all CNS infections, whether I spoke about Nipah virus, whether I spoke about Neisseria meningitidis, whether I spoke regarding development of meningoencephalitis, all CNS infections by default. Meningitis, encephalitis, bacterial, viral, fungal, कोई सा भी etiology हो जाए, चाहे brain abscess हो जाए, all CNS infections will always result in development of SIADH in a patient. Even he might begin by saying HIV positive guy with cerebral toxoplasmosis, because it is a CNS lesion. You have to understand that examiner is trying to indirectly tell you कि मैं तुम्हें SIADH पूछ रहा हूँ. In any patient of SIADH, in any patient of SIADH, there will always be more water in the body. So more water in the body will always result in sodium values to be low. And the technical term for this is euvolemic hyponatremia. The technical term for this is euvolemic hyponatremia. Now, for the next part, I want you to think logically. I'll draw a diagram also to facilitate the learning here. The diagram is very simple. This is V2 receptor. This is V2 receptor, and all the water is going back in the body. All the water, like you can draw thick arrow like this to mentally visualize कि सारा पानी जो है वो antidiuretic hormone ने खींच लिया. All the water is going back in the body. Now tell me, if all the water will go back, what will happen to urine? Will it be a dilute urine or concentrated? You have to type in the chat box right now in next 2 seconds. What will happen to urine? Remember, all water coming back in the body. So what will happen to urine? Dilute urine or concentrated urine? No MBBS, simple like chemistry aspects here only. The water is coming back, right? Water is coming back. Exactly. Urine will be concentrated, and therefore, because it is concentrated in the MCQ, it will be written as urine osmolality is high. You can see the word high. Exactly. For those of you who did not get an opportunity to type here, I give you second shot at this. The second shot is water is coming back in the body. So what will happen to serum osmolality? Will it be a very concentrated serum, all the water coming in, or will it be a dilute serum? Water is coming back, no. Water will cause a dilution in the patient. So you can see here it is written low serum osmolality. One thing which will make your life a little easier is you can write like this: urine osmolality and plasma osmolality have an inverse relation. Urine osmolality and plasma osmolality always have an inverse relation. अगर आप दोनों में से एक को भी वर्कआउट कर लेते हो, अगर आप दोनों में से एक को भी वर्कआउट कर लेते हो तो एरो को उल्टा कर देना. फॉर एग्जाम्पल इन SiADH मोर वाटर, वाटर वाटर एवरीवेयर, सो यू विल से यूरिन इज dilute, sorry, serum is dilute. I'll say that again, water water everywhere in the body, so serum is dilute. तो आपको लॉजिक लगाने का जरूरत ही नहीं, जस्ट एरो उल्टा कर देना and you'll be able to figure out, because they will give you these permutation combinations, you know, low serum, low urine. I mean दोनों का ये लिखा होगा serum osmolality, urine osmolality, 4 permutation combinations, both low, both high, one low, one high, one high, one low. In 15 seconds you should be able to work it out, and I will make you practice this once again, though I will say in Hindi this time. एंटी डायूरेटिक हार्मोन पानी खींचेगा, तो पानी की मात्रा यदि बढ़ जाए तो सब जो होता है पतला हो जाता है ना, पानी ज्यादा होगा तो भाई पतला पतला हो जाएगा, पतला इज डाइल्यूट, राइट? सो दैट इज द सीरम ऑस्मोलैरिटी, द सीरम इज पतला, and then just use opposite arrow for the same, because in exam you have limited time at your disposal. So the hack of inverted relation of urine and plasma osmolality will always help you, that urine and plasma osmolality will go opposite. Usually in FMG exam, these are the 3 things they will ask you. Sodium is less, agreed. Plasma is dilute and the serum is dilute and the urine is concentrated. नीट बीजीएस ने कहा कि यार ठीक है यार, अभी तो है थोड़ा मेरिट वाला एग्जाम है, थोड़ा और परेशान करते हैं इनको. तो परेशान करके, परेशान क्या किया उसने, मतलब यू गाइज आर स्मार्ट गाइज, तो परेशान नहीं हो गए. द लॉजिक टू बी यूज्ड इज दैट SiADH इज अ कंडीशन वेयर मोर वाटर इन द बॉडी. आई होप एवरीबडी इज ऑन विद मी फॉर दिस. मोर वाटर इन द बॉडी, मोर वाटर विल कॉज स्ट्रेचिंग ऑफ द राइट एट्रियम. यदि शरीर में ज्यादा पानी होगा, इट विल कॉज स्ट्रेचिंग ऑफ द राइट एट्रिया ऑफ द पेशेंट, एंड बिकॉज ऑफ स्ट्रेचिंग ऑफ द राइट एट्रिया देयर इज अ केमिकल लिबरेटेड बाय द नेम ऑफ atrial natriuretic factor. And now if I say atrial natriuretic factor is more, there will be natriuresis, there will be natriuresis. Let me say and explain this once again, and then I will ask you, and I want you to obviously answer. Urine sodium will be low or high. I know it is on the slide, but still use logic. Don't focus on what is already printed. Focus on my words. More water in the body. शरीर में पानी का मात्रा बढ़ गया. It will stretch the right atria. Stretching of right atria will cause ANF release. ANF causes natriuresis. Please comment in the chat box natriuresis word. What will happen to urinary sodium in a patient? The urinary sodium of this patient will be, yes guys, low sodium or high sodium. Low sodium or high sodium. Waiting for your comments. Natriuresis, salt lost from the body. So there is going to be a high urinary sodium. That is because the values would usually be given in like, 20s, 40s, 50s or 60. Yes, guys, they will not give you value most of the time. They will themselves say low versus high. So the point to be understood is simple, that urinary sodium in the patient is elevated. I've gone into the rationale for it. If you are an FMG student, 3 points to be remembered. If you are a NEET PG aspirant, 4 points to be remembered. In competition, it goes a little thoda sa of the same topic. Disease is still the same, rationale is still the same. It is just that we tend to focus more on the first 3 points. He knows कि तुम्हारा ध्यान कहाँ पे है, sodium, urine, plasma osmolality. वो कहता है चल यार अगला बता दे, urinary sodium in the patient. And in these patients, it's a euvolemic hyponatremia, as I have currently explained already. So this is like the description for SiADH that I have told you. Now, irrespective of the aspect that I'm telling you, urinary sodium usually would be in the range of about 20. And if it is like going towards 10, like all the questions that I was discussing yesterday, pre-renal, and if it goes more than 20, then it goes in favor of SiADH in a patient. Okay, coming back to the question, now my counter question. In SiADH patient, शरीर में पानी ज्यादा है ना, what will you advise the patient? Liberal water intake, comment. Liberal water intake, water restriction. ज्यादा पानी पीने के लिए बोलोगे या कम पानी पीने के लिए बोलोगे? You will be telling the nurse कि इनको पानी नहीं देना है. SiADH is already having more water in the body. तो हम क्या बोलेंगे जी? Fluid restriction. Yes, it is fluid restriction that would be done. तो गर्मी में होठ सूखते हैं ना. In hot, even if the AC is running, your lips will dry. So can you tell me how? What? Just practical question. No, practical question to everybody. You said पानी नहीं देना. Lips are drying. क्या करेंगे? How will you make the patient comfortable? Yeah, restriction is fine. Perfectly right. Everybody. How would you make the patient comfortable? If lips are dry, yaar, you feel irritated, na? Yeah, cotton. Ice cubes ले लो. Best है पता है. Ice cubes ले लो. Patient को बोलियो देख पियो मत. Ice cube ले लो. उसको ice cubes, and you can roll it in cotton gauze, and you can ask him to gently suckle on that, because that cold will give that soothing. Ice cubes can be used in a patient. Yeah, wet the lips and the mouth, उससे impact नहीं आता. You use cotton and wet, it doesn't give impact. He'll try to swallow that. So you give him an ice cube, No, not wet wipes. उसमें तो chemical है भाई. Wet wipes would be having chemical. It is ice cubes in a cotton. Ice cubes in that वो पट्टी नहीं होता. That bandage I'm saying. So ice cubes in that bandage, and just ask him to suckle that, keep it in the mouth, rinse the mouth a bit, spit it, right? I don't want him to drink that. And lip balm तो खैर obviously यार ना lip. I mean lip balm, देखो girls are answering lip balm, मैं मानता हूँ यार lip balm से थोड़ी ना ठीक हो जाएगा भाई. तो you need to give like uh, yes, it is not a wet wipe that would be used. Okay, wet wipes are used for a different reason, right? Okay, fine. Fluid restriction would be done. That is a good answer in this patient. Next best treatment for this patient. Comment if I will not give options this time, how will you raise the sodium? Yes, wet wipes. Okay. Okay, guys, waiting. What is the next step in the medical management of this patient? Sparmolacton. Beta, heart failure का मरीज नहीं है ना. This is not sparmolacton that will be used. Anything else? Diuretics. Okay. Sir, you will ask the nurse to get B complex from the medical store, like your hospital in hospital supply. You will say, "Ma'am, B complex के capsule ले आओ." Then you will ask her to get salt from the namak from the kitchen of the hospital. You will say, "Ma'am, वो B complex का जो capsule होता है उसको खोल दो. Throw out the B complex and fill the capsule with salt." नमक से आप capsule को भर दो. And then we give salt capsules to the patient. How do you give these salt capsules? Is you will get salt from the kitchen of the hospital, and the B complex capsule, the shell will be preserved and the B complex will be thrown there. So the next step is salt capsules that should be given to this patient because salt is less in the patient. And yes, Natrize is the main medicine that we use. Exactly. That's the brand name, no? Natrize. That is. We will be using Vaptans for management of these patients of SIADH, syndrome of inappropriate ADH secretion. बेटा 3% saline is answer only if there is seizures. अगर यहाँ पे suppose if I say to you, if I say that patient has turned unconscious, if I say that the patient is unresponsive, and at the same time the relative said कि इनको दौरा भी आया था, if the patient is turned unconscious, unresponsive, there is presence of seizures, that is when you will do emergency correction with 3% saline. तो वो तो by default ही है ना यार. That we have already discussed that emergency management of the patient in such situation. What will you do in the patient? Then you will be managing the patient with 3% saline. Agreed. But like you will not continue 3% saline forever now. By after 3 days, even if you correct the person, the lung cancer is still producing ADH. That's why I said, na, 3 days in ICU, then sent to ward. And in the ward, what are you doing? Fluid restriction, salt capsules, and Natrize to be given to the patient oral. So ये patient आराम से 4-5 दिन hospital में रहेंगे. मतलब maybe 2 days in ICU and 2 days in the ward, or maybe 3 days in ICU and 1 day in the ward. But I have to stabilize and send the patient in these particular patients. So नहीं बेटा refractory क्यों होगा? We will using can we also use infusion pump? Yeah, all infusions are via infusion pump. यार हॉस्पिटल में सारी इतनी लाइंस infusion pump भी तो होती हैं सारी की सारी. हम ये नहीं बोल सकते कि फैसिलिटी नहीं थी. जज थोड़ी ना सुनता है कि फैसिलिटी नहीं थी. सरकारी हॉस्पिटल में तो आप कुछ भी बहाना बनाते हो, फैसिलिटी नहीं थी, लो रिसोर्सेज, ये वो. इट्स नॉट लाइक दैट. इफ पेशेंट डाई, सपोज दे गो टू कोर्ट ऑफ लॉ, अगर वो हॉस्पिटल में 1 रुपए का भी पर्ची दिया ना, 1 रुपए का भी पर्ची भी है, कंज्यूमर रिलेशन इज एस्टैब्लिश्ड. नो, द कंज्यूमर लॉज आर एप्लीकेबल. 1 रुपए का पर्ची बनता है, 5 रुपए 10 रुपए का पर्ची पड़ता है सरकारी हॉस्पिटल में. वी थिंक वी आर इंसुलेटेड. नो सर. If you are a resident handling the case, you must always, when you sign now, you say case discussed with senior consultant. So that tomorrow, if the court case, suppose I'm saying God forbid court case comes, then they will call the consultant. वरना तो हम क्या करते हैं, अपने सिग्नेचर डालते बड़े बड़े, मैंने इलाज किया आज हाइपोनेट्रीमिया का, है ना. कल को अगर कोर्ट केस हो गया, वो बोलेगा आ जाओ कोर्ट. Okay, treat the underlying cause. Obviously, we have to treat the underlying cause of the patient. Okay, guys, so this was SIADH, which I covered at the moment, and now we will just quickly look at two important electrolyte imbalances once again, hypo and hypernatremia. In hyponatremia and hypernatremia, in both of them, the cause of death in the patient will be seizures. Hyponatremia is considered to be dangerous. I'm saying dangerous value लिख रहा हूँ. It is said to be dangerous when the value is less than 125. And hypernatremia is said to be dangerous when the value is more than usually 158. Some books say something like 160 also. I'm okay with it, but it is 125 and 158. What is the possible cause of death? Then in both of them, there is a fluid shift across the brain. So the cause in these patients is The cause of death in both of these patients can be development of seizures. In dangerous hyponatremia, what is the intervention that we will do? We will be giving 3% saline correction to the patient. It is the saline correction that will be giving to the patient, depending upon obviously, like, whether it is acute or whether it is chronic. I have written both the words bolus and infusion. Bolus for the acute presentation and infusion for the chronic presentation. And now I would like to ask you for hypernatremia. Like today in your ward, just roundabout like this time when you are like planning to go for lunch, the nurse just showed you, okay, sir, I was entering a report in the hospital system. The sodium was 155. Patient is not having seizures at the moment. He's complaining of headache. He's a little drowsy. He's a little irritated since morning, and he has been screaming at the family members and he's using cuss words. So nurse said, "Sir, I was entering the sodium report and it is like elevated 158." You will notice that hypernatremia is one illness which usually does not occur in young people. Either it occurs in geriatric age group, like this electrolyte imbalance usually occurs in extreme age group. या तो आपको नीकू में, न्यूनेट्स में, या फिर एल्डरलीज में यू विल बी हैविंग लाइक हाइपरनेट्रीमिया डेवलपिंग. हाइपरनेट्रीमिया इज लाइक very like hyponatremia is common, hyper is not. Hyper is like seen in elderly patients, very elderly patients due to fluid deprivation. like ये elderly patient थे पार्किंसन डिजीज के और इनको फ्रैक्चर भी हो गया. इनका बेटा बेटी अभी ऑफिस गए हुए हैं तो पानी पीने को नहीं मिला तो सोडियम बढ़ता रहेगा. Elderly patient of Parkinson disease had a fracture of the femur when he fell down in the bathroom. Now he can't even walk and go to the refrigerator, and Parkinson disease anyway makes the activities difficult. So fluid deprivation will result in development of hypernatremia and seizures will occur. So in this particular patient, like how will you manage the patient? If the sodium of the patient is having CNS manifestations, then we will be giving to the patient 5% dextrose. Yes, हम पानी देंगे, हम 5% dextrose देंगे. Very good, very good. We will be giving 5% dextrose to the patient. You guys have answered beautifully and correctly. And one doctor has answered very correct statement. To make it look sophisticated, to make it look sophisticated in the MCQ, he will deliberately not give you 5% dextrose. He will give you n by 2 and 5% dextrose. That is just to make it look sophisticated. It is a hypotonic solution. It is hypo क्योंकि sodium is more, so you need to give hypotonic solution जिसमें पानी ज़्यादा होता है. So what are the solutions which are having lot of water? It is 5% dextrose slash n by 2 and 5% dextrose that would be given in the patient. Yeah, we can manage that here. 5% dextrose will not cause very high values. And सीजर में जान बचानी ज़्यादा जरूरी है ना. डायबिटीज को तो मैं मैनेज कर लूंगा स्लाइडिंग स्केल से. I can give insulin to the patient to stabilize the blood sugar. So I am not worried about the little bit of 5 gram sugar will not do any harm to the patient. The message is n by 2 in 5% dextrose. 250 ml of normal saline, 250 ml. आपकी your nurse is new to the job. It is her first day of posting. कह रही सर ये क्या लिख दिया? You wrote n by 2 and 5% dextrose. Your nursing staff is new to the job and she says कि सर ये क्या होता है? There is no fluid like this. हमने तो कभी पढ़ा ही नहीं, हमें पढ़ाया ही नहीं है कभी भी. उसको बोलोगे कि मैम वो जो आईवी फ्लूइड के कनेक्टर्स होते हैं ना उसमें आपने 2 बॉटल से नई बॉटल में 1 बॉटल तो पहले डिस्कार्ड कर देंगे पूरा. कोई सा भी बॉटल ले लो, आरएल को खाली कर दिया. You take 250 ml of normal saline and you take 250 ml of 5% dextrose, and with help of IV fluid connector you will now make a new fluid that is n by 2 in 5% dextrose in the patient. So yeah, I mean कई बार डॉक्टर्स को भी नहीं पता होता है, कह रहे अरे सर ये क्या लिख दिया n by 2 n by 3 ये क्या होती है मेरे पास. So it is like 250 ml, that is half of दोनों ले लिया तो it is 0.45 in the patient in 5% dextrose that would be used here. But yeah, 250 ml of NS, 250 ml of 5% dextrose, combine the two it becomes n by 2. Then comes the aspect of hypokalemia. Why will hypokalemia result in death of a patient? The reason for that would be diaphragmatic paralysis. The reason for that is diaphragmatic paralysis. And what will I do in the patient is I will give potassium chloride with IV fluids to the patient. When I will give KCl with IV fluids, the patient is bound to recover because I will be giving a correction slowly to the person. Yes, it is a slow correction that I will be giving to the patient. KCl, IV fluids would be given to the patient. जो KCl का एम्प्यूल होता है ना, बड़े वाला ग्लास का ऐसे बड़ा सा एम्प्यूल देखे होगे तो इट्स लाइक अ बिग एम्प्यूल. एड्रेनलिन का तो छोटू सा होता है. इफ यू लुक एट द एम्प्यूल of potassium chloride, it is a very big ampule that is present. One ampule, right? This one ampule is having approximately 10 ml of KCl. This is having 10 ml of KCl or 20 millicoulomb. 1 ml में 2 millicoulomb होता है. 10 ml is like 20 millicoulomb. Mathematics कर रहा हूँ. this is just for a knowledge sake that one ampule of 10 ml glass ampule will be having 10 ml fluid. 1 ml is having 2 millicoulomb, so 10 into 20 is 20 millicoulomb is the amount that is present here. 20 millicoulomb is the amount present in this. Now a basic rule that I just want to say is कि 20 millicoulomb अगर आप पेशेंट को देते हो तो 20 millicoulomb देने से आपने क्या दिया 20 millicoulomb KCl, तो पोटेशियम कितना बढ़ता है, तो पोटेशियम का जो राइज होता है ब्लड में, जो ब्लड में राइज होता है वो 0.25 millicoulomb होता है. The rise of potassium in the blood is 0.25 millicoulomb. अगर आपने 1 एम्प्यूल पेशेंट को दिया, ऑब्वियसली डायरेक्टली तो देते नहीं है, यू गिव इट एडेड टू द बॉटल ऑफ IV फ्लूइड. तो सपोज आपने इसको 500 ml या 1 लीटर रिंगर लैक्टेट में दिया, तो पोटेशियम कितना बढ़ेगा, ओनली 0.25 millicoulomb. लाइक सपोज पेशेंट की वैल्यू थी 2.5, तो इट विल बिकम 2.75. इफ आई गिव 2 एम्प्यूल्स टू द पेशेंट, इट विल बी 0.5 का राइज. If I give 4 ampoules to the patient, it will be 1 millicoulomb ka rise in the patient. I'll say this once again. When you give 20 millicoulomb KCl, it is potassium and chloride chemistry. So how much will rise in the blood potassium? Only 0.25 millicoulomb. Just to see that you got me or not, let me know quickly. Suppose potassium of somebody is 1.5. If you have to increase from 1.5 to 2.5, how many ampoules will be required? Especially if you are a NEET PG aspirant, good to do calculation with me right now. 1.5 से अगर 2.5 करना है तो कितने ampoules चाहिए होंगे? Yes guys, quick answers please. 4 ampoules will be required. सिंपल सी बात है, 4 ampoules. उनको देंगे कैसे, तो वो ऑब्वियसली IV फ्लूइड में ऐड करके ओवर 24 आवर्स देंगे. वी नेवर गिव करेक्शन ओवर couple of minutes, it is over hours in a patient. But I just wanted to explain to you that what is the rationale of potassium correction. I mean, what is the mathematics by basis of potassium correction, that is potassium को हमेशा अल्ट्रा स्लो देते. अगर आपकी नर्स ने ये एम्प्यूल तोड़ के सीधा IV लाइन में दे दिया, IV लाइन मतलब सीधा कैनुला में डाल दिया, मेडिको लीगल केस हो जाएगा. पेशेंट विल हैव कार्डियक अरेस्ट. You always have to tell the nurse to add it to the bottle of IV fluid. Even if you don't remember this data, आप बोलते हो सर नहीं याद हो रहा, कोई बात नहीं, बट इतना तो याद कर लेना कि नर्स को हमेशा बोल देना कि मैम KCl लिख रहा हूँ, इन्फ्यूजन में देना. Because lots of time, they might not read the order properly. New nurses hired in the hospital, ना emergency जब hiring होती है, तो the new nurses are hired and they lower the, उनका कोई एग्जाम भी दिया नहीं, उन्हें स्टैंडर्ड कम कर दिया, तो बिना एग्जाम के हायरिंग हो रही है. तो उसकी वजह से lots of time these mishaps can be happening. बेटा पॉट क्लोर जो होता है ना, that is given for oral correction for values between 3 to 3.5. Give me some time. I'll come to you, Dr. Humaira, but you have a good point there. Pot chlor is the oral solution. Coming back, hyperkalemia. Hyperkalemia kills a patient due to a cardiac arrest. Hyperkalemia kills a patient due to cardiac arrest. The type of cardiac arrest that will occur in the patient is diastolic cardiac arrest. And I don't need to write the treatment algorithm again, so I utilize that space here. For completion, I'm just writing that for this patient, I will be using calcium gluconate or calcium chloride. That aspect has already been deliberated upon earlier. So there is no point of getting into the hyperkalemia component again. Now, hypocalcemia. The values lethal here are less than 1.5. If the values lethal are usually more than 8. Let me write this again. More than 8 millicoulombs. If calcium in the body is less than 7, if calcium in the body is less than 7, then it is a cause of tetany. Why will tetany result in mortality of a patient? Then the reason for tetany was discussed in one of the earlier classes. It is laryngospasm. Even for management of this condition, it is a calcium gluconate that will be used for. It is calcium gluconate that will be used for management of this patient. Laryngospasm is the cause of death, and this has already been deliberated upon. If calcium in the body goes more than 13, then the reason why the person will die is because of, again, cardiac arrest. But this time, when he says, what is the type of cardiac arrest? The rationale to be remembered is calcium causes contraction. Calcium causes contraction. So in this particular patient, it will be a systolic cardiac arrest that would be occurring in a patient of hypercalcemia. Cardiac arrest would be systolic in nature. And as far as the treatment of hypercalcemia is concerned, that has again been discussed. I will divide into two parts. If he says, what is the first line management? Your answer will be normal saline with furosemide. Last 6, I have explained to you, loop diuretics, lose calcium. Loop diuretics, lose calcium. If he says, what is the best management of this condition? It is ibandronate. Ibandronate is the main management for this patient. but I would just like to put a like a red star mark here to say कि क्वेश्चन करते हुए देख लेना कि ऐसा तो नहीं है कि द क्वेश्चन इज ऑन स्टेरॉइड रिस्पॉन्सिव hypercalcemia. I have already in one of my classes explained to you that if person is having let me say sarcoidosis or vitamin D intoxication, then we give steroids to the patient. तो बस वो ध्यान दे लेना कि भाई कहीं ऐसा ना हो कि वो सीधा पूछ रहा है कि भाई मल्टीपल माइलोमा का मरीज है, कैल्शियम बढ़ रहा है, क्या करेंगे, तो या तो स्टेरॉइड्स देंगे या डायलिसिस कर लेंगे. Or hypermagnesemia, when magnesium will become high in the body, when hypermagnesemia, magnesium will become high in the body, the units in this particular case will usually be more than 10 milliequivalents. If magnesium is usually more than 10 milliequivalents, then it can cause a cardiac arrest and it can cause a neuromuscular paralysis in the patient also. And then this is again a medical emergency for which you guys will be telling me what will we be doing for management of this person. I will meanwhile be writing theory like today you are posted in the obstetrics ward. There is a lady who's having there is a lady who's having eclampsia. She has become unconscious because of this eclampsia aspect, and you are giving magnesium sulfate to the patient. Magnesium sulfate is being administered. The total dose of magnesium sulfate कितना देते हैं वो बोल देना फटाफट से. What is the total dose of magnesium sulfate that would be given to the patient? Yes, guys. What is the total dose of magnesium sulfate that is given to the patient? Yes. Yes. Total dose that is given to the patient will be 14 grams. The total dose that will be given to the patient is about 14 grams of magnesium sulfate would be given to the patient. जिसमें से जो 4 grams होता है वो हम IV दे देते हैं. This is 4 gram or 20%. 20% magnesium sulfate which is given intra. इसको ध्यान से सुन लेना. Lots of time in OBGY people tend to take it casually. It is 4 grams or 20% that is given intravenously, and then you give 5 grams of 50% magnesium sulfate intramuscularly in each buttock. So the total will become 10 grams. In the MCQ उसने 14 grams तो पुराना MCQ है, अब उसने क्या करा परसेंटेज पूछनी शुरू कर दी. उसने ये स्वैप मार दिया 20 और 50 को कि कौन से वाला परसेंटेज IV देते हैं और कौन से वाला IM देते हैं. तो 20% वाला जो सोल्यूशन है वो इसका स्वैप मारा था. 14 ग्राम्स वाला क्वेश्चन तो पुराना हो गया. नाउ व्हाट ही डिड वाज ही सेड कि आप जो दोगे उसमें कौन से वाला मतलब IV देना और कौन से वाला इंट्रामस्कुलर देना. सो 20% वाला IV दे रहे हैं और 50% वाला 5 ग्राम और 50% मैग्नीशियम सल्फेट intramuscular in each buttock of the patient. So total will be 10 and 4, that will be 14 grams given to the patient. Now by mistake the nurse has given 10 gram in each buttock because the name of the patient, two patients with same name were admitted. Lots of time like in private hospital, so we have that barcoding, no, and through barcoding we have a RFI reader through which we can see that if two patients are with the same name, then obviously there would be no mixing up of fluids and administration. But in government hospital we don't have too much of like these checks present. So unfortunately two patients with the same name were admitted in the labor room, and unfortunately like the same patient by two different nurses was given the same injection. So in these patients, yeah, you have to monitor the reflexes in the patient. Yeah, that's okay. I should write that also. Like what will you use for magnesium toxicity? So deep tendon reflexes, respiratory rate, and urine output. And obviously the most reliable sign for like toxicity of the patient is deep tendon reflexes becoming relatively lesser. Ultimately what will happen is neuromuscular paralysis will occur, so respiratory rate will go down and bladder will relax, so the urine output of the patient will become relatively lesser. This is like Pritchard regimen, and now he will say, what will you do for the patient? Yes, Priyesh has already answered that. I deliberately wasted your time by describing some. Obviously, this is important. 14 grams is important, values are important, but then I wasted your time talking about reflexes, respiratory rate. You already know that. And then वो कहानी सुना के बोलेगा कि भाई आप करोगे क्या? So your answer will be that I will be using for the management of this patient calcium gluconate. I will write in black color only because I've been using that color for calcium specifically. So especially when you are gonna focus on this word calcium gluconate being given in the patient intravenously, especially when you're gonna focus on the word calcium gluconate being given to the patient intravenously, then it is like these algorithms that are to be deployed. Calcium gluconate is answer to 3 MCQs. That is gonna be hyperkalemia, then is tetany, and then is gonna be hypermagnesemia and hypermagnesemia. Yes, guys. Moving ahead in our agenda. Moving ahead in the agenda, we will now talk about hypomagnesemia in the patient. Hypomagnesemia is known to cause arrhythmias. And this arrhythmia usually that can occur in a patient is torsades de pointes, or they could be tetany occurring in the patient also. Tetany-like features, not exactly tetany, but potassium जब magnesium जब कम हो जाता है, then tetany-like manifestations can occur in a patient. That is neuromuscular excitability can be present. So don't be surprised if he says the word carpopedal spasm in a MCQ of hypomagnesemia also. I said don't be surprised if he says the word carpopedal spasm in a question of hypomagnesemia, because calcium and magnesium both are important for maintaining neuromuscular excitability. If calcium will become less और magnesium की कमी होते है तो neuromuscular excitability बढ़ जाती है nerves की, तो वो carpopedal spasm जो मैंने describe किया था वो question में mentioned हो सकता है. And there could be arrhythmia developing in a patient which is torsades de pointes, which will look like ventricular tachycardia only. But when you will see the ECG, you will notice that this ECG will be different from VT because the height will keep on changing. Because when I was describing ventricular tachycardia to you, in VT, the height of all the parameters was same, but now the vertical height of the QRS complexes will change. This is again a NESET as well as an FMG exam question. This is what is called as torsades de pointes, the Latin term, or it might be also referred as polymorphic ventricular tachycardia. The point I'm trying to say is that the vertical height in the QRS complexes of this patient is changing. And what will you do for this patient is you obviously have to increase the magnesium. So you will be using in this patient magnesium sulfate. I mean, if the person is having this arrhythmia, then magnesium sulfate will be given to this patient intravenously. So I wanted to bring to your attention two situations where we give magnesium sulfate right now intravenously. One is Pritchard regimen of eclampsia, and second is the situation of torsades de pointes / polymorphic ventricular tachycardia that can be given in the question. Guys, this is again an intense slide where in a single slide I have covered all the electrolyte imbalances on a single slide. At this particular point of time, I have covered the electrolyte imbalances before you, and I would expect you to remember all of these words verbatim. Like whatever I've said, it's almost like 3/4 of a slide, I will say, not even a full slide, but like you can see, it's very dense slide where hyper, all kinds of electrolyte imbalances that I've described at various points of time have already been explained to you, right? So this was a description for electrolyte imbalances which I wanted to bring to your attention. Verbatim, guys, verbatim, all the manifestations are remembered. Magnesium sulfate came up yesterday for management of even severe acute asthma. Here the rationale was different though. Obviously, I wanted to relax the airways, but today I'm trying to stabilize the cardiac membrane in the patient, stabilize the cardiac membrane. This single slide is like a high-yield slide which is to be remembered for your exams. So electrolytes are important, guys. That's all I can say for this at this particular juncture. And yes, another point just quickly and we can move on. Do you have RBCs in urine of a normal person? Do you have RBCs in urine of a normal person? In urine of a normal person? Yes, guys, waiting for your answers. Do you have red blood cells in urine of a normal person? Oh, I'm getting a no here. Okay, sir, RBCs are present now. RBCs are present in urine of a normal person. Please come to page number 155 and just add this miscellaneous information. This is a normal question. This is a baseline data. I'll tell you the reason also. क्या नॉर्मल आदमी के यूरिन में आरबीसीज होते हैं? तो होते हैं ना, क्योंकि हमारी जो किडनी की कैपिलरीज होती हैं वो फेनेस्ट्रेटेड होती हैं. हमारी जो किडनी की कैपिलरीज होती हैं वो फेनेस्ट्रेटेड होती हैं, और वो जो फेनेस्ट्रेटेड कैपिलरीज होंगी उनके थ्रू आरबीसीज लीक करते रहते हैं. सो इफ यू विल टेक यूरिन स्पेसिमेन ऑफ अ नॉर्मल पर्सन, if you will be taking urine specimen of a normal person and then you will centrifuge it, in the centrifuge specimen you will be able to see red blood cells which are normally less than 3 RBCs per high power field in a centrifuge specimen. This is perfectly normal. Now I will introduce the word hematuria. मुझे एक्चुअली इस वर्ड का वन लाइनर एमसीक्यू कवर करना था, दैट व्हाट इज द डेफिनेशन ऑफ द वर्ड हेमाचूरिया. सो यू विल से द डेफिनेशन ऑफ वर्ड हेमाचूरिया इज मोर देन 5 RBCs. The definition of the word hematuria is more than 5 RBCs per high power field. Okay, it is more than 5 RBCs per high power field, and you will need 3 consecutive reports. Like for example, today, tomorrow, and day after, I will be checking the urine reports in the patient, and on 3 consecutive days, if 3 consecutive reports are showing that the patient's If three consecutive reports are showing that the patient's RBCs are more than 5, then it is a definition of hematuria. And another definition is more than 100. Another definition is more than 100 RBCs per high power field. So if any of the two definitions are given, more than 5 or more than 100 in a single report, it is definition of hematuria. Just this normal value, I wanted you to remember that what is the cutoff for hematuria? More than 5 or more than 100 respectively is the cause of hematuria in a patient. The question that came in the exam was like, the patient is having a painful hematuria. The moment you read about painful hematuria, the number one cause would be kidney stones in a person. And then he also mentioned urine microscopic examination finding. In the urine microscopic examination, obviously RBCs could be seen, but along with RBCs in the urine, there were some crystals also present of envelope shape. There were some crystals also of envelope shape. So the question said like, what is the possible etiology? So you can very well understand it is calcium oxalate stones that I'm talking about. Because any patient who's having painful hematuria, we will think in terms of our diagnosis as a doctor will be nephrocalcinosis. Our diagnosis in this particular case will be nephrocalcinosis, that is person is having kidney stones. And one of the commonest kidney stone is what I've just highlighted, envelope shaped stones, envelope shaped crystals could be present. Then they changed the question and they mentioned that the person is having crystals, but these crystals are coffin lid shaped. Though this is covered in pathology, but I just wanted to give you a quick heads up with respect to the coffin lid shaped crystals present. And another time they mentioned hexagonal crystals. Hexagonal crystals are again related to like an amino acid which is present. So the answer in all of them will obviously change. Let me just write down the data. As far as the envelope shaped crystals are concerned, you know that this is one of the commonest kidney stones. Your answer in this particular question would be that I suspect that the patient is having calcium oxalate stones, that is calcium oxalate crystals are envelope shaped, and that's why the problem is occurring. The second possibility where I have said the word coffin lid appearance. Where I have said the word coffin lid appearance. Coffin lid appearance is a feature of triple phosphate stones. So here my answer will change. This stone, lots of time they give this X-ray, and in the X-ray it will look like ginger. जैसे अदरक होता है ना, अदरक के जैसे protuberances होते हैं. So in the renal pelvis of the patient, you will be able to see a stone with lot of protuberances. They will give you X-ray KUB to assist you in this question. The X-ray KUB will also be given. This X-ray KUB will help you understand that what you are dealing with is what is also called as true white stone. This is also called as Staghorn calculus. This is also called as triple phosphate stone. The highlight of this triple phosphate stone is that it is composed of three things, that is magnesium, ammonium and phosphate. The reason why these stones will develop is due to a bacteria which is producing urease. This urease positive organism will cause alkaline pH of the urine. Each of the words that I've written are asked in different years, but I'm writing it together. Like one question said, alkaline pH of the urine is causing stones. What is the possible cause? Then answer is urease positive organism. In the MCQ, this question is specially directed to like NEET PG aspirants. Proteus mirabilis was not in the options. Can I have the answer, please? Which is the second bacteria that you know is urease positive and caused this? Proteus mirabilis was not in the options. We gave all the story. Yeah. Agreed, beta. Proteus mirabilis is the common cause. Proteus mirabilis was not in the options. Can I have the answer, please? Staghorn calculus, alkaline pH, and Proteus mirabilis. Not in the options. Yes. The answer in this case would be answered as Providentia. The second organism which causes this manifestation is Providentia. It is again a urease positive organism. Yes, guys. The first one is obviously Proteus. The second one is Providentia. And the UTI with this can increase the risk of true white stone. See, you started telling me that urease positive organisms, but not all urease positive organisms have the capacity to result development of stones. So there are two names to be remembered, Proteus and Providentia. One good answer that I got was Klebsiella also. So that I accept that answer, that is Klebsiella. Ureaplasma urolaticum also agreed, that is also a urease positive organism. But like the specific answer what the examiner wanted to hear was the word Proteus and Providentia. For the third one, he has mentioned that the stones which are present in the patient are hexagonal shape. So if it is going to be a hexagonal crystal present here, then obviously the answer of mine will change once again, because hexagonal crystals would be seen with respect to cystine stones. That would be a condition called as cystinuria, and this is one of the hardest kidney stones which is present. My next question is directed to all FMG aspirants. What is the investigational choice for any patient coming to the hospital with renal colic? First investigation is obviously ultrasound. First investigation is obviously ultrasound, but chota stones can be missed. So what is the investigational choice for kidney stones in a patient? Patient came with renal colic. Ultrasound is first investigation, beta. It is not the investigation choice. Yes, yes, yes. एक्सरे में तो आता नहीं है भाई. आई थिंक ये तो आसान है ना. अगर अल्ट्रासाउंड में नहीं आएगा तो एक्सरे में कैसे आएगा, आप बताओ मुझे. If the stone is small in the ureter or in the renal pelvis, then if it is not visible on ultrasound, then X-ray पे तो नहीं आएगा ना. It is a CT scan that will be used here. उसने पूछा कि contrast वाला करेंगे तो non-contrast वाला करेंगे. So some people have answered correctly, but I just want to say that lot of students wrongly answered that as contrast enhanced CT scan. Sir, we will not answer contrast enhanced CT scan, because अगर मैंने contrast enhanced किया and contrast is not getting excreted from the kidney, like if I do a CECT abdomen in the patient and I give contrast to the patient and the kidney is damaged, then patient is at risk for development of contrast-induced nephropathy. The contrast-induced nephropathy will result in development of renal shutdown. It will cause polyuria because there is no anuria present here, and along with that there would be uremia manifestations, uremia features that will be developing in the patient. I don't want to take that chance. The serum creatinine of the patient will begin to rise. I have discussed a case like this yesterday where serum creatinine is rising, uremia is coming, but then there is polyuria manifestations that are occurring, because never answer contrast. The learning point is avoid contrast-based studies in kidney damage. Avoid contrast-based studies. Avoid contrast-based studies in kidney damage, because most of them are having a pre-existing kidney damage. There is a risk of CIN in a patient, for which main management is IV fluids. Main management is IV fluids only, and sometimes we might give N-acetylcysteine, but he says nowadays no role. So though academically I did speak about that N-acetylcysteine part, but yep, it is non-contrast CT abdomen to be done. क्यों contrast study नहीं करना है? The reason for not doing a contrast study is the risk of development of a person developing, unfortunately, a contrast-induced nephropathy. Another question directed to all of you: kidney stone का size should be less than how many centimeter for lithotripsy? Should not have written it. अब लिख दिया. Kidney stone should be less than how many centimeter for lithotripsy, and it should be more than how many centimeter for PCNL. So if the page number is on the slide, man, 155. If the size is less than 2 centimeter, then we will go for extracorporeal shock wave lithotripsy. And if the size of the stone is more than 2 centimeter, we will go for percutaneous nephrolithotomy. This data is valid for renal stones also. I would like you to read up the renal stones topic from the surgery also, though I've covered all the questions there, but do read up from the surgery domain also. And the stone size, if it is more, then we go for percutaneous nephrolithotomy in a patient. Less than 2 centimeter, extracorporeal shockwave lithotripsy. Everybody comment which is the hardest kidney stone. I did say about it, but can you tell me the hardest kidney stone in the patient? Yes, guys. Hardest kidney stone. That's just a verbal answer that I expect out of you. Hardest kidney stone, please. Waiting for answers. Yes, cystine. Exactly. Cystine is the hardest kidney stone. Okay, guys. So next, what I will discuss before you is a very easy topic. So I think next part would be a breeze, I think, from the discussion that we'll be doing. I want you to come to page number 159. I want you to come to page number 159. So some miscellaneous points I'll be saying again also, like I invested almost one slide into RBCs in the urine. I described the hematuria. So I will be describing some miscellaneous points later also, but at the moment, let's discuss some again very simple topic, and this would help us, reduce the noting part also and help us remember the information at the moment. Okay, guys. So first question to everybody is, since I think you have all had pathology, you are pathology champions. Look at this slide. This is GI tract slide. I can see a lot of glands in the GI tract. I mean, you have glands, you have goblet cells present. Goblet cells not very clear at this magnification because the image became too pink, but then the glands can be seen, and you can see a volcano-like growth. You can see a volcanic eruption. ऐसा लग रहा है कि जैसे एक न्यूक्लियर बॉम्ब फटा है, और उसके बाद में एक एक्सुडेट जो है, this volcanic exudate is literally sticking to the wall. This is the volcanic exudate which is sticking to the wall. And also when I did colonoscopy of the patient, there were these yellow, pseudomembranes with erythema, like a lot of redness present. So erythema is also there. Erythema is also there. And the colonoscopy report of the patient is revealing that the doctor has the colonoscope, the gastroenterologist has reported that on colonoscopy of this patient, we have noticed that the chap is having yellowish exudates with erythema of the adjacent colonic mucosa. Everything in this question is in favor of the diagnosis of PMC, that is pseudomembranous colitis, which is caused by overgrowth of a bacteria by the name of Clostridium difficile. So this is a very easy topic that we'll be revising at this moment, that is called as PMC. You can note down the name at the moment. Like, I did not deliberately start by writing the name of the topic. I began by describing a slide because it can be a spotter. And along with the spotter part, the second thing would be a colonoscopy report, which is present here. So the combination of the two is what is called a pseudomembranous colitis. There is an overgrowth of bacteria. And this overgrowth of bacteria is by the name of Clostridium difficile, that is producing two toxins, that is toxin A and toxin B. And because of the toxin A and toxin B, I get it, man. Usko bol de. The toxin A and the toxin B are the villains in this case. Now, what is the most common antibiotic that is responsible for pseudomembranous colitis? Then, like, now summer season is coming, so you might be giving cefixime or ceftriaxone. Like, ceftriaxone is IV, and if typhoid patient can take orally, you might be giving cefixime or cephalosporins that can cause this. Second antibiotic is clindamycin, then is even fluoroquinolone. So you need to remember that all antibiotics are capable of causing this, including what I said yesterday, prolonged PPI usage. I said this point yesterday, I'm saying this once again. Nowadays, they've stopped asking what is the most common antibiotic responsible for causing it, which is going to be cephalosporins. They have started asking regarding PPI, that is proton pump inhibitors, that can also contribute to this. So I gave you a heads up with respect to that. How the language of the question will be, he will say post antibiotic diarrhea नहीं लिखेगा. वो बोलेगा patient came to the hospital, he's having, let me say, continuous epigastric pain, and he's having now profuse watery diarrhea. Like, he's trying to say is a known case of gastritis, he's taking PPI regularly. So if he mentions post antibiotic diarrhea, everything is like cat is out of the bag, you know the diagnosis, you know the answer, and there will be nothing left to ask. So I wish questions were so simple that they said that post antibiotic diarrhea. The question will say profuse watery diarrhea in a patient who's taking some medication, and there is abdominal pain and fever also. So when you read fever, low grade fever, you are thinking about obviously an infective cause. You are thinking maybe ate something from outside. Then he will also say that on the workup, on the blood work of the patient, TLC was elevated. So most of the time in the question, like, he will try to disguise it as, like, food contamination, food poisoning kind of a question. And along with that, profuse watery diarrhea given. But then the main thing that is given in the questions that will tell you is that he might, if he's kind on you, point number 4 is if he's kind on you, he might mention regarding antibiotic exposure. As I've told you earlier, pseudomembranous colitis is seen with oral antibiotics, but it can also be seen with IV antibiotics. When I was teaching you pneumonia, remember I was telling you severe pneumonia, we will give ampicillin, sulbactam, azithromycin, 3 antibiotics, patient will cry. Why? Because IV antibiotics can also cause pseudomembranous colitis. So if you get a question where like antibiotic exposure is given, great, but then the question that would be given will be disguised in such a fashion that it will look like an infective cause, and therefore you will be expected to workup. And now I want you to tell me the workup of this patient. Can you tell me the screening test for this condition? Because I'm going to send this sample for stool microscopic examination. If on the stool microscopic examination, if he says that he can see trophozoites with ingested RBC, like, I'm just slightly deviating from the topic, but I want to say that in the exam, it is not a guarantee. He will ask you pseudomembranous colitis. He might say patient came with diarrhea, abdominal pain, fever, and like fever might be not mentioned sometimes in the question. It might be low grade fever. He says trophozoites with ingested RBC, then the answer will obviously change. Or he might only see that microscopic examination only shows bacilli and lot of neutrophils. Then the answer will again change. And obviously the third differential is what is currently there. So I'm waiting for your answers, guys. What is the screening test that you do for diagnosis of pseudomembranous colitis? Super easy topic. All of you read it. Just inputs are required. What is the screening test for diagnosis of pseudomembranous colitis? Waiting for your answers at the moment. Yes. Couple of hints are there. Trophozoites ingested RBC, that is okay. What is the test you will write for this guy? Your answer will be stool GDH, that is glutamate dehydrogenase. This is glutamate GDH, that is the test tool. GDH antigen is what we do for this patient. This is a neglected aspect which is usually asked in the exam. It is stool GDH antigen, that is test. It is stool glutamate dehydrogenase. It is the enzyme which is produced by the bacteria. It is an enzyme which is produced by the bacteria. So stool GDH, glutamate dehydrogenase antigen test is the initial test that we'll be doing in this patient. It can be a ELISA test. The second test I can do is a stool EIA for toxin A and toxin B. I can do a stool EIA for toxin and toxin B. Both will be given in the question and your answer will be stool GDH. This again is one of the highly neglected aspects of the topic of pseudomembranous colitis. So you have to remember it verbatim. As I've said at the moment, that what is the initial test for pseudomembranous colitis for screening purposes, you will say, okay, I'm going to do a stool GDH test in the patient. Before I go to the investigational choice, before I go into the investigational choice, I will also use this opportunity to mention regarding, suppose if the question was saying to me that it is trophozoite with ingested RBC and a patient has come with diarrhea, then obviously I will think about amoebic dysentery in a patient, that is Entamoeba histolytica. And suppose if he gives me a question where only bacteria present with lot of neutrophils, then I will think in possibility of Shigella, because see, shigellosis is also common in our country and sometimes it can result in blood in the stool also. So my point is that if he is gonna talk about this kind of an examination finding, then I also want to say that for both of them, there will always be mention of, like, either way to solve the question will be that you will have to solve it on the basis of the microscopic examination, or there would be presence of blood in the stool. Blood in the stool is never a feature. How do you pick up in a question डायरिया के मरीज में अगर वो बोल रहा है pseudomembranous colitis versus these common causes in India, how will you pick it up? The word is blood in the stool. Guys, if blood in the stool is given, the message I want to give to all of you is, if blood in the stool is given, the answer can never be pseudomembranous colitis. If blood in the stool is given, I repeat the statement again, blood in the stool given, don't answer ever pseudomembranous colitis. It cannot be. This organism will cause diarrhea, it will cause low-grade fever, it will look like an infective cause. If recent antibiotic coverage is given, cool. If not given, then obviously, like the examiner may ask you even without that also, then stool GDH is the first test to be done, followed by the next test in this patient. Investigational choice for diagnosis is what Rajesh has answered. We can do a PCR or a NAT on the patient. So what we will do in the patient is a stool PCR. Don't answer stool culture. In stool there are so many bacteria ना, anaerobes भी होते हैं, aerobes भी होते हैं. ढूंढेंगे कैसे Clostridium difficile को? It would be looking for a needle in a haystack. So it is a stool PCR that will be done in a patient for toxin A and toxin B gene. देखो pseudomembranous colitis टॉपिक तो आप पढ़े हो, लेकिन जो मैंने दो पॉइंट्स बताए ना, जिनको मैंने अभी येलो में हाइड किया, this is what I find mostly students tend to overlook a bit. So if you are aware of these two things, I am so happy. But if you're not aware of this, my question is why this is like the questions that are asked. What is the first test, screening test to be done, and what is the investigation choice for Clostridium difficile induced pseudomembranous colitis? Then it's going to be the following test that would be answered: stool PCR for toxin A, toxin B gene, and stool GDH levels. That is like the must know facts. बाकी तो देखो पैथो में भी मैडम ने इतना करा दिया कि आपको पता है कि PMC क्या होता है, बेसलाइन तो पता ही है. It is just that I am trying to supplement over it. And then colonoscopy report in this patient will show yellow plaques which are pseudomembranes with erythematous mucosa. Both of the points are important: yellow, white, raised plaques and erythematous mucosa in the colon. Once you get this data right, the diagnosis is made, then he is asked the antibiotic of choice, which is very clear. The first episode, the management of the patient is fidaxomicin. Fidaxomicin belongs to macrolides. Fidaxomicin is like a cousin brother. Fidaxomicin is like a cousin brother of azithromycin, etc. So this is a macrolide category drug. But if the episode is occurring again and again, if he specifies first episode, patient just came right now, fidaxomicin. If he says already hospitalized patient had already had an episode, is having it again for severe or a relapsed case, the answer would be given as vancomycin for management of the patient. It is oral vancomycin that will be used in this particular patient. So there is no controversy. Lot of students say, sir, some platforms say fidaxomicin, some say vancomycin, and different teachers हमने पूछा, कोई कुछ बोलता है, कोई कुछ बोलता है. भाई आंसर पे डिपेंड करता है. If nothing is given in the question, that means it is first episode only, fidaxomicin. If he himself says the fact that the patient is not responding to fidaxomicin, or he says patient is having relapsed pseudomembranous colitis, एक बार ठीक हो गया था, फिर से हो गया था, then it is oral vancomycin that is to be used. And now I will say a very shocking thing: stool transplantation. If person is having multiple recurrences, then we will take fecal matter of normal person. And the fecal matter of normal person will be put in the colon of this patient to achieve a balance between the bad bacteria and the good bacteria. The bad bacteria is Clostridium difficile, so we will be sending in the bacteria of the normal stool, anaerobes, to fight it. They proliferate very fast because there is no gas. So the Clostridium difficile will be like, it will be something like survival of the fittest. So fecal microbiota transplant is one of the therapeutic options for management of this patient, where fecal matter of, it looks very unappetizing and like, horrible to say that fecal matter of a normal person will be transplanted into the colon of this patient. And Priyesh is asking me per oral. Obviously not per oral, man. Yes, it is obviously per rectal, right? You do it by colonoscopy, can get rich by donating it. Yes, I love the comments there. I love the humor there. Okay. So the aspects that I've explained to you are for pseudomembranous colitis in a patient. So that is like basic data that I wanted you to remember. Okay. Yeah, vancomycin for second admission, vancomycin for like, yeah, no, second admission, history of PMC in the previous admission. It is second episode of history of PMC in the previous admission. Then we will be going ahead with this. Now a question for you guys, though I made it very, very clear, it's a one-liner question. Yes, the question was antibiotic. The patient is having a antibiotic-induced dysentery. The question mentioned the patient is having post-antibiotic-induced dysentery. Like the antibiotic that was given to this patient was Augmentin. Augmentin is amoxicillin and clavulanic acid. The patient is having antibiotic-induced dysentery. This question is mainly targeted at all NEET PG aspirants. What is the number one cause of post-antibiotic-induced dysentery in the patient? And obviously the answer will not be Clostridium difficile. So a couple of people answered in the actual paper, people answered Klebsiella, people answered it as Clostridium difficile only, because they said post antibiotic likha tha. But one guy was saying कि no sir, it was like blood in the stool that was described after antibiotics. Post antibiotic यार, Augmentin तो एंटीरो हेमरेजिक नहीं होगा ना. Post antibiotic induced dysentery. Yes guys, more people please. No, it is not E. coli. It is not E. coli. It is Klebsiella oxytosa. This is antibiotic associated colitis. Basically it is antibiotic associated colitis. Dysentery word की जगह पे colitis लिख लेना. Post antibiotic induced colitis. Just modify the statement as post antibiotic induced colitis, and colitis implies that there would be blood in the stool. This is slightly a trick question that came in the question. Rifaximin is used for traveler's diarrhea, doctor. We use rifaximin for traveler's diarrhea. So recommendations are, textbook recommendations are fidaxomicin, and second antibiotic that is recommended is obviously like vancomycin. The statement to be noted for all NEET PG aspirants and INISET aspirants is post antibiotic induced colitis is Klebsiella oxytocin. Probiotics will not work, man. Probiotics will not work. Na? Prebiotics, probiotics will not work in this case. राइट वो इरिटेबल बबल सिंड्रोम की बात अलग होती है कि कॉन्स्टिपेशन रह रहा है, डायरिया रह रहा है, लैक ऑफ एक्सरसाइज की वजह से, वहां पे प्रीबायोटिक्स प्रोबायोटिक्स काम करते हैं, वो भी उनका सिंबॉलिक रोल रहता है मोस्ट ऑफ द टाइम. तो द आंसर फॉर दिस पर्टिकुलर क्वेश्चन, okay, fine. Post antibiotic induced colitis is Klebsiella oxytosa. The aspect is what I've sorted at the moment. We shall now be talking about one more medical disorder, that is celiac sprue, which is again very, very simple because they gave a biopsy report of the patient. In the biopsy report, you could see in the small intestinal mucosal biopsy, in the first report, there is a blunting of the villi. In the first report, there is blunting of the villi. And in the second report, you can notice that there is a regeneration of the villi that is happening. One is flattening of the villi, that is blunting. And in the second report, you can see regeneration because we are going for gluten restriction in the patient. The cereals which are contraindicated in this condition are obviously barley, are bro cereals. So I will write down the name of the cereals also, though you all know that barley, rye, oats and wheat. Obviously not rice. Rice is what is given to this patient for management. Barley, rye, oats and wheat are contraindicated in this patient. Then he is asked in FMG exam, what is the cause of development of this condition? The cause is HLA DQ2 and DQ8. Just get the numbers right. HLA DQ2, DQ8 are the not DR2 DR, right? It is not DR, it is DQ. So DQ2 and DQ8 is the reason for development of autoimmunity in this condition. And the biggest problem with celiac sprue is that there is formation of autoantibodies. Now, what is the pathogenesis of the disorder is that यहाँ पे जो antibody होती है IgA class of tissue transglutaminase antibody. The name is TTG, that is tissue transglutaminase antibody. The problem with this tissue transglutaminase antibody is that ये antibody खुद को ही attack कर रही है. खुद को attack कर रही मतलब it is causing damage to the microvilli of the intestine. It is causing damage to the microvilli of the intestine. And what do microvilli do? They increase the absorptive surface area. Na? What do microvilli do is that they increase the absorptive surface area. So what will happen in this patient is that the total absorptive surface area for nutrient absorption will become less. And if the absorptive surface area will become less, the person will end up with development of osmotic diarrhea. That's the point to be remembered, that if the microvilli of the intestine are damaged, then the surface area available for nutrient absorption is less and there is a osmotic diarrhea. So loose motions will be described in this question, steatorrhea will be described in this question, and after that either he will ask you the antibody or he will ask you he will say what is the most specific antibody, so the answer will obviously change. If he says what is the investigational choice for this condition, it is anti-TTG, tissue transglutaminase antibody. But if he says which is having the highest specificity, then it is endomyocele. It is endomyocele specificity. And if he says IgA deficient, then it is IgG class of TTG antibody which is to be taken in these patients. These names have to be remembered, guys. Specifically TTG, to everybody remembers, but endomyocele antibody, the name is forgotten. So that is having the highest specificity. Yeah, crypt hypertrophy will occur in the patient. That is a compensatory. Crypt will try to overcome the damage that is present because crypts are trying to regenerate the normal mucosa in the patient. So yeah, the main feature in the patient is blunting of the villi. It's not crypt hypertrophy. And from pathology perspective, obviously there is a classification which is present here that is called as Marsh classification. So that the name alone is sufficient, that you need to remember that in Marsh classification, there would be blunting of the villi, there would be a crypt enlargement that is occurring in this patient. And then he will say, what will you do for this patient? What are the cereals that can be given? So the cereals that can be used for management of this patient are quinoa, or we can use bajra, or we can use maize and rice with iron and folic acid. Why iron and folic acid? Because this particular disease has maximum tendency to cause damage to the duodenum, and duodenum is the site of iron absorption. This disease has tendency to damage the jejunum, so there will be folic acid deficiency. Ileum is usually spared. Ileum is usually spared in this patient. So the main aspect is iron and folic acid supplementation is required in these patients to take care of the anemia that will be occurring, because iron deficiency जो होती है उससे microcytic anemia होता है and folic acid deficiency होती है तो उससे macrocytic anemia होता है. Combination of the two वो बोलते हैं dimorphic anemia. You see, अगर किसी patient को microcytic anemia भी हो, if somebody is having microcytic hypochromic anemia and is also having macrocytic anemia, then it is called as dimorphic anemia in a patient. You see the gold standard investigation for this patient. If he just says the word, what is the gold standard investigation for this condition? The gold standard investigation is obviously a small intestinal mucosal biopsy, but the problem is that it is invasive and it has to be done twice. First I will demonstrate that there is a flattening of the villi, blunting of the villi. And after 4 weeks, when I do the biopsy again, there would be regeneration of the villi. Small intestinal mucosal biopsy usually is rejected by patients because of 2 reasons. One, it has to be done twice. Before intervention, before dietary restriction, if you do, what you get is main finding is not crypt enlargement, it is the villus atrophy which you will focus upon. And after restriction, and it is not immediately, after like exclusion of gluten from the diet, after exclusion of gluten from the diet, आजकल तो ये gluten free ice creams are also available, gluten free foods are also available. You order a pizza also, it is written gluten free. So I mean things have become easier for these patients. So after exclusion of gluten, you will notice that there would be a perfect regeneration of the villi. Like there were two reports that were given in the paper. That's what I'm trying to say. It mentioned doctor had given some advice. He did not even say dietary advice. He said doctor's advice before and after the report is given. Comment on what diagnosis is present. Answer is celiac pro only. Now to see whether you guys have read the topic, please let me know what is the cause of death in celiac group. Yes, guys. What is the cause of death in patients of celiac group? Options are like diarrhea, malabsorption, electrolyte imbalance, malignancy. Diarrhea, malabsorption, electrolyte imbalance, anemia also came up, and then cancer risk in a patient. Yep. The most common cause of death in these patients, is a cancer of the intestine. The surprising thing, why these patients die, though this is taught in pathology, but this is again a very neglected point of this topic. The most common cause of death that occurs in these patients is lymphoma of the intestine. The number one cause of death in patients of celiac pro is not obviously everybody will be having it, but yeah, if they develop it, then this is what they will develop, not adenocarcinoma of the intestine. They will develop cancer of the intestine. In pathology, the technical term that you will put for this is EATL. What is EATL? EATL stands for enteropathy associated T cell lymphoma. Actually, the medicine MCQ begins from here. Prior to this, whatever I was telling you is what you've already studied in pathology. I could have said, pathologist has discussed celiac pro, you can read from there, but I thought that I'll just try to build up the data, because in the exam, what he will do is he will first write all that information, make it 3-liner, 4-liner, and then we'll talk about the reason why the patient is dying. That is enteropathy associated T cell lymphoma, or EATL, is the number one cause of death. The second problem in these patients is a skin disease, about which I will talk about at the bottom. That is dermatitis herpetiformis. It is written at DH. I will write it at the lower part of the slide. And unfortunately, a lot of these cases can be diagnosed with type 1 diabetes mellitus. So from the medicine domain, what he will ask you is that why do you need to monitor these patients? From the medicine domain, like why these patients come to us is mainly because of the three problems that can be anticipated to develop in these patients in future, because it's an autoimmune condition. So they can develop another autoimmune condition, type 1 diabetes. They can develop a skin disease by the name of dermatitis herpetiformis, and they can develop lymphoma of the gut, that is enteropathy associated T cell lymphoma. 95% of the data that is taught to you for celiac pro, including interventions, that is taught even in pathology. The medicine point is the ones which I want you to remember. In future, usually after around about 8 to 10 years of age, risk for type 1 diabetes, not all will develop it, risk is there. Don't be under impression that I'm saying everybody will develop it. It is some will develop type 1 diabetes, some can develop a skin disease, and some can be developing EATL. Yes, Vikrant. Dapsone is the drug that we use for dermatitis herpetiformis. So what I will also do on page number 160 is that I will utilize this opportunity that I have got to discuss regarding how MCQ dermatitis herpetiformis will be given to you. Most MCQs will avoid saying the word gluten allergy, because if you will say the word gluten allergy in the patient, you will immediately crack and mark it as dermatitis herpetiformis. So this is how the question of your exam came. Let me write it before you. He said a teenager has come to the skin specialist today. The complaints are pruritic papules. And there was an image also given of the elbows of the patient and on the knee of the patient, extensor surface of the knee. If you ever get a photo of the elbow and photo of the knee, and he says pruritic papules, and my student said, sir, they were not only papules, there were scratch marks also. No? If you scratch very hard, then excoriation marks will occur. So pruritic papules विद एक्सपोरेशन मार्क्स, क्योंकि उसको सारा टाइम इचिंग होता रहता है, खुजली होता रहता है, तो नाखून अगर बड़े हो बच्चे के तो ब्लीडिंग भी हो जाएगा थोड़ा बहुत. सो एक्सपोरेशन मार्क्स वर मेंशन्ड देयर. आई मीन देयर सो मच ऑफ इचिंग द चाइल्ड विल कीप ऑन scratching and pruritic papules with exploration marks are given at two sides. What are the two sides? One is the extensor aspect of the elbow, and second is the extensor aspect of the knee. If you ever read these two statements, teenager with prorectic papules with excoriation marks, by default the answer will be thought as dermatitis herpetiformis, and he will help you by writing the workup of this particular question in the following ways. For the workup of the patient, he will first say that the doctor decided, the dermatologist, they don't do blood test. Like if this patient comes to me, I will straight away say, blood test kara lo and we'll make a diagnosis. So he'll talk it from a dermat's perspective. उन्होंने बोला जी biopsy करेंगे यहाँ से. So he will ask you regarding, Nadeem, you are spot on for this one. But before I come to that antibody test, which will be helpful in diagnosis, you have to tell me the light microscopy finding that you get for this particular condition, dermatitis herpetiformis, and it is because of this antibody only, which belongs to immunoglobulin A class. And name of the antibody, Nadeem, you have mentioned very well, but like I'll write it in like about maybe 1 minute from now. So can I have the light microscopy finding of this condition, please? And then he will also mention regarding immunofluorescence study. In immunofluorescence study, the slide will be green. Obviously, the slide will be green, and in that green slide, you will notice multiple breaks in the epidermis of the patient, and there green spots will be present. These green spots are IgA antibody deposits that would be given. These green spots are the deposits of immunoglobulin A that are present. Yes, guys, first is the word light microscopy. The technical word will be papillary tip microabscesses. The light microscopy finding is papillary tip microabscess. Just to make you comfortable, I will say one word and I want you to comment. Munro's microabscess is seen in. Munro's microabscess formation is seen in. Munro's microabscess formation will be seen in. Subepidermal blister beta is seen in pemphigus vulgaris. Subepidermal blister is a feature of bullous pemphigoid. Subepidermal blister is a feature of bullous pemphigoid. We are not discussing bullous pemphigoid. Very good, guys. If I say the word Munro's microabscess formation is seen in, everybody commented beautifully psoriasis. जितना comfortable आप इस बात से हो, the amount of comfort level that all of you are having for the word Munro's microabscess or psoriasis, I want you to have the same level of comfort for this statement of mine. The statement of mine is papillary tip microabscess formation is seen in, answer is dermatitis herpetiformis. It is a one-liner of FMG exam and NEET PG as well. The amount of comfort everybody exhibited, जैसे ही मैंने बोला मुंड्रोज माइक्रोअब्सेस, धड़ल्ले से सीधा 50-60 कमेंट आ गए सोरियासिस अभी भी चल रहे हैं सोरियासिस. The same level of comfort I want you to remember for the finding of dermatitis herpetiformis, that is papillary tip microabscess. Point number 2, immunofluorescence studies in this particular case. When you do immunofluorescence studies in this particular case, then it will be revealing presence of focal immunoglobulin A deposits. Obviously, we are talking about antibodies getting deposited there, so it is focal immunoglobulin A deposits which are present at the dermoepidermal junction. No, this is epidermis, this is stratum basal. इसके नीचे dermis आ जाएगा, इसके ऊपर epidermis हो जाएगा. तो focal immunoglobulin A deposits at the dermoepidermal junction. So I'm just writing the word dermoepidermal junction, DEJ. DEJ का मतलब dermoepidermal junction is the immunofluorescence finding of this patient. So they will love to ask you regarding the skin biopsy findings of this condition. The antibody test of this condition is what has been already commented upon by one doctor. So I want to say that is relatively easier. Another name to be noted by you is anti-epidermal transglutaminase antibody. Don't mix it with the phrase that the patient is having tissue transglutaminase antibody. The name is epidermal transglutaminase antibody. These words should not ever go wrong. Don't rush into the answers, because he will write tissue transglutaminase also, anti-endomyosil also, and epidermal transglutaminase also. So the name is epidermal because skin disease, epidermal transglutaminase antibody. Most questions on this topic have given you the workup of the patient. And then obviously the treatment for this condition is Dapsone. But DH is one of the reasons why this topic is asked. That history of gluten allergy. If history of gluten allergy is given to me in the question, I am happy. But even if gluten allergy is not given, I should be comfortable answering these kind of questions of DH, that is dermatitis herpetiformis. And now I will talk about what is the investigation choice for malabsorption syndrome. Like, because malabsorption can be due to various reasons. Celiac sprue is one of them. I've invested one page. It's a one pager for PMC. It is a one pager for you for the entire celiac sprue data that I mentioned. Uh, Indian patients, yeah, ideally we should be doing testing. Yes, ideally we should be. Investigation choice for malabsorption syndrome is 72-hour fecal fat estimation. IOC for malabsorption is 72-hour fecal fat estimation. I mean, you can very well understand the condition of your technician who's opening the package which is containing feces of somebody for 3 days. Investigation choice is 72-hour fecal fat estimation, which will be having 7 gram of fat, and the stain that is used is called a Sudan 3 stain that you know from microbiology, that you know from pathology. It is like, you can very well understand. First, patient will have to collect the stool, and then the technician will open the package. So today my technician has given a resignation कि sir कितने गंदे गंदे टेस्ट कराते हो. I'm not gonna do this. 72-hour fecal fat estimation is the best test with more than 7 grams of fat. That's a standard MCQ. My question is, can you tell me what is the breath test that can be used here? What is the breath test that can be used in this patient? Just like you are comfortable with breath urea test for Helicobacter pylori, today I am telling you, asking you regarding breath test for fat malabsorption. This patient is having fat malabsorption. What breath test is available for fat malabsorption? It is a non-invasive way to identify, yes, there is a problem. And obviously you can understand fecal matter for 3 days to be collected. The package is not very good. So breath triolein test can be done in this patient. At this moment, I would like to clarify the fact that if he just says the word malabsorption, fat malabsorption, what is the best test? Then answer is 72-hour fecal fat estimation. That is gold standard. I said if he says among the comparison in breath tests, don't be under impression that for fat, like the way I've written it, the impression that goes in mind of students is that for fat absorption, malabsorption, the answer is breath triolein test, and overall the answer is 72-hour fecal test. No. Overall, whether he says malabsorption, whether he says fat malabsorption, the answer is 72-hour fecal fat estimation. And only if he says comparison of breath tests in a patient, comparison of various types of breath tests, that is when breath triolein test would be answered. And now I will talk about another cause of malabsorption syndrome, which is an infective cause, because the previous cause that we were studying here was due to allergy, which was due to autoimmunity. But breath hydrogen is for lactose intolerance. Breath, like a lot of Indians know, they're not able to tolerate milk. So lactose intolerance, that is where we use it. So now you will look at this purple macrophages. They're loaded with bacteria. I mean, in the lamina propria itself, these are villi in the lamina propria itself, you can see so many security system macrophages, and these macrophages are loaded with the bad guys, that is the bacteria. That is the cause of Whipple's disease. That is what has been asked in the exam. What causes development of this disorder? Then your answer would be Trophairma whippleyi. Yes, it is a past positive bacterium. One of the simple questions that came in the exam was, what is Trophairma whippleyi? Is it a bacteria, or is it a bacteria, or is it is it a bacteria, or is it a fungus? So it is a intracellular bacteria. Like H. pylori is an extracellular bacteria. This is an intracellular bacteria which will cause problems. And yeah, the purple thing that you could pick up very beautiful is the pause positive. That is the Schiff's reagent, which is being used to demonstrate the macrophages which are laden with this organism. The question will first begin very harmlessly by describing diarrhea in a patient, steatorrhea. Meaning of the word steatorrhea is bulky, foul-smelling stool. There would be weight loss in a patient, but then he will also talk about joint pain, and he will also talk about presence of fever and hyperpigmentation. Most of the time we read only about point number 1 for this condition, chronic diarrhea, steatorrhea, and weight loss. But especially they will like to talk about joint involvement in this patient, which can even occur before the GI symptoms. Then low-grade fever, which could be present off and on, and there could be hyperpigmentation over the knuckles of the patient. So one of the important cause of hyperpigmentation of the knuckles can be B12 deficiency. Another cause of hyperpigmentation over the knuckles and the IP joints of the patient can be like malignancy, like oat cell cancer. But then today I've told another reason why hyperpigmentation can be present. 2, 3, 4 will be distractors. 2, 3, 4 will be distractors. How will you get back in the question will be, he will say duodenal biopsy of the patient was done or small intestinal biopsy was done. It says past positive macrophages in the lamina propria showing a rod-shaped vessel. The main word that I wanted to remember is past positivity. You will read about past positivity two times in your career. One will be in the topic of alpha 1 antitrypsin deficiency. Past positivity with respect to hepatocytes. He will say past positive inclusions. If you get a question that says past positive inclusions in the hepatocytes versus past positive inclusions in a duodenal sample, I mean, hepatocytes would obviously be a liver biopsy, and here it is like duodenal sample, then the answers of mine will change. I mean, this is a good pickup point to identify. Past positivity in hepatocytes is alpha 1 antitrypsin deficiency. Past hepatocytes, right? I did not say blood cells. If it was blood cells, then it is leukemia. You know, so Siva Balan said leukemia, that is for the lymphoblast. You know, if I say like bone marrow aspiration shows past positivity, then it is okay. I mean, acute lymphoblastic leukemia. But for hepatocytes, it's alpha 1 antitrypsin deficiency. Then it's gonna be duodenal sample. That is the topic of interest. That is called as Whipple's disease. And if it is like a bone marrow aspiration, and he says what is the cell that is responsible here, then in all probability it will be a lymphoblast only. In all probability, it will be acute lymphoblastic leukemia. I will confirm by doing flow cytometry where CD 19, 20, 23 will turn out to be positive. You very well know 19, 20, 21, 23. These are like CD markers positive for lymphoblastic leukemia. So I've given you three situations for past positivity here. Most of the information that I'm saying is a repeat from, you know, what you've read in pathology also. 2, 3, 4 is the distractor points. The main part is past positivity present in this patient. And the second test that we will do is pass PCR on the blood sample, because the infection is going through the blood and is then ultimately reaching the GI tract of the patient. Then he will ask you the treatment. The treatment part is again neglected because it's a medicine domain. So he will say, how will you manage this patient? All cases of ACTH. Dr. Vipin, you have a point. Then is treatment of this condition. Treatment for this condition is ceftriaxone. It is a very high power antibiotic that we normally use in pneumonia and meningitis. We are giving for somebody with diarrhea and malabsorption because it is a deep-seated infection. The query of most students is, sir, why are we wasting so much of firepower and using such a high potency antibiotic for something as simple as a diarrhea? The reason is that this organism is very deep-seated. ये organism छुप के अंदर बैठा हुआ है. It is a very deep-seated organism. The deep-seated organism is hiding inside. The very deep-seated organism is hiding in the security system. So I will be giving to this patient ceftriaxone that would be intravenously for 2 weeks. After ceftriaxone has been given to this patient for 2 weeks, then I will be putting this patient on cotrimoxazole. This cotrimoxazole will be given to the patient for 6 to 12 months. Do remember the treatment. बेटा आपने जो टेट्रासाइक्लिन में फोलिक एसिड बोला ना साइराज, that is answer for what is called as tropical sprue. That is answer for tropical sprue. The answer is not tetracycline with folic acid beta. The answer is ceftriaxone with Septran for management of this patient. So देखो, past positivity, all of you will be able to answer. Past positivity, I am 100% sure, 200% sure, all of you will be able to answer for the past positive bacteria in the macrophages of the lamina propria, the image that I told you. That pathologist has done very well. He will ask you deliberately the treatment of this condition by giving that slide, and your answer will be ceftriaxone plus cotrimoxazole. Don't answer alone. It is ceftriaxone plus cotrimoxazole, and this is where I'm met with disbelief, saying, sir, come on, sir, diarrhea में थोड़ी ना IV antibiotic दे देंगे, इतना aggression थोड़ी ना है भाई. Organism is deep seated, that is why, क्योंकि ना वहां तक oral antibiotic पहुंचता नहीं है. And then he will ask you the CNS complications and the cardiovascular association of this patient, especially NEET PG aspirants, especially INISET aspirants. Be careful at the moment. FMG aspirants, you also have to listen to this, but you can just listen to this once. But NEET PG aspirants, you have to imbibe what I'm saying next. Dementia and CNS cognitive decline is a long-term complication that can be seen in patients of Whipple's disease. And cardiovascular, there can be endocarditis. There could be a development of sterile endocarditis. You know, normally whenever we read about sterile endocarditis, the word that comes to our mind is Libman-Sachs endocarditis. I will cover Libman-Sachs endocarditis in SLE, but I just want to say that whenever you read the word sterile endocarditis, one of the causes for sterile endocarditis, culture negative endocarditis, happens to be Proferma whippleyi. That's the bacteria which can be detected by doing PCR and a small intestinal mucosal biopsy in the patient. So worth remembering, guys, both of these points, the CNS involvement as well as the organism itself damages the brain. The organism itself damages the brain. This organism causes deep-seated infection in the gut. The impression of most people is that ये organism सिर्फ intestine में होता है. No, it goes into the brain also. It goes into the heart valves also. It causes heart valve damage. It's a deep-seated infection. The organism, once acquired by a person, can result in development of damage to the gut, damage to the brain, and damage to the heart of the patient. That is why IV antibiotics and aggressive treatment is required for management of this particular condition. Yes, what I've shown is macrophages. Those macrophages are filled with the bad guys. That is the bacteria, and that is having pass positivity. It's a intracellular bacteria. जो H. pylori होता है, H. pylori is always a extracellular bacteria, but this one is a intracellular bacteria. And now I want the everybody to comment in the chat box. I know you know the diagnosis. Tell me the most common cause. They gave this image, and I will give the first right to answer here for all NEET PG aspirants. The question में उसने ये photo दी थी, and he said he did not ask the diagnosis. Obviously, diagnosis is so simple. Anybody who's a medical, yeah, oculomasticatory myarrhythmia. That's like a sinus decline that can occur in this patient. Okay, I'll just write that, Humaira. That's a good answer that you said. Oculomasticatory myarrhythmia. This is obviously achalasia cardia. You can notice the smooth tapering defect which is present here. The lower part of the esophagus is like simply constricted. So my question is, what is the most common cause? And I expect answers from you guys. Options are idiopathic, autoimmunity, Chagas disease, malignancy. Select one. Please minutes. 20 minutes. Okay. Yes, guys. The question says overall, what is the most common cause of it? Guys, it is not Chagas disease. Yeah, Chagas disease तो भाई Chagas disease will be in South America ना. So suppose हम वेनेजुला चले जाते, ब्राजील चले जाते, पेरू चले जाते, तो वहां पे Chagas disease होता है. Chagas disease में क्या क्या इन्वॉल्वमेंट होगी? So it will be dilated cardiomyopathy, mega heart. It will also be having mega colon, and it will also be having mega esophagus. So suppose I was giving you that a person from South America, and I said that this guy was bitten by a bug. You know that the parasite is Trypanosoma cruzi. The bug here is called as red ovate bug. A tropical medicine question is, the bite of the bug causes swelling. What is that swelling called as? That the swelling is called as Romana sign. The bite of the bug is called as Romana sign. So suppose they give you a question in which you are able to notice that he mentions South American ethnicity of the patient with mega heart, mega colon, mega esophagus, and Romana sign given, then if you say it is Chagas disease, but if he says what is the reason for the degeneration of the inhibitory neurons, what is the reason for destruction of this nitric oxide producing, VIP producing, nitric oxide or VIP. Nitric oxide is a vasodilator. VIP will also relax. So point is, relax करने वाले esophagus को relax करेंगे तभी तो peristalsis होगा ना. When esophagus one part will contract, other part relaxes. Peristalsis क्या होता है? One part constricts, other part relaxes. So you want peristalsis to happen, and in this patient, like that, peristalsis will not be able to happen because the relaxing part is gone in this patient. The most common cause for this is autoimmunity. The most common cause for this is autoimmunity. Guys, this was a simple question that came in the paper. वो बोला कि क्यों होता है achalasia cardia? The answer is not Chagas disease. It is not idiopathic. It is autoimmunity. That is why most questions will begin by saying young female. From the pathogenesis perspective, though, you know what is the, yes, that drug that you're mentioning, benzimidazole, that is basically the treatment of Chagas disease in a patient. But at this moment, my point is, we are not in South America, we are living in India, and overall the most common cause on global basis is also autoimmunity. In this particular patient, there are two problems from the pathogenesis perspective. One problem is aperistalsis, because the esophagus will not be able to relax now. It is tonically constricted. You can notice the smooth tapering defect. Esophagus यहाँ पे tonically contracted है तो उसमें खाना फंस जाएगा. The complaint of the patient is, this lady says, doctor, when I eat food, the food sticks behind my chest bone. She puts her hand like this. She says, doctor, I eat anything, the food sticks behind my chest bone. The reason for this is that the esophagus is now lacking peristalsis, because the relaxation part of the esophagus, that is like when the food has to go down, one part will constrict, other part will relax, the relaxation part will not happen. The second biggest problem in this patient is that the lower esophageal sphincter tone, because inhibitory control is gone, so lower esophageal sphincter tone is increased, so food will not be able to go down. You can see two reasons why the food will not go down. क्यों खाना फंसता है? One is aperistalsis and second is inhibitory control is gone. If you lose physiology, inhibition of inhibitory control gone, then you get a stimulation. Stimulation means lower esophageal tone of the patient will be increased. So in the exam, they ask what is the most common cause. Second, they ask the endoscopy finding. So can I have the endoscopy finding of this condition, please? I think everybody has attended a surgery class and they know about HLSA cardiac. It was the lower one third. Can I have the endoscopy finding of this patient? Because any patient with dysphagia, when he will come to you, any patient with dysphagia, when he will come to you, you will first do endoscopy. Barium swallow is done only for academic reasons. It is not a diagnosis. What is the endoscopy finding that is present in this patient? I will wait for more people to comment here. What is the endoscopic finding? Options are puckering of the esophagus. Option number 2, rat tail appearance. Option number 3, bird beak appearance. Some people are already commenting. Yes, guys. Options are puckering, bird beak, rat tail. Quick answers, please. Yes, 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 yes. I'm waiting for more people, please. The answer is puckering, rosette. Those are the words that are described. Puckering of the lower part of the esophagus. Puckering of the lower part of the esophagus is the reason why the question is put up here. Guys, the answer is not bird beak or answer is not a rat tail, because those terms are used for describing if it is a barium swallow. It is puckering of the lower esophagus. This is a motility disorder. So the motility disorder will say, what is the, the question itself will say, what is the investigation of choice for this condition? It is a high resolution manometry. And the main feature of high resolution manometry will be what I said already. The lower esophageal sphincter tone is more. That is why the food is not able to go down. If you do a barium swallow in the patient, the barium swallow will be showing what is called as a smooth tapering defect. Malignancy will always have irregularity. Like suppose in the later part, you will see I will draw a diagram like this, which will have a irregular filling defect. That is the rat tail. The rat tail is the feature of cancer. Malignancy always results in, I'll remove this from here so that there is no confusion. If there is a description given like this where you can see the irregular filling defect, then you'll say, okay man, this is rat tail appearance. But here it's a proper filling defect, a smooth tapering defect, so it is also called as bird beak appearance. And then because the proximal part of the esophagus is dilated, भाई आगे खाना नहीं जा रहा है तो पीछे वाला पार्ट डायलेट कर जाएगा. द प्रॉक्सिमल डायलेशन इन दिस कंडीशन इज कॉल्ड एज sigmoid esophagus. So there are 3 barium swallow findings that I've covered. Guys, it's a one pager but high yield for the topic of HLSA cardia. Smooth tapering defect, bird beak appearance, maybe also written as pencil tip appearance. It can also be written as pencil tip appearance, or a sigmoid esophagus is the endoscopy finding of this condition. And then obviously when we do a high resolution manometry, we'll be spot on for the diagnosis of this patient as well. Question for everybody. Do you have chest pain? Do you have chest pain in patients of HLSA cardia? Yes or no? Comment in the chat box Y or N. I would like at least 100 comments coming up very soon, guys. Do you have chest pain in HLSA cardia? Okay, so the class is divided 50-50% here. I want to tell you that chest pain can be present in HLSA cardia. Why? Because there is a contraction of the esophagus. Contraction will squeeze its own blood supply. होता है sir, chest pain होता है. How many types of HLSA cardia are there? 3 types. You have to remember the name of the windy city. What is windy city in America? Chicago. It's a Chicago classification, which is total of 3. In all of them, it will be absent peristalsis, incomplete relaxation of the sphincter, but one of them will be having spastic contractions. That spastic contractions will cause development of chest pain in the patient also. It will result in development of chest pain in the patient also. So since I was having a bit of inaccurate answers there, what I will do on this slide is that I will mention the clinical manifestations of this question, how the case will be given. It is optional if you want to note down, because this is covered in surgery. I expected answers at this particular point of time to be very precise, but since they were a little accurate, so let me invest about 1 minute in explaining to you how the question will be given. We will begin by saying young female. Comment in the chat box whether this will be progressive dysphagia or will this be non-progressive dysphagia. Meaning of the word progressive is that the symptoms will worsen. over, let me say, 6 months, 1 year, non-progressive symptoms will remain the same. So it will be a progressive dysphagia occurring. The symptoms of the patient will worsen with time because like autoimmunity is not getting treated. In this particular patient, there will always be complaints of the food sticks behind the chest bone. There is a dysphagia. Now I want you to say that solids जो होते हैं, they are heavy. Solids can are heavy. So solids by cause of their weight can still be going down. Like let me say if this is solid, then the solid food item, what the solid food item can do is that the solid food item due to weight can still go down the sphincter. This is the tightly constricted sphincter here. The food can still navigate across the tightly constricted sphincter. Why? Because the solid is heavy, but liquid is lighter. So liquid will not be able to go down. So these patients eat food, then they drink water, they eat food, they drink water, nothing is going down or less but it's going down. So the question will mention dysphagia is more for, and your correct statement is, I think everybody knows this, so I don't need to ask you, the dysphagia will be more for liquids as compared to solids. The rationale for that is dysphagia is more for liquids or solids is liquids are lighter. The liquids are lighter, so therefore the food will not go down, liquid will not go down, solid is heavy, so it will be able to go down. So progressive dysphagia would be given in this patient, that is one, and dysphagia more for liquids. He will say dysphagia more for liquids as compared to solids. After that, the question will waste your time by mentioning halitosis. That is because there is residual food and water. In you and me, not a single drop of food and water will remain behind in the esophagus. So he will say halitosis. He will say regurgitation of food items that were consumed previously. Listen to my words carefully. It is regurgitation of food items, not vomiting of food items. Like he had poha in breakfast or dalia in breakfast. Like most Indians will be eating paratha or like poha, dalia, like common idli, like common food items. So he will say whatever I ate in breakfast, the food items are coming out. It will be undigested food particles because they're stuck in the esophagus of the patient. So regurgitation of food items would be the next manifestation that will be given in the question would be recurrent pneumonia episodes. He will say recurrent pneumonia episodes, and there is a tendency of doctors to start calculating Curve 65 score. That is a good habit. Always try to calculate Curve 65 score in any case where pneumonia is mentioned, because that may come in handy. And then he might deliberately mention the word chest pain in the question also, because he wants you to think in terms of diffuse esophageal spasm, because chest pain is seen in some cases of type 3 variety, that is type 3 variety of HLA by the Chicago classification. In fact, a lot of these MCQs will deliberately begin with this information. He will mention halitosis, he will say regurgitation, pneumonia, chest pain. This will be the starting of the question. The dysphagia for liquids more than solids will deliberately be given in the later part of the illness, because he wants to hide that from your vision initially. So at this moment, the question can be Zenker diverticulum also, it can be diffuse esophageal spasm also, because these are common findings that are seen in patients of esophageal involvement. There are total 3 varieties. The best prognosis is the worst prognosis is for type 3 because chest pain is present, so that symptom usually tends to persist. Type 2 has the best prognosis and responds best to pneumatic dilation. And if he says what is the treatment of choice for this pre-malignant condition, then all of you know the treatment of choice is a laparoscopic Heller's myotomy. It is a minimally invasive procedure. We will be going ahead with a partial fundoplication also, because I don't want reverse to happen, that is GRD. And he will also ask you what is the type of fundoplication that is done in this patient. It is either Doer or it is Toupet. So for all Chicago types, we can be going ahead with this, but especially type, fundoplication is a basic procedure that is done to prevent the development of GERD in the patient. This is the surgery of choice, but if the patient will refuse surgery, Heller's myotomy, laparoscopic plus fundoplication, then what we can do in this patient is, we can go in for a percutaneous, we can go for a per oral endoscopic myotomy in the patient also. So laparoscopic or a per oral POEM can be done in a patient. But if the patient refuses, then we can go for balloon dilatation. We can go for botulinum injection also. Like normally botulinum injection is for looking, young. Like people get this Botox injections. But then here we are injecting Botox to relax. No, better not Nissan's fundoplication. Not Nissan's. It is either DOR or it is Toupet. It is either DOR or it is Toupet. It is not Nissan's fundoplication. That is a complete fundoplication that would be done. And the last resort is we can be using calcium channel blockers in a patient. This is a pre-malignant condition. Other procedures that can be done are like PD. PD stands for pneumatic dilation. Botulinum toxin injection can be given, and even calcium channel blockers can be used here. And anyway, you are all aware of the fact that this happens to be a pre-malignant condition. This happens to be a pre-malignant condition related to the esophagus, and that's why like the follow-up of the patients and monitoring of the patients is important. What I will do next is discuss like two quick topics which will take like 2-3 minutes each one here. And first one is Zenker diverticulum, where the food will get stuck in this posterior diverticula. I know that you know this topic, but let's just quickly do this. I'll do a sketch diagram here, and then I'll put up a question for you guys. The diagram, I would suggest you to draw with me quickly. That will help you remember the information also relatively bad. But if you're done in surgery and you are sure about all, then it's okay also. I mean, if you say that I am done with this in surgery and I am just attending it for the sake of completion, I'm okay with it. This oblique fiber that I'm teaching you at the moment, this oblique fiber that I'm teaching you at the moment is fibers of the inferior constrictor muscle. These oblique fibers are of the inferior constrictor muscle. और ये जो transverse fibers हैं, they are of cricopharyngeus. Yes guys, give me like, you know, I said max गिन के I will take max 5 minutes of your precious time, but hear me out. Inferior constrictor muscle and cricopharyngeus muscle is what I've shown at the moment. You will soon realize the importance of listening to the data here. This is the smooth muscle. This is the smooth muscle below the cricopharyngeus. Below the cricopharyngeus, this is the smooth muscle which is present. And you know that esophagus is a junction of the skeletal muscle and the smooth muscle. And this is one anatomical area that I would like to highlight is having a weakness. And you could be developing, this is like a triangle which you can see here, and you could be having a outpouching developing from this triangle. So I give a quick answer to all FMG students here. They all can contribute quickly here. Look at this triangle below the cricopharyngeus and let me know what is the name of this triangle. Yes, guys. Yes. What is the name of the triangle? Quick comments in the chat box. I would like you to fill up the chat box so that I stop looking at the chat box. Yes, guys. Quick answers first to FMG students, then to NEET PG aspirants. You can join now. Yes, guys. Okay. 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 Okay, guys. So let me say all of you are wrong. All of you are wrong. All of you are wrong. Yes, one guy did get it correct. Sir, आपने discussion सुना नहीं है. That is why I'm making you sit. That is why I'm making you practice this. Yes. Sir, you can't get it wrong. ये इतना मतलब आपको भूख लगा का मतलब ये नहीं है कि लास्ट एमसीक्यू गलत कर देंगे. This triangle is what is called as Lymer's triangle. जो किलियंस ट्रायंगल होता है वो ऊपर होता है, ये वाला. अगर मैं आपको ये ग्रीन वाले ट्रायंगल को मार्क कर, उसने पेपर में जानबूझ के एरो नीचे दिया था, सब लोग किलियंस मार्क करके आए थे कि अरे सर बड़ा इजी पेपर था सर, वो बड़ा ईएनटी में तो बड़े फुल स्कोर मार्क करके आ गए. ईएनटी वाले आधा टाइम तो बता भी नहीं रहे होते. सर इफ द डाइवर्टिकुला विल डेवलप हेयर, द ग्रीन वन, then you will say it is the Killian's triangle. It is a silly mistake that occurs in overconfidence that a lot of people वो तो देखते ही नहीं है कि अरे सर वो जिंक डाइवर्टिकुलम था, मैंने किलियंस बोल दिया. तो बंदा कह रहा है नहीं सर ऐसा था ही नहीं क्वेश्चन, आप पूरा डायग्राम बना हुआ था उसमें एरो नीचे था. अब आप इसको अनाटमी बोलो, ईएनटी बोलो, या फिर इसको मेडिसिन बोलो, सर्जरी बोलो, ऐसी गलती करनी नहीं है आपको. लाइमर ट्रायंगल और किलियंस ट्रायंगल तो बेसिक है यार, फर्स्ट ईयर में भी पढ़ाते हैं, फिर ईएनटी वाले पढ़ाते हैं, फिर सर्जरी वाले पढ़ाते हैं, आज मेडिसिन में आ रहे हैं तो आप जाके रियलाइज करोगे अरे यार इसको भी सुनना था क्या. हाँ भाई सुनना था. Below the cricopharyngeus it is Lymer's triangle. Above the cricopharyngeus it is the Killian's triangle. Diverticula can develop at any of the following sites in this patient. The clinical manifestations in this patient will be uniform. This is the only GI condition. In fact सिर्फ GI की दो ही conditions होती है जहाँ barium swallow करते हैं. I will mention the second one after the lunch session. There are only two GI conditions where esophageal disorders where barium swallow is done, where you will get a posterior filling defect. Here the word will be that you can see a outpouching. The barium swallow will say outpouching, and that outpouching is a filling defect. Clinical manifestations I'm not writing, I've already told you. Halitosis, क्योंकि खाना फंस जाएगा तो bad smell. Regurgitation of food items would be given in this patient. The age group here will deliberately be given to be old man because he wants you to think in terms of cancer. The MCQ will begin by saying dysphagia, but it will be a non-progressive dysphagia. Cancer में progressive होता है. It will be he may not write the word non-progressive or progressive, but he will try to describe in symptoms that as compared to last year, symptoms are same. Diverticular 2.5 सेंटीमीटर से 3 हो गया, 3 से 3.5 हो गया, तो it will not cause any change in the symptoms of the patient. So it is a non-progressive dysphagia. And then he will start wasting your time with respect to halitosis. He will talk about that regurgitation of food items that I've already explained to you. He will also talk about pneumonia episodes. So obviously, like in an old man, pneumonia given, that is again a cause of concern. And he may even add the word weight loss just to make you think that this is a cancer. You will be able to identify this condition either on endoscopy, first investigation for this patient. If he says, what is the first investigation in this patient? Don't answer Merriam-Swallow. Anybody with dysphagia, old man with dysphagia, first investigation is always endoscopy. Endoscopy report will be clean because most of the time the opening of the diverticulum is chotu sa, so it is not visible. Endoscopy, first anybody comes with khana fasta hai. Any patient, and especially an old man, comes with dysphagia. If old man comes with dysphagia, first thing to be done is always endoscopy to check for whether there is some cauliflower growth which is occluding the esophagus. Luckily, no cancer present here. That is when you do a Barium-Swallow and are able to identify this, and then you do a surgery in this patient. Everybody is under a surgery class. Let me know what should be the size of the diverticula. Diverticular size should be more than how many centimeter that surgery is planned. The name of the surgery is mentioned here, Dolman's procedure. It's an endoscopic diverticulotomy, not a culectomy, not a diverticulopexy. इसको पढ़ लेना. Endoscope surgery से endoscopic diverticulotomy, not colectomy and not a pexy. Yes, it should be more than 4 centimeter. We can also go for Z poem in this patient. That Z poem is a special poem for Zenker diverticulum. This Z is for Zenker diverticulum. This Z is for Zenker diverticulum. That is poem. आप Zenker degeneration भी पढ़ रहे होते हैं ना. Zenker degeneration कहाँ पे पढ़ते हो? Pathology, Zenker degeneration. Quick answers, please. Zenker degeneration. Last question for before we go for lunch break. Zenker diverticulum नहीं, Zenker degeneration is read in. मैडम ने बताया हुआ है, मैं तो बताता ही हूँ. Zenker degeneration. It is present in skeletal muscle in typhoid. Exactly. Anjali was the first one to comment on that. When you listen to initial lectures, then you will notice in pathology बताते हैं Zenker degeneration is seen in typhoid and it involves the skeletal muscles. क्योंकि ये Z वाली term जो है ये बड़ी close मतलब बड़ी peculiar है ना, Zenker, तो that is why I thought I should just mention here. But like yeah, these are a couple of aspects which I wanted to remember, and obviously like the differentiation from the cancer is pretty easy to identify. So fine guys, I think we are like sorted for this part of the discussion. We go for a lunch break, so I think 3:40 is okay by you. 3:40 is perfectly fine, and we can start again. It's almost gonna be 3, so 40 minutes is okay guys. Fine, fine. I see you at 3:40. बैंगलोर जाना पड़ेगा। हाँ ऐसा तो चल अभी तो काम करते हैं। Hi guys, you can join back and we can finish the topic of esophagus. Hi guys, let's get started. Oh, what's for lunch? Pizza. Okay. Okay. So let's talk next regarding carcinoma esophagus. Before I start with carcinoma esophagus, I have a question for all of you. Hi guys. Hi Dr. Suruchi. Let's get started. A question for all of you is you are supposed to note this on page number 163 only. What below? Note this below where calcium channel blocker is given. Okay. What is the cause for development of pseudo achalasia? Yes, guys. Quick answers, please. Hi, Saransh. How are you? Hi, Pranav. Great. Eggs, vitamin B12. What is the cause of pseudo achalasia? चलो भाई, अब एक दूसरे को पिकिंग मत करो. What is the cause or development of pseudo achalasia? HLS cardia is primarily a pre-malignant condition which is caused by autoimmunity. But if he specifically says like pseudo HLS cardia, then your answer would be given as cancer. And most of the time, the cancer in this particular case would be originating from the stomach. I think all of you read about the term linitis plastica. Have you heard about the term linitis plastica? Yes, I'm sure, 200% sure you read it. So just like you guys are comfortable about the fact that linitis plastica is where the cancer of the stomach will infiltrate the wall and will cause a leather bottle stomach. Today I'm saying that carcinoma stomach cancer will spread into the wall of the esophagus and it will damage the Auerbach plexus. Exactly. The carcinoma stomach will spread retrogradely and it can then go and damage the Auerbach plexus of the esophagus. If the Auerbach plexus is damaged, then it causes the development of HLS cardia. Yes, all of you have read the term leather bottle stomach in linitis plastica. I've solved a question for you guys. The question that you need to remember is pseudo achalasia. Why we call it pseudo? Because you can understand it is not autoimmunity, it is because of a malignancy by the name of carcinoma esophagus. So that's another question of the pre-IQs or previous year questions that I have currently handled at the moment before you. And carcinoma stomach is not only famous for linitis plastica, it is also famous for that sister Mary Joseph nodule where the cancer will metastasize to the umbilicus of the patient. So those are very familiar terminologies, but I wanted to speak about this cancer just to say that the cancer can be spreading retrogradely and can involve the wall of the esophagus, and Auerbach plexus can be damaged in the patient. Now coming back to this is to be added on page number 163, just below the topic of achalasia, where I've covered it. Now we will talk about carcinoma of the esophagus on page number 165. Cancer of the esophagus, the usual risk factors for this would be like H. pylori is one of the known causes because it can cause reflux esophagitis, GERD, and then due to that reflux esophagitis and GERD, person can have Barrett's esophagus that can cause cancer of the lowermost part of the esophagus, that is adenocarcinoma. But overall, the most common cancer of the esophagus, however, is not adenocarcinoma. Most of the time, carcinoma of the esophagus could be secondary to like person is eating preservative based food. Like nowadays, a lot of people eats preservative wala khana, so that preserved food, canned food is having like agents which can cause problems, and thereby squamous cell cancer will be involving the middle 1/3 of the esophagus, and this is the commonest cancer. You can see this image also. The image shows very classical, like if I say anything, the answer will become obvious. So I can say this is like a cauliflower growth. The cauliflower growth is causing that irregular margins to develop. So can you tell me at this particular point of time, what is the radiological finding of carcinoma esophagus called as? I will remove this marking. This was like a cauliflower growth which is occluding the lumen of the esophagus. What is the technical term that you would like to say for this, where you can see that this is like it looks like a moth eaten, right? It looks like a moth eaten. No beta, it is not apple core. Beta, apple core answer जो होता है, that is given for apple core answer is given for colorectal cancer, not for this cancer. ये कोई circum दोनों साइड से थोड़ी ना narrowing हो रही है, ये apple core नहीं होता. Guys, your answer for apple core is wrong. कार्सिनोमा इसोफेगस की जो फाइंडिंग है उसको टेक्निकली ये रेड टेल भी नहीं है ना. रेड टेल इज अ फाइंडिंग ऑफ द लोअर 1/3. एग्जाम में वो ये वाला इमेज दिया था. तो दिस इज व्हाट इज अ इरेगुलर फिलिंग डिफेक्ट, आल्सो रेफर्ड एज अ शोल्डरिंग साइन. गाइस, दिस इज नॉट अ एप्पल कोर अपीयरेंस. This is simple a irregular filling defect which one doctor had mentioned earlier. Sorry, I just missed your name there, but it's a irregular filling defect which was answered correctly and is also called as shouldering sign. The barium swallow. जो रेड टेल होता है वो लोअर 1/3 द इसोफेगस पे होगा, उसमें वो इसोफेगस देके फिर वो ऐसे रेगुलर फिलिंग डिफेक्ट लोअर 1/3 में दे देगा. रेड टेल इज यूजुअली नॉट आस्क्ड इन द एग्जाम, दो सारे रेडियोलॉजिस्ट एवरीबडी शोज यू रेड टेल का अपीयरेंस का फोटो, बट मोस्ट ऑफ द टाइम द फोटो दैट हैज कम इन द पेपर इज जो मैंने आपको दिखाई है. द इमेज लाइक मैं ऐसे बोलूंगा कि मैंने जो एफएमजी सॉल्यूशंस किताब में जितने भी रेडियोलॉजी के क्वेश्चंस मैंने डाले हैं उनमें आप देखोगे रूटीन वाली इमेजेस है ही नहीं, क्योंकि एग्जाम में अगर रूटीन वाली आती होती है, अगर पेपर इतना इजी होता है यार रेड टेल वाला और बर्ड बिग वाला, तो फिर दिक्कत ही क्या थी. तो मैंने रेडियोलॉजी में सारे इमेजेस वो वाले डाले जो बच्चों ने बोला कि नहीं सर ऐसा रेड टेल तो था ही नहीं ना, इट वाज अ इरेगुलर फिलिंग डिफेक्ट दैट वाज गिवन इन द पेशेंट. दिस इज द शोल्डरिंग साइन, दैट इज अ इरेगुलर फिलिंग डिफेक्ट. The question will begin by describing a person. Most of the time it would be like a person on senior age, male or female. And the first complaint of this patient is खाना फंसता है. And that खाना फंसता है तो आपने पूछा कि भाई symptoms बताइए मुझे, पहले से improve हुए हैं या worsen हुए हैं. So the question may not use the word progressive, but they will give you a sense of the fact that the symptoms of this guy are progressively worsening over time. Cancer undetected will keep on worsening, so it's a progressive dysphagia. Then you will also manage that the dysphagia is more for solids, because solids तो फंस जाएंगे ना, लिक्विड तो अपना रास्ता बना के साइड से निकल जाएगा, because it's a cauliflower growth in the esophagus causing a luminal narrowing. So liquid will be able to force its way across, but the solid will get stuck in this particular case. After that, the question will then again try to waste your time by describing the standard features which I've explained to you. Halitosis will be given in the question, regurgitation of food items will be given in the question, and also he will mention recurrent pneumonia episodes. Now, what is written in the question that will make the diagnosis very, very clear will be presence of very significant weight loss, that is cachexia. The moment you read the word cachexia in any question, the moment you read that the person is like, having like he was before cancer started, he was 90 kgs weight, tall guy, 5 feet 11 inches, 90 kg weight. Now he's only 45 kg. Literally the clothes are hanging on the body of the patient. That would be the key word that will help you identify that you're dealing with the malignancy. And then they will ask you what is the workup of this patient. So I will give you options as they gave in the exam. One of the ways for diagnosis is upper G endoscopy. Another one is we can go for high resolution manometry. HR stands for high resolution manometry. Then I can go for a barium swallow in this patient. Then I can go for a barium meal follow through in the patient. So you can quickly comment on the options which are given here. What is the main test for diagnosis of this condition? As I've said, anybody with cachexia, you will do an endoscopy and then you will do an endoscopic biopsy. Guys, the answer is endoscopy. He deliberately did not write the word. The examiner deliberately did not write the word biopsy, but it obviously means the same, that when you are doing an endoscopy and if you are going to see a fungating growth, the main test for diagnosis of this condition is upper G endoscopy with a punch biopsy from that cauliflower growth. When we send it to the histopathologist, he will be able to see a squamous cell or adenocarcinoma as the case may be, but squamous cell cancer is more common in the middle one third of the esophagus. The next investigation that we will do after this would be a CT abdomen because we want to check out the spread. While I'm writing, like question asking to you is what is the most common organ to which esophageal cancer will spread? I want to say that esophagus serosa is absent. That is the reason why it can spread so fast. Serosa is absent in the esophagus. This is the reason why the cancer can spread very fast. So, what is the organ that what is the commonest organ that commonest site of metastasis of carcinoma of the esophagus? Yes, it is the liver. The cancer most of the time is already spread, just like colorectal cancer is already spread. Here also the cancer would have already spread. So CT abdomen is going to be done in this particular case to determine the spread to the liver. There is no definitive, like surgery most of the time cannot be done because the cancer is already spread, but I'm just leaving it a blank here. I would like you to read from the surgery notes for this condition if he has taught some kind of named surgery, etc., because sometimes there are name of some doctors who are pioneers in esophageal surgery. So if it's given some name, you can do it from there only, but otherwise, like, we do a staging, and again the staging part also, if he has told, you can go through that. The cancer has a poor prognosis and most patients will be dying between 6 months to 12 months. So overall cancer of the esophagus has a bad prognosis. So CA esophagus is why recurrent pneumonia. Why? Because the aspiration ना, because खाना फंस जाता ना यहाँ पे. So micro aspiration can occur even in this case also. Micro aspiration can occur because any food, and if there is even a single drop of food item in the esophagus, no, it could be going up, and that could result in similar kind of issues in the patient. So it's mainly a palliative treatment that would be done. The next thing that I've described is this corkscrew esophagus. You can easily see the appearance there for corkscrew esophagus, and the diagnosis of this patient would be given as diffuse esophageal spasm. Now, why do you get a diffuse esophageal spasm? I would like to say that this is a idiopathic condition. Diffuse esophageal spasm is a idiopathic condition. What is the highlight of this condition? It is a non-peristaltic premature contractions of the esophagus. It is a premature non-peristaltic contraction of the esophagus. Let me explain what I mean by that. Like, suppose you can stop noting for like 30 seconds and listen to me. Like, suppose if one part of the esophagus will contract, then the other part is bound to relax. No, like this is the food bolus. Then when the food is present, then one part will contract, the other part will relax, so that the food can be propulsed or moved in a particular forward direction. Now, in this particular patient, like, why this person has come to me is the following reasons. This is the blood vessels. All blood vessels of the esophagus would be traversing through the wall of the esophagus. Sir, the condition is very resistant to treatment, and most of the time, like, esophagectomy being done is not an easy thing to do. We can put a prosthesis in place, but then most of the time the prognosis in this condition is really bad. So most patients will be refusing surgery. And just to tell somebody, we are going to do a transhiatal esophagectomy, it's like a very extreme procedure. Now, what I'm saying is, what is happening is that there is a simultaneous contraction of all parts of the esophagus. मैंने तो खाना भी नहीं दिखाया. I have not even shown food, and esophagus in this condition will contract with so much of force that it will squeeze its own blood supply. The esophagus will contract with so much of force that it will constrict its own blood supply. This is the reason why this topic was asked in the exam, and I've described it this moment, that for, yeah, exactly, Santosh, you're right, exactly, Santosh, cancer esophagus is fine. That the reason why diffuse esophageal spasm was asked in your exam was because the presentation in this case would be that of chest pain, and therefore the alternative name for this condition that you need to note down is esophageal angina. This was the question that I wanted to handle. It was a one-liner only, that which condition is called as esophageal angina. The answer would be given as diffuse esophageal spasm. The esophagus will contract with so much of force that it will constrict its own blood supply. I hope it's clear, guys. Esophagus इतनी जोर से contract करेगा, अपनी खुद की blood supply को दबा देगा. It would be a non-peristaltic contractions of the esophagus. Non-peristaltic means one part should contract, one should non-peristalsis means one part should contract, other should relax. Here it is all contraction, so it's crushing its own blood supply, and therefore esophageal angina will be occurring. The most of the time the question will begin by saying a young female, and then he will say that she's having chest pain. Now, as I told you, chest pain was present even in achalasia cardia, so he will try to disguise it in such a fashion that you might be thinking that it can be spastic achalasia cardia. He will say intermittent episodes of chest pain. This young female came, she's having intermittent episodes of chest pain. These episodes of chest pain are present at rest also. So initially the patient will also think, and doctor will also think, because chest pain is occurring at rest, it is going to be angina of the heart, that is narrowing of the coronary arteries. So you might be doing ECG, echocardiography, treadmill test in the patient, but all reports will be normal, because problem is not in the coronary artery. It is a contraction of the esophagus smooth muscle which is causing problems in this patient. So it is intermittent episodes of chest pain at rest, which how this disease will present. Second would be dysphagia, then would be regurgitation of food items, because if two parts of the esophagus will contract together, if the distal part will contract with more force, the food may go in reverse direction. मैंने बोला जो डिस्टल पार्ट है अगर वो जोर से कॉन्ट्रैक्ट करे प्रॉक्सिमल पार्ट से, तो खाना फिर आगे नहीं जाके रेट्रोग्रेड जाएगा. So regurgitation of food items and dysphagia can be a presentation given even in this particular question, because it's saying a female dysphagia, regurgitation of food items. Anybody can actually misdiagnose this for HLHI cardia of the spastic variety. But then one of the highlights is chest pain will be very, very significant. And how to resolve the confusion? Well, you will do the investigation, and the investigation of choice for this condition will be not a barium swallow. It will not be a barium swallow. The investigation of choice for this condition is high resolution esophageal manometry, and he will himself mention what is the finding that is present here. Just like achalasia cardia question, it was mentioned regarding increased tone of the lower esophageal sphincter. Here he will say non-peristaltic contractions of the esophagus. I repeat my statement, if this kind of question is given to you, then the answer will depend on the final output that is given. Suppose he gives you a question in which he says lower esophageal sphincter tone is increased, then obviously the answer will not be the topic in spite of the history that is given, because I've explained to you that HLHI cardia of the spastic variety can also result in development of chest pain at rest in a patient. So if he says the word tone is more, then you will say spastic variety of HLHI cardia. But then specifically if he mentions the fact that it is non-peristaltic contractions, it is whole of the esophagus contracting together. If the word is non-peristaltic contractions, then the answer is the topic of interest, which is called as diffuse esophageal spasm. So read the question completely. Don't get biased only by the history of the patient. Question will be disguising each illness from the other. The predominant symptom of this patient is chest pain. But I told you, chest pain can be seen in spastic variety of cerebral spastic variety of HLHI cardia. So keep your patience and answer it accordingly. If he says the word tone of the sphincter is elevated, then you will say it is HLHI cardia. If he says non-peristaltic contractions, obviously diffuse esophageal spasm. For the management of this patient, it is mainly a medical management. And in medical management, what will we do? First, we will be giving anxiolytics for the patient. Anxiolytics because उसको लगता है कि मेरे को heart disease है, डॉक्टर सबसे diagnose नहीं हो रहा. You put it on yourself also. You're having chest pain and doctor is saying, no, your heart is fine. You will still be in doubt. Is this doctor good enough? Should I change the doctor? So this patient has been to he has been to two cardiologists, he has been to two gastroenterologists, and is showing you a lot of purchase, what are slips. And he says, I've been doing doctor shopping. He'll be admitting that I've been showing to different doctors. Max mein dikhaya, aise bola, Apollo mein dikhaya, aise bola. So the guy is gonna be like, a little nervous about the fact that he could be having heart disease. So we give anxiolytics, then we give long acting nitrates to these patients, that is isosorbide mononitrate. Normally we give isosorbide mononitrate to those patients who are having blockages in the coronary artery, but today we are giving isosorbide mononitrate not for any cardiac case, because you want to relax the smooth muscle of the esophagus. See, isosorbide mononitrate will act on the smooth muscle of the coronary artery also, but today there is no blockade. There is no blockade of the coronary artery, so it is isosorbide mononitrate acting on the smooth muscle of the esophagus, and the patient will feel better. And yeah, you can also be using calcium channel blocker in a patient, that is like amlodipine. So these are like the medical management that will be done in the patient. And meanwhile, just out of curiosity, I'm asking you, which antihypertensive drug has a side effect of pedal edema? Which antihypertensive drug causes reflex tachycardia and pedal edema? Options are ABCD: ACE inhibitor, beta blocker, calcium channel blocker, diuretics. The answer is amlodipine. Amlodipine has the side effect of contributing to pedal edema, so you have to do dose adjustment. It can also cause a development of reflex tachycardia. So when you're giving calcium channel blockers, you have to be a little careful regarding the dose that you're giving in this case, because of the ankle edema component that can come up. This entire slide is having overlap from surgery, that is carcinoma esophagus and diffuse esophageal spasm. So do read the surgery notes for this topic also, and esophagus is one topic that should never go wrong. And now I will discuss one more esophageal condition before you, where alcoholic has come with very severe vomiting and retching. There is also a development of chest pain in this patient. So the question says, what is the first differential diagnosis? There are three options in front of you: Mallory-Weiss, Boyer-Haave, and bleeding varices. So can I have quick comments? And meanwhile, I'll then start answering. No, decrease the dose of calcium channel blockers. Don't give diuretics. Decrease the dose. Yes. The main thing in this particular question to be understood is, I'm getting Mallory-Weiss as an answer also. Okay, I'm getting Mallory-Weiss as an answer also. Boyer-Haave is a more, okay, fine. So let's solve it. Mallory-Weiss cannot be the answer to the question, because Mallory-Weiss syndrome कैसे present करता है guys? Mallory-Weiss syndrome will always present with vomiting of blood. Is this question mentioning any vomiting of blood? No, it is vomiting, it is retching. I understand that vomiting and retching can result in development of tear, but here the question is not mentioning any vomiting of blood in a patient, so the answer is obviously not option number A in the patient. It is vomiting that is happening. It is self-limiting, that is okay, but Mallory-Weiss में तो blood का vomiting होता है, so answer is not point number 1. Bleeding esophageal varices will also present with hematemesis, vomiting of blood, so the answer will not be 3. The answer to this question is option number 2, that is Boyer-Haave syndrome. Why it is Boyer-Haave syndrome? Because the triad is getting satisfied. What is the triad in this condition? The triad is 1, there is a forceful vomiting in a patient. He's retching now, so forceful vomiting is happening. Because of this forceful vomiting, there is a rupture of the esophagus, there is a complete perforation of the esophagus, so there would be development of chest pain. And third that is given in this question is evidence of pneumomediastinum. How the pneumomediastinum can be given to you? Most of the time it will be a chest x-ray or an examination finding. Most of the time they will give you a x-ray, and in this x-ray you can notice that there is air. If I zoom into the diagram, you can see the shadow of air. This is the shadow of air below the heart of the patient. I'll remove it now. This is like the shadow of air below the heart of the patient, which is a cause of concern. So pneumomediastinum is present, because when esophagus will rupture, then obviously the rupture of the esophagus will cause air also to come. So pneumomediastinum would be present. There are two ways the examiner can mention the word pneumomediastinum. Like, he may not write the word pneumomediastinum, he may say subcutaneous emphysema. Or there is an X-ray finding, which Prashant has picked up very correctly. The X-ray chest finding of the patient is continuous diaphragm sign. So in a multiple choice question, you will notice that any of the two can be written. Either the question will use the word examination finding of subcutaneous emphysema, or he will say the word continuous diaphragm sign. These three things that have been picked up correctly by everybody is called as macular striate. So the point to be remembered is macular striate is the main pickup point for diagnosis of Boyer-Haave syndrome, where there is a complete through and through perforation of the esophagus. The contents would be spilling over into the chest cavity of the patient. A question to you guys again: what is the cause of chest pain here? There is no heart attack, na? Still the patient is having a chest pain. Yeah, the auscultatory finding is, yeah, Hamann sign is an auscultatory finding in pneumomediastinum. That can also be given. Yeah, the reason for development of chest pain is chemical mediastinitis, no? Sir, whatever alcohol he was consuming, saliva, sputum, food, whatever he was eating. So if he says in the question that what is the chest pain finding in a patient, then reason for chest pain, then the reason for chest pain in this patient is chemical mediastinitis, which will cause, like, excruciating chest pain, vomiting, and then pneumomediastinum. All the three things together, as answered correctly by almost all the people, is called as macular striate. One more question. You guys can comment here for this patient. What is the investigation of choice for this condition having perforation of the esophagus? The perforation of the esophagus in majority of cases will be in the lower one third and will be involving posteriorly. So it's a posterolateral tear. It's a posterolateral perforation that has occurred. The contents are spilling over into the peritoneal, into the mediastinal cavity. So what test will you do? Would you like to do a barium swallow? Would you like to do a CT chest? Or would you like to do CT chest with oral contrast? Okay, I'm having a good answer there. One of the correct answers is we will do a CT chest in a patient. No, we will not do endoscopy. एंडोस्कोपी तो नहीं करेंगे और बेरियम से केमिकल मीडियास्टिनाइटिस वर्सन हो जाएगा बिकॉज द कंटिन्यूटी ऑफ द esophagus is gone. So there is no role of like in this particular patient. I mean there is no role of doing a endoscopy because esophagus is gone. So you will have to do a CT chest. Now tell me, will you do CT chest with barium? So will you do CT with oral contrast? That is barium. Will you do CT with the IV contrast or will you do CT with gastrogeffen contrast? We will not give barium to the patient because it will worsen the chemical mediastinitis, but we can give water soluble contrast to the patient that is in the form of gastrogeffen. So the correct answer for this patient is we will do a CT scan. It is a CT chest, but along with CT chest, you need to remember what will we give to the patient. It is not barium, obviously, as you answered rightly. It is a gastrogeffen water soluble contrast that would be given to the patient. So the final answer is it is still a CT chest with oral contrast. It is still a CT chest with oral contrast that would be given to the patient. But yes, the contrast that would be used is a water soluble contrast and not barium because I don't want to worsen the chemical mediastinitis component. The surgery that will be done in this patient is a thoracotomy. It will be an emergency thoracotomy. We will have to open up the chest and then we have to repair the esophagus. You guys have to tell me from your surgery notes that will you be doing an emergency thoracotomy from the left side? Will you open the abdomen or right side? Is it in the options left-sided and right-sided thoracotomy? Both were given. We can open the chest from any side, but on the left side, if we try, then the problem is if we open from the left side, there would be aorta. No? Aorta tends to go more towards the left. Aorta blood vessel branches will be present. अगर हम लेफ्ट से खोलेंगे तो aorta और aorta की branches present होंगी तो उनके थ्रू navigate करके जाना पड़ेगा जो कि थोड़ा risky रहता है. So it is a right-sided thoracotomy. It is the right-sided thoracotomy that we will be doing in this patient. And along with that, obviously, that emergency repair of the tear that needs to be done. And obviously, as I think everybody is picked up correctly, except for a few people initially, like you got carried away by the term malarious. Alcoholic पढ़ के malarious नहीं सोचना है. अल्कोहलिक तो तीनों में लिखा होगा, मैलोरीवियस में भी, बोयराफ सिंड्रोम में भी और ब्लीडिंग इसोफेजियल वाराइसिस में भी. एंड वैसे भी मैलोरीवियस जो होता है उसमें तो टीयर होता है. I mean, what is the reason for development of malariviasis? It is actually a submucosal tear. It is a non-life threatening condition. Malarivius causes vomiting of blood and it causes submucosal tear. This submucosal tear का location बताओगे मुझे? From your surgery notes, please tell me what is the location of the tear in malarivius. Option दे देता हूँ. Stomach, lower esophageal sphincter. Single answer देना. Stomach, lower esophageal sphincter, esophagus. Is it the stomach? Is it the lower esophageal sphincter? Or is it the esophagus? Yeah, the tear is starting from the stomach and it is going to the lower esophageal sphincter. If we ask single best answer, then your answer is lower esophageal sphincter. वो बात ठीक है कि जो वॉमिटिंग होती है वो रिवर्स पेरिस्टाल्सिस होती है. फॉर दोज ऑफ यू हु हैव आंसर्ड esophagus, भाई tear is not in the esophagus. It is Boyraf syndrome where the perforation is कि फट गया पूरा का पूरा, transmural involvement. It's a partial thickness involvement here. It is starting from the cardia. It is involving the undersurface of the lower esophageal sphincter, and this is a self-limiting condition. So you don't need to give blood transfusion in most of the cases, and you don't need to most of the time we keep patients under observation also. So we'll send him. I mean we'll observe him for short duration and send him back home. If he says what is the source of bleeding in this particular case, the source of bleeding, yeah, it's a longitudinal tear. And if he says what is the source of bleeding, it is left gastric artery. My question is it does not connect because left gastric artery should cause life-threatening bleeding. Why is there a self-limiting illness then? If the source of bleeding is left gastric artery, it should kill the patient. Now the person is still alive after 24 hours. You're sending him back after 40 hours. So why are you why is it not life threatening? That is because the tear that is happening is in the superficial branches. It is not the main trunk. Like in peptic ulcer, it is the main trunk that would be affected. In this particular case, it is the superficial branches that are getting present. Yeah, they will heal, but it is superficial branches. No, it's not the main trunk of the artery. It is the superficial branches of the artery that are getting involved in this. Because submucosa में artery थोड़ी ना होती है. Artery तो नीचे होती है ना, near the matrix plexus के पास में. तो here तो it's like very far away from the submucosal area where the tear is actually present. No guys, terlipressin तो यहाँ देते हैं bleeding varices में. There is no role of terlipressin. I will teach you about terlipressin and octreotide in the later part of the discussion. Bleeding esophageal varices तो यहाँ पे दूर दूर तक नहीं है ना. Suppose I said vomiting of blood and the guy is having pedal edema or the guy is having caput medusae, then I would have thought in terms of bleeding varices in this patient. So terlipressin will come up only for bleeding esophageal varices. No role of terlipressin here. It is conservative management only and person will recover. So Mallory-Weiss is submucosal tear of the LES. The word is lower esophageal sphincter. It's not a through and through tear. It's a superficial tear. So superficial branches will get involved. Whereas Boyrov syndrome में तो esophagus पूरा फट जाता है. Spill over of the contents होता है. Spill over. That's the word to be remembered. Spill over of the contents, which is why such aggressive manifestations are present. And now I will discuss one more slide, which is on emergency situation, but obviously it's not related to the esophagus. We are going a little down, but these questions always come in the exam, and this is pneumoperitoneum. If you check out this slide, you will notice gas under the diaphragm. You can notice that mustache sign that is coming up here. So your interpretation of the X-ray is this is pneumoperitoneum. The radiological finding which is present here is either called as gas under the diaphragm. The radiological finding which is present here is called as gas under the diaphragm. Yeah. Or it will also be referred as mustache sign. So reverse mustache sign is a feature in heart failure. Reverse mustache sign is a feature in heart failure. This time it is not reverse mustache sign. It would be a simple mustache sign, or it can be like a cupola sign. The word is at least two names to be known as gas under the diaphragm and mustache sign are features of pneumoperitoneum. Yes. Rishi Karan just mentioned that MCQ that he gave this X-ray. He did not ask the interpretation. The question was not that what is the diagnosis, that to anybody can tell now that this is pneumoperitoneum. He said what is the reason for it. So the answer is perforation. It is a hollow viscous perforation. This was the question of the exam. They gave an X-ray. It was a spotter. He did not ask for diagnosis. That everybody could pick up. It is pneumoperitoneum. वो बोला क्यों होता है? Then the answer is hollow viscous perforation. Then it can be a two-step question. He will say why is it perforating? Why the hollow viscous perforation is occurring? Yes, guys, I agree to the fact it's a hollow viscous perforation. Why is it happening? Yes. Cause is duodenal ulcer. The hollow viscous perforation is occurring because of, no, not road traffic accident. It is duodenal ulcer. It is the ulcer in the first part of the duodenum that is perforating. Now, everybody to comment, is it anterior duodenal ulcer that is perforating or posterior duodenal ulcer that is perforating? Your answer of peptic ulcer disease is perfectly correct. My question is it anterior duodenal ulcer that will perforate or posterior? Posterior duodenal ulcers will be having high chances of bleeding because behind is the gastroduodenal artery. It is an anterior duodenal ulcer. It is an anterior location of the ulcer that is in the first part of the duodenum that will be perforating. And the reason why this ulcer occurs is because of the bacteria which the patient got from Golgappe wale bhaiya, that is H. pylori. So actually the cause is H. pylori causing duodenal ulcer in the first part anteriorly, and the duodenal ulcer was not managed by the patient. He did not take PPIs properly. That is why there is a hollow viscous perforation causing a pneumoperitoneum in the patient. In NEET PG, it was a two-step question. He asked, what will you do? I think this was repeated in FMG also, the last one. Exploratory laparotomy. And after that, because there is a perforation, so what we'll do is, we will be putting a omental patch. That omental patch is what is called as Graham's patch. There is a hole in the anterior part of the duodenum. Because of the hole in the anterior part of the duodenum, the surgeon will be using omentum. Omentum is the policeman of the intestine. That omentum of the intestine, that policeman of the intestine will be used for that Graham's patch there. Yes. So we spoke about Graham's steel murmur of severe pulmonary artery hypertension. But today it is gonna be omentum, which is used for sealing the tear which is present. So puncture laga rahe basically. Emergency laparotomy with Graham patch repair would be done. We'll do a laparotomy. We'll do saline lavage of the entire peritoneal cavity, remove all the acid and the contents which are spilling over, and then Graham's patch in the patient would be deployed. So this is the abdominal emergency that is usually asked in the exam. And now there is the second abdominal emergency that I'm covering here. This particular slide is covering 4 abdominal emergencies which are asked in the exam. Perforation of the esophagus, perforation of the duodenum. First was perforation of esophagus, second was perforation of the duodenum. And now there would be, yep, in this particular patient, you can see lot of dilated bubble loops which are present. But the bubble loops are not in the chest. Now, this is not a diaphragmatic hernia. Because diaphragmatic hernia, the bubble loops will be in the chest of the patient. Here you can see dilated bubble loops. Why? This is not CDH. This is not a congenital diaphragmatic hernia. The bubble loops are in the chest of the patient. So because this is the X-ray we are talking about, this is small bubble obstruction. It is multiple air fluid levels present. Even without history, you should be able to tell from this image. I'll mention the history for this question. The question began by describing that this is like a 20-year-old female. The reason why she's come to the hospital is because she's having colicky pain. The pain is spasmodic colicky pain. She's taking antispasmodics, but the pain is not going away. Along with colicky pain, there is also a development of bilious vomiting. Along with it is colicky pain with bilious vomiting, and lots of time these cold drinks etc. They are served with that liquid nitrogen. That liquid nitrogen can punch a hole. So 20-year-old female will be coming with colicky pain. There is a bilious vomiting that is present in this patient, and the doctor did a X-ray of the abdomen. When you check out the X-ray of the abdomen, you can notice multiple dilated bowel loops. There is multiple dilated bowel loops in a patient. If you look at the data here of multiple dilated bowel loops, that means that the person is having a clinical diagnosis of SBO, that is small bowel obstruction. Yeah, liquid nitrogen is that dry. Yeah, liquid nitrogen, dry ice, all those components are used, to make the drink that धुआं से निकल रहा था. So it is like small bowel obstruction which is present. Yes. Now comes the question. Actually, Nadeem has already answered it, so don't look at whether he's answered it correct or wrong. The question was, why is this lady having it? Why is this lady having it? Nadeem can be right, he can be wrong also. Yes, guys. What is the cause of small? The question was two-step. He did not say what is the diagnosis. Oh my God. Okay, the question is, why does the patient die in this case? Yeah, central valvular convergence. Okay, fine. Why is the person dying? Cause or death? Cause of manifestations. Death would be most of the time occurring due to, it can perforate subsequently, but the cause of death is adhesions. Yeah, cause of obstruction is adhesions. It can be bands, or sometimes it can be worms also. Usually it is round worms in India. Like they had mentioned an X-ray like this, and then they said that this patient was found to be having worms. Right, in the intraoperative picture that was given in the paper, you could see a lot of worms occluding the bowel. So I think you guys can give comment me the scientific name. Right, I'm talking about a worm that will be living in the small bowel, and it can result in physical obstruction in India, especially because of the poor hygiene component. Yes, it is Ascaris lumbricoides. So it is adhesions, it can be bands, it can be ascariasis, which could be responsible for this kind of a parasitic overload. The overload of parasite can result in this. The next question is having again abdominal emergency, and you can see the big hostrations. This is a large bowel obstruction. The question is beginning with a 60-year-old man. The reason why he's come to the hospital today is severe gross abdominal distension. वो कहता है पेट बिल्कुल फूल गया. It is not the pain that is bringing the patient to the hospital, it is gross abdominal distension. And then the patient is also having obstipation. That obstipation का मतलब होता है कि गैस नीचे से गैस भी पास नहीं हो रहा है. Can't pass flatus. Meaning of the word obstipation is that the patient cannot pass flatus. That means that there is something sinister going on with the large bowel. He might sometimes even mention that this patient is having history of constipation. If an old man is having history of constipation, no big deal. Constipation can be a normal finding in old people also. But yeah, if the constipation is very severe, then it's a cause of concern, and it's non-responsive to laxatives, like I'm writing here, that constipation is severe, it is non-responsive to laxatives. That means there must be some fungating mass which is causing issues in the patient. Then the question will give X-ray findings in this patient. In the X-ray, you can notice big hosterations. In the X-ray, you can notice hosterations. You can notice dilated bowel loops. The clinical diagnosis of this particular patient will be given as LBO, and it will again be a two-step question. He will not say that, okay, this is large bowel obstruction. Obviously, this we can tell. The main aspect is why this guy is having a large bowel obstruction. The question is, why is he having a large bowel obstruction? Yes, guys, why is he having a large bowel obstruction? Some people have already answered. It is a query malignancy. It could be most of the time a colorectal cancer, which is responsible for this manifestation. Obviously, other causes for this can be like sigmoid volvulus, but then sigmoid volvulus will not have a long history, or it will not have history of constipation. It would be like very fast management. It is malignancy. Most of the time it is colorectal cancer that needs to be basically evaluated. So we can do a like a carcinomembranous antigen levels. We can go for Duke staging to evaluate for the colorectal cancer that is usually spread to the liver by the time the diagnosis is made. What I've done at the moment is discuss before you questions where like abdominal emergencies are given, which is one esophageal perforation. Next one is peptic ulcer perforation, then is SBO, then is LBO. And at the bottom, I will mention something that you guys are, yeah, X-ray once again. Okay. First X-ray that is shown to you is showing pneumomediastinum. हवा दिखाई दे रहा है, so X-ray shows pneumomediastinum. Yeah, now better. Pneumomediastinum. If you compare the first X-ray where there's a perforation of the esophagus with the second one, you will notice gas below the diaphragm. Here the problem is not at the level of the heart, the problem is below the heart. So this is gonna be a manifestation of, yeah, they can mention indirectly as abdominal surgery. This is gas under the diaphragm, below the diaphragm. Then is gonna be multiple dilated bowel loops present. And the last is where, yeah, trichophagy, yeah, hair consumption can be possible, can be a cause for it. And then is LBO, that is large bowel obstruction. Abdominal emergencies are always asked in the exam in the GI. Usually at least 1 to 2 X-rays would be present. And now to finish this at nearby page number 133, I will write 2 more questions for you and you know the answer. When I will ask you, then please comment. This is day 2 of life. It is a newborn baby. He's having bilious vomiting. And the doctor was able to count 2 bubbles present there. Considering that the X-ray abdomen is showing presence of 2 bubbles, so our interpretation in that would be a duodenal atresia. My question comes now, what is the surgery that is done for double bubble sign? What is the surgery done for duodenal atresia? Option number A is, will you be doing a duodenostomy or would you be doing is a duodenojejunectomy? You have to comment in the chat box double D, DD or DJ. Yeah, duodenal atresia. That is not the comment that I'm asking. I'm saying what is the treatment for this patient? What is the surgery that is done in this patient? Either you will comment the word DD or you will comment in the chat box DJ. Okay, most people have answered the word DJ. Please check out your notes again. We don't do DJ now. Nowadays, the surgery that is done for this condition is not DJ. It is DD that is done. It is duodenostomy that will be done in this patient. Sir, it is not a DJ. It's a common error that happened in the paper. I think this should not be happening. So it is DD followed by DJ. Obviously, both procedures are done, but you have to give a single best answer in the question. The second is X-ray abdomen showing a triple bubble appearance. Obviously, the answer in this particular case would be a jejunal atresia. Our answer would be a GA, that is a JA, that is a jejunal atresia in a patient. So you have to comment on the surgery for this patient. And if you will not comment on the surgery, then it is subsequently like, you have to like, yes, you can comment in the chat box even at the end of the class from your surgery notes also. Surgery that is done for jejunal atresia. Okay. हाँ, क्योंकि सिली मिस्टेक्स होते हैं ना, हम ओवर एस्टिमेट करते हैं अपने आप को. व्हाट इज द सर्जरी डन फॉर जजनल अट्रेसिया? लिविंग इट ब्लैंक एट द मोमेंट. माय सजेशन इज कि आपने सर्जरी में तो बहुत सारी ये चीज़ें पढ़ी हैं, राइट? तो ये वाले क्वेश्चंस बिल्कुल भी गलत नहीं होने चाहिए थे. मतलब इसमें जो भी, अगर मैं एक भी पॉइंट, मेरा 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 स्टेटमेंट है, इफ इवन वन पॉइंट ऑन दिस पर्टिकुलर स्लाइड इज गोइंग रॉन्ग, if even one point on this slide is going wrong, that means GI has not been studied well. GI is not to be studied 2 times. It's only once in your life, and whole maximum 3 pages, whole of patho, whole of surgery and whole of medicine should be over. There is no point of reading GI topic again and again. I mean, esophageal disorders, and then we were discussing like, Lymer's triangle Ankylian's triangle, silly mistakes were happening. I mean, esophagus कैसे गलत कर सकते हो यार? मैं कहता हूँ बाकी सारे में माफी है कि you can say that I messed up, or like I did not remember. Esophageal disorders, I want to say they have to be foolproof, because if somebody will make a mistake in esophageal, then obviously later part of the GI part will obviously be having mistakes. So please read this, take this up seriously. I mean, whatever suggestions that I give you, they tell that either it's a underperformance or a average performance. So for the esophageal in the GI part, the topic everybody is assuming हाँ सर बहुत आसान है, राइट, बट आसान में गलतियां ज्यादा होती हैं, बिकॉज यू लेट योर गार्ड डाउन ना, यू लेट योर गार्ड डाउन। तो आप आज क्या करना, पहले जीआई को मेडिसिन से नहीं पढ़ना, पहले सर्जरी से पढ़ना, फास्ट फास्ट। उसमें क्या करना है, सारे डिजीज का नाम लिख के उसका इन्वेस्टिगेशन और चॉइस लिखना है। आधे लोग तो उसी पे गलत कर देते हैं। जैसे बेरियम स्वालो सिर्फ 2 जगह पे आंसर होता है। बेरियम स्वालो इज आंसर ओनली 2 times. One is obviously the topic that I mentioned here, right? Barium swallow is an answer only 2 times. One I mentioned, barium swallow will be done for diffuse. और इसको आज खत्म कर देना, मतलब राइट इट एंड जस्ट गेट ओवर विद द मंकी, राइट, गेट द मंकी ऑफ माई बैक वाली बात है। उसको अपने बैगेज में मत रखना, इमोशनल बैगेज इज वेरी डिफिकल्ट टू हैंडल, राइट। At this particular point of time, additional point, I'll please come to page number 163, pseudo achalasia के नीचे, because couple of errors also happened, so I just wanted to add couple of points there. Pseudo achalasia cardia, as I explained to you, would be related to carcinoma stomach in the patient. There are only, आप क्या करना, सारे conditions का नाम लिखना, achalasia cardia से शुरू होके, and then write down the investigation of choice and surgery of choice or treatment of choice for it. That is step 1, right? Investigation choice. अगर investigation choice और surgery choice आता तो बाकी सब कुछ आता। Barium swallow is answer for 2 MCQs in GI. One is for Zenker diverticulum that we had studied earlier, and the second one is I gave lot of time as prompts also. This would be a surgical topic by the name of hiatus hernia. हाँ बेटा देखो, लास्ट ईयर जो हो गया उसका तो कुछ नहीं कर सकते ना, whatever, there is no point of crying over spilled milk ना, लेकिन अभी तो आपको पता है ना कि क्या कमी है, तो आप उसके ऊपर टाइम लगाओगे ना। द लेट नाइट आवर्स दैट यू विल बी पुटिंग इज, आप नोट्स में एचएलएस कार्डिया अंडरलाइन नहीं करना है, आपने बीमारी का रजिस्टर में लिखना, कॉज, प्रेजेंटेशन, IOC and the treatment of choice for the patient for all the conditions of the GI that you write 1 2 3 4 5, हार्डली 25-30 ही तो है, मैक्सिमम 30 तो बहुत ज़्यादा हो रहा है, मैक्सिमम 25 ही हो गएगा, आधे तो कैंसर ही हो जाएंगे, बायोप्सी आंसर हो जाएगा। Hiatus hernias are 2 types, rolling hernia, and the second one is that sliding hernia. So read about these also. I mean, these are surgical topics which I'll not be going in at this particular point of time, but I just wanted to give you a heads up with respect to the common diseases which can usually go wrong. I'll just do one more activity here and then I'll move to my next slide. My question is, what is the drug of choice for Crohn's disease? एवरीबडी नोज रिगार्डिंग कॉबलस्टोन म्यूकोजा, मुझे उसको दोबारा बोलने की जरूरत नहीं है, ट्रांसम्यूरल इन्वॉल्वमेंट एंड ऑल दोस थिंग्स दैट यू स्टडी इन पैथोलॉजी। क्रॉन्स डिजीज इन्वॉल्व्स द आइलियम, टर्मिनल आइलियम, सो पैथोलॉजी के पॉइंट को रिवाइज करने का पॉइंट नहीं है। देयर आर 2 क्वेश्चंस दैट आई एम पुटिंग बिफोर यू, वन इज इन्वेस्टिगेशन ऑफ चॉइस फॉर क्रॉन्स डिजीज एंड सेकंड इज द ड्रग ऑफ चॉइस फॉर क्रॉन्स डिजीज। सो प्लीज गिव मी क्विक आंसर्स, क्रॉन्स डिजीज का IOC एंड ड्रग ऑफ चॉइस। द कंडीशन विल बी हैविंग, ओके फाइन, वेरी गुड। चलो मैं ऑप्शन लिखता हूँ फिर। आई विल बी राइटिंग ऑप्शंस इन द फर्स्ट वन। वन इज ब्यूडेसोनाइड प्रिपरेशन, वन इज prednisolone, then is mesalamine. The next drug that I'm writing is mesalamine, and one I can write a monoclonal antibody by the name of infliximab. You have to do voting for this one. 1 is budesonide, 2 is prednisolone, 3 is mesalamine, and then is infliximab. Yes guys, which of the following is the drug of choice for management of patients of Crohn's disease? Okay, waiting for your comments there. Okay, so I'm getting all kind of comments here. Guys, the drug of choice for management of this condition is budesonide. The drug of choice for management of this condition is budesonide. We have a special ileal release preparation. Budesonide के लिए we have is what is called as a ileal release preparation that will treat, because most common site involved is the ileum in the patient. What is the investigation of choice for this patient? या अभी अल्सरेटिव कोलाइटिस भी पूछूंगा भाई, मैंने आपसे पूछना है, आप मुझसे क्यों पूछ रहे हो? अल्सरेटिव कोलाइटिस एंड क्रॉन्स थोड़ी ना, मतलब जो पॉइंट्स है वो मतलब हम क्वेरी में चैट में थोड़ी ना डालेंगे कि इसका ट्रीटमेंट क्या होता है. दैट इज व्हाट आई विल बी आस्किंग यू. Yes, yes. What is the investigational choice for Crohn's disease? Colonoscopy. Okay. Will you be able to reach the ileum with colonoscopy? Will you be able to reach the ileum with colonoscopy? No, na. You will hardly reach the cecum. So, what is the investigational choice? Yes, it is wireless capsule endoscopy. The investigational choice for this condition is WCE, wireless capsule endoscopy. If this is not given in the options, the answer is MR enterography. We will do MRI because it is best for soft tissues. We will make the patient drink the contrast, and then we can scan the intestine for multiple strictures. The hallmark of Crohn's disease, the hallmark feature of Crohn's disease, if he says single best answer for hallmark feature of Crohn's disease, then it is development of fistulas. If he says what is the hallmark feature of Crohn's disease, it will be development of perianal fistulas. Poor hygiene will be present. Perianal fistulas should be answered as it is not a feature of it is not a feature that is seen in patients of ulcerative colitis. 3 must know MCQs for Crohn's disease are, हम इतना सारा पढ़ते हैं Crohn's disease, तीन क्वेश्चन जो वो पूछता है वो है कि व्हाट इज द हॉलमार्क क्लिनिकल फीचर विच इज गोना डिफरेंशिएटेड क्लिनिकली फ्रॉम अल्सरेटिव कोलाइटिस इज पेरिएनल फिस्टुला. What is the investigation choice for Crohn's disease? It is wireless capsule endoscopy followed by MR enterography, and the drug of choice for the patient is budesonide ileal release preparation. Crohn's is a full stack, full transmural involvement. Whole of the intestine is involved. The only part of the intestine that is spared is the rectum of the patient. But yeah, the disease starts from the ileocolic area. Ileum is the most common site involved. Crohn's starts from damaging the ileum. So you can be having B12 deficiency in the patient. You could be having bile acid diarrhea because bile acids are for emulsification of fat, they're absorbed from the ileum. So you could be having a bile acid diarrhea present, but it will always be skip lesions that would be seen on MR enterography. Instead of skip lesion, first I would like to write the word strictures, because जो दिखाई देता है वो तो stricture होता है, and between the strictures, like it is segmental, like कुछ centimeter normal, stricture, normal, normal, stricture, normal, stricture, normal, stricture. So that is why we say skip lesions word. So that is what pathologist will be saying. But the core information is multiple strictures all through the length of the intestine is the main way for diagnosis of Crohn's disease in a patient. 3 very standard questions are what I have highlighted for this condition. Now I will be writing regarding ulcerative colitis the same thing. Ulcerative colitis जो disease होता है उसकी खासियत ये होती है कि ulcerative colitis में only the rectum is predominantly the rectum is involved. Rectum is usually spared in Crohn's disease, but rectum की जो involvement होती है वो ulcerative colitis में predominant होती है. Biopsy for Crohn's, no, if it says granulomatous versus non-granulomatous colitis. Suppose he says to you granulomatous colitis, it is Crohn's. So if you want to check for non-gazetic granulomas now, because Crohn's will be having non-gazetic granulomas, so only then the biopsy part would be answered, or for suspected malignancy. Wireless endoscopy for differentiating ulcerative colitis and Crohn's. Yes, absolutely. When the capsule will migrate, it will pick up the lesions only in the large bowel, and it will be contiguous involvement. There would be no normal areas that are present. Wireless capsule, when it will travel through, will be able to scan through the small and the large intestine. But my point is, why do you want to do a wireless capsule endoscopy when small intestine is not involved? Wireless capsule endoscopy is used to scan the jejunum and the ileum, which cannot be reached by conventional endoscope. जब आप endoscopy करते हो तो endoscope कहाँ तक जाता है? Fourth part of duodenum. Jejunum में तो आप गए ही नहीं, ileum में भी नहीं गए, और disease तो वहाँ पे बैठा हुआ है. That is why we did a wireless capsule endoscopy. If you do endoscopy, you can reach max up to the fourth part of duodenum. You can't reach the jejunum, you can't reach the ileum. That is where the disease is sitting. So we did a wireless capsule endoscopy. But in ulcerative colitis, the disease is only in the large bowel. If disease is only in the large bowel, then I don't need to scan the small bowel. Your answer is right. Your question is apt that, can I use a wireless capsule endoscopy to differentiate? Yes, I can, because lesions will be only in the large intestine. That is differentiation. But if he says what is the investigation choice, it is colonoscopy. In this colonoscopy, you will be having contiguous involvement.
rectosigmoid. Then from rectosigmoid, the disease will be involving, like it will start from the rectum, then the sigmoid colon, then the descending colon, then the transverse colon. So it will go in a contiguous fashion, in a retrograde fashion. And here a question that I want to put up, though this is from the surgery part only. He said, what score is done to evaluate the severity of ulcerative colitis? Yeah, backwash ileitis, exactly. Yeah, we'll write down the drug of choice. Pranav, before that, what score is used to test for severity of ulcerative colitis? Because patient could be having 4 stools in blood, it could be 6 stools with blood, there could be fever, there could be anemia, there could be tachycardia, there could be elevated ESR. Acute phase reactants are always elevated in these patients. Yes, true love, hard to find nowadays, and Witt's criteria. That is why it's written true love and Witt's, because it is hard to find. So true love and Witt's criteria is a scoring pattern that is used to evaluate for the severity of ulcerative colitis, and the drug of choice for this condition as of now is to be answered as yes. Can you comment on the drug of choice? Some people have already done that. Some people already done that. What is the drug of choice? Yeah, the answer is changed. It is not sulfasalazine. Sir, I have been teaching this for almost 2 years now, and I hope other teachers have also, you know, they should have copied by this time at least. The answer for this is not sulfasalazine, it is mesalamine, which is given for this patient. Along with mesalamine, we will be giving steroid enemas for these patients. It is mesalamine and it is budesonide. The reason why they have discontinued sulfasalazine is because of the side effects that are seen with the medicine. What I have covered here is the core MCQs that you should be remembering for this particular topic of Crohn's and ulcerative colitis. None of these questions should ever go wrong. So I came back to this slide to invest time into the IBD component, where there would be blood in the stool. We don't have blood in the stool in inflammatory, we don't have blood in the stool in irritable bowel syndrome. We don't have elevated ESR. We don't have like elevated ESR and positive CRP in दोनों conditions में in IBD. I mean, what is the differentiating features here? IBD will always be having like low grade fever present. In IBD, there would be mention of bleeding, that is blood in the stool. Then ESR can be elevated, CRP can be positive, acute phase reactants can always be there in these patients. Can you tell me a stool test? Last question on this topic and we move on to the liver. Can you tell me a stool test by which you can identify, especially the presence of, yes guys, I'm waiting, stool test. And if I say anything more, the diagnosis will become very obvious. Any stool test that you have read by which you can differentiate between ulcerative colitis and Crohn's disease? Yes, more people please. Some people have started commenting. Yes, stool or fecal. Lactoferrin. Okay. Instead of lactoferrin, can I have a better answer? It came up. Yashika, you were right. I understood what you said. No, beta, it is not lactoferrin. No, it is not procalcitonin. Yashika, you were right? Calprotectin, no? Yeah, Sai Rohit is right. It is stool or fecal calprotectin. Yes, stool or fecal calprotectin is a test that would help you in differentiating. ये जो test है, this would help you differentiating IBD versus IBS in the patient, that is irritable bowel syndrome in a patient, that is a stool calprotectin levels. IBS can never ever be confused यार. IBS में तो क्या होता है, वो कहता है बार बार वॉशरूम जाना पड़ता है, लंच खाया थोड़ी देर बाद वॉशरूम जाना पड़ रहा है. जैसे लंच खाता है तो उसके पेट में दर्द होती है, कहता है मुझे लगता है पेट में गैस भर गई है, आई गो टू द वॉशरूम, ही पासेस लॉट ऑफ फ्लैटस, little bit of fecal matter. He'll come back again after some time, again he will go to washroom, again flatus and little bit of fecal matter. So person will go again and again, and sometimes diarrhea can be there, sometimes constipation can be there. That is called as irritable bowel syndrome. That is only seen in most of the time young patients who are having anxiety. Because young people, anxious people will also do lot of aerophagia. They keep on swallowing the air. तो पेट में वैसी गैस हो जाती है, कहते हैं सारा दिन बैठ के इससे पढ़ना है और साथ में टेंशन भी है, हाइपर वेंटिलेशन भी है. तो बीच में अगर आदमी एरोफेजिया टेंशन से हाइपर वेंटिलेट करेगा तो देन इट विल कॉज स्टमक डिस्टेंशन, दैट विल कॉज द पर्सन टू फील एज इफ द बबल इज फुल. व्हेन पर्सन विल गो ईदर वेरी लेस फीकल मैटर little bit of fecal matter with some gas will pass. Patient will say I'm better. Then again the same thing will be represented in this patient. So the point to be understood is simply that IBS is like a functional disorder. There is nothing wrong with these patients. It is just a mind orientation that has to be done. Though we give, I mean, obviously when they come to us, they will, if you say to somebody, no, that आपको mind में stress है इसलिए IBS होता है, तो बुरा मनाते हैं, अरे यार ऐसे थोड़ी ना होता है, हमें दिक्कत है, आप समझ नहीं रहे हो. So you have to give, like, you have to give agents, especially for constipation, for diarrhea. You might have to give probiotics, prebiotics to this patient. But what actually works is mind orientation. Yes. No, you don't need to give medicines to these people at all. Your way of talking should be such that you tell them that there is nothing wrong with them. Gradually, अपने सब ठीक हो जाता. You need to build their confidence levels. लाइफ में स्ट्रेस तो सबके होता है यार. लाइफ में स्ट्रेस तो सबके होता है ना भाई. हर किसी को जिंदगी में, हर किसी को कोई ना कोई एग्जाम निकालना है यार. इंडिया में तो मैंने बोला ना, बच्चे पढ़ने वाले उन्हें कोई ना कोई एग्जाम का स्ट्रेस होता है. ऑल इंडियन हैव सम काइंड ऑफ स्ट्रेस. जिसका एग्जाम निकल गया उसे इंटर्नशिप का स्ट्रेस है, इंटर्नशिप के पीजी का स्ट्रेस है, पीजी के सुपर स्पेशलिटी का स्ट्रेस है. मैं तो मेडिकल का बोल रहा हूँ. मेडिकल के सिवा देखो ना, वहाँ तो और भी ज़्यादा होता है. या फाइबर रिच फूड, फॉड मैप्स, यस यस यस, फॉड मैप्स. कुछ नहीं यार, सबसे पहले स्ट्रेस कम लिया करो. मतलब देखो, स्ट्रेस सबको होता है. मैं तो बस यही कहना चाहता हूँ कि रूमिनेटिंग ओवर व्हाट विल हैपन की जगह पे ना, व्हाट यू कैन डू. मेरा तो एक ही मैसेज होता है सबको. अगर आपको लाइफ में, मतलब देखो, डॉक्टर की लाइफ ना बड़ी स्ट्रेसफुल होती है, और हर डॉक्टर के पीछे कहानी होती है. हर डॉक्टर के ऊपर एक मूवी बन सकती है ना, उसकी स्ट्रगल्स के ऊपर में एक मूवी बन सकती है. क्योंकि 19 सब्जेक्ट्स पढ़ने होते हैं, कोई छोटी मोटी बात नहीं होती है. सो यू गाइस शुड बी प्राउड ऑफ योर सेल्फ दैट यू आर एंड्योरिंग. हाँ, मैरिज अलग से नया फंडा है, पेरेंट्स चलते हैं. What I'm trying to tell you guys is 19 सब्जेक्ट्स पढ़ना कोई छोटी मोटी बात नहीं है. सो यू गाइस हैव टू बी प्राउड ऑफ योर, नॉट दैट एटीट्यूड वाली बात बोल रहा हूँ. यू हैव टू प्राउड ऑफ योरसेल्फ कि यार आपने जिंदगी में कुछ ऐसा किया जो बाकी लोगों की बस की नहीं है. ये मेरी वर्ड ध्यान रखना, तुमने वो बात काम किया है जो बाकियों के बस की नहीं है. 19 सब्जेक्ट्स पढ़ना है ना. लोग बोलते तुमने सिर्फ MBBS किया है, तुमने ये किया, तुमने वो किया. भाई इतने पढ़ने में जान लग जाती है. तो फर्स्ट बी प्राउड ऑफ द फैक्ट कि आपने कुछ किया. एंड नाउ माई सेकेंड एडवाइस इज वेरी सिंपल यार, कि देखो एट द एंड ऑफ द डे यू हैव टू डू एक्शन. एक्शन इज प्रोएक्टिव. यहाँ पे कितने सारे होते हैं जो आते हैं, छोड़ के चले जाते हैं, बीच में कुछ कर लिया. अगर आप सर सीक बटन से आगे पीछे वीडियो को कर रहे हो, मतलब गेम ओवर. बिलीव मी, अगर आप कोई भी वीडियो लेक्चर देख रहे हो और आप उसमें आगे पीछे कर रहे हो ना, और आपको समझ में नहीं आ रहा है, इसका मतलब है आप ध्यान से सुन नहीं रहे हो, आपका माइंड तो कहीं और है. You are imagining that you are studying, but you are really not actually studying. Study has to be one time at 1x, 1.5, 1. Whichever speed you are comfortable है. 2x पे तो कुछ समझ में नहीं आता, तो वो तो illusion है. But if you are doing 1.2, 1.5, whatever, you have to listen only once with care. एक बारी पढ़ो, ध्यान से पढ़ो. That is the only mantra. That is the only thing that works here, guys. That's the only thing that works. And execution every single day. Like I'm happy that you guys are showing up even today, ना. नॉर्मली क्या होता है कि भाई एज डेज पास बाय, हाँ ठीक है यार बाद में देख लेंगे, रिकॉर्डेड लेक्चर पढ़ा है ना, देख लेंगे वहाँ पे. इतने पढ़े वीडियो लेक्चर, इतनी तुम्हारे पास ऐप है, 500-500 रुपये में तो वैसे ही कॉपी करके बेच रहे हैं लोग, है ना. वैसे ही वो पाकिस्तान वाले जो है उन्होंने, है ना, सारा सर्वर से डाउनलोड मार लिया डेटा, आजम सर का और बाकी सारा भी हमारा वाला ना. मेरे वीडियो मुझे बेच रहे. मुझे मैसेज आ रहा है, डू यू वांट प्रेप लेटर वीडियो लेक्चर. मैं कहा किसके देगा, तो कह रहा है डॉक्टर मारवा वीडियो लेक्चर्स. मैं कितने का देखा, कह रहा 300 रुपये. तो मैं सिर पकड़ लिया कि भाई. Right, so it's a crazy world out there, right? I think you are aware, right? That there's this guy, मैं नाम भूल गया यार उसका. I think he's a doctor only. He has very good technical skills. वो कॉपी मार लेता है डेटा का, है ना. अफरा तफरी. तो अफरा तफरी जो है, हाँ मुझे पता है, वो देखते हैं यार मेरा. अफरा तफरी ने क्या करा कि उसने सारे वीडियो सर्वर पे जाके हैक मार लिया. नहीं लगा रखी थी सिक्योरिटी उन्होंने, तो उससे किसी को नहीं छोड़ा यार, सारे वीडियोस के डाल दिए. तो पॉइंट है कि वो VPN हम ट्रैक करते हैं, VPN से लॉग इन करते हैं, तो भाई कहाँ से हो जाएगा. तो चलो कोई बात नहीं, ये तो चलता रहता है. यस. चलो जी, फाइन. लेट्स गेट बैक टू स्टडीज. तो लाइफ में चलता रहेगा. देखो यार, व्हेन यू विल डू समथिंग गुड, तो यू डोंट नीड टू वरी अबाउट बैड थिंग्स दैट आर हैपनिंग. मैं तो ये जानता हूँ, है ना. कर्मा कैचेज अप इन द सेम. इलीगल पैसा कभी किसी को ना डाइजेस्ट नहीं होता. तो इट इज लाइक आप कर भी लेगा, कितने कमा लेगा यार. Fine guys, okay ji, fine. Let's move on to the next one. What I will discuss next before you, please come to page number 167 and we will talk about liver topic. You guys need to do the talking in this particular patient. Most common cause of acute viral hepatitis. Options are A, B, C, D, E, and I would expect you to comment in this particular case. Yes, yes. अरे ऐसी तू सर्च करेगा मिल जाएगा यार, उसमें क्या है. Yes. हाँ, मैं वही तो बोल रहा हूँ भाई. रिकॉर्डेड में क्या होता है, रिकॉर्डेड इज अ गुड वन. देखो ऐसा नहीं है, पढ़ने वाले तो रिकॉर्डेड भी पढ़ते हैं. बट व्हाट आई एम ट्राइंग टू टेल यू इज कि वो डाउनलोडेड वीडियो है, कोई 300-500 में खरीद के ना वो कभी नहीं पड़ेगा उसको. कलेक्शन कलेक्टर आइटम है, वो कलेक्शन कर रहे हैं. 4 ऐप खरीद लिए हमने 1200 रुपये में. तो पढ़ोगे कैसे भाई, है ना. एक ऐप में 600 घंटे का डेटा है. 600 इंटू 2400 आवर्स. यहाँ यार 60 घंटे पढ़ने में 60 मिनट्स में आपको पढ़ाता हूँ, तो 60 मिनट के बाद में लोग ड्रॉप आउट हो जाते हैं. खुद से करना यार, इट्स नॉट पॉसिबल. हाँ हाँ, अफरा तफरी में चले जाओ, मिल जाएगा यार, उसमें क्या. ध्यान से जाना, ऐसा ना हो तुम्हारा कंप्यूटर हैक हो जाए. देख लेना उसमें ट्रैकर लगा हुआ है. अगर तुम्हारे पास में वो नहीं है ना तुम्हारी वेबसाइट में, जैसे मैं गया लैपटॉप पे तो मेरी स्क्रीन रेड हो गई एकदम से, राइट, बिकॉज उसमें ट्रैकर लगा हुआ है. तो दे ट्रैक योर. उसमें तुम्हारा ये भी हो सकता है कि इफ़ यू पुट डेटा ना, अगर कोड वर्ड डालोगे तो तुम्हारी फिनेंशियल अगर तुम करते हो ट्रांजैक्शंस वगैरह, तो उस डिवाइस से मत कर लेना कहीं पे. लाइक यूज अ सेपरेट डिवाइस अगर करना भी है इस टाइप का काम. ऑलवेज कैरी अ सेपरेट फोन फॉर दैट. ऐसा ना हो कि जिसमें तुम्हारा बैंक अकाउंट है, क्रेडिट कार्ड डिटेल्स है, वही फोन यूज कर लिया, वो रेट्रोस्पेक्टिवली तुम्हारे कार्ड का सारा डेटा खाली हो जाएगा. कार्ड का डेटा खाली हो जाएगा सर जी, अगर आपने वो वेबसाइट पे जाके करोगे ना इस तरीके से. तो इट्स नॉट सो सिंपल सर, दिस गाइस आर वेरी स्मार्ट. या चलो चलो, कमिंग कमिंग बैक टू द एजेंडा. सो बी केयरफुल गाइस. आजकल साइबर वाला जो है ना बहुत तेज है सर. वो एक बार आपके डिवाइस में घुस गया सर, किसी भी उससे आपने कोई भी लिंक कर लिया, तो आप कुछ भी कर लो, आपकी डेटा मॉनिटरिंग होती रहेगी. आपके सारे पासवर्ड स्टोर होते रहते हैं उनके पास में, क्योंकि वो डाल देता है ना, वो वाला जो आपका की लॉगर होता है, कीपैड लॉगर. So with the keypad logger, they have all the access of whatever you're doing on your device. Chalo guys, what is the most common cause of acute viral hepatitis? Coming back to the agenda. Yes. What is overall? Yes, yes guys. Most common cause of पढ़ाई करो. Most common cause of acute viral hepatitis is hepatitis E virus. Here the answer is not hepatitis A beta. The answer is not hepatitis A virus. Hepatitis A virus is the answer for children. Hepatitis A virus is the answer for children. Your answer in this case would be hepatitis E virus is the leading cause of acute viral hepatitis. Then is which virus will be having the highest chance of progression to chronicity? Answer for this is hepatitis C virus. But if I change the language of the question, that what is the most common cause of chronic viral hepatitis, then most common cause of chronic viral hepatitis is hepatitis B. The most common cause of chronic viral hepatitis is hepatitis B. ये आपके पैथो के नोट्स में गलत दिया हुआ है. नॉट क्रिटिसाइजिंग. मुझे पता तुम एकदम से डिफेंड करने आ जाओगे, सर आपने ऐसा कैसे बोल दिया, मैम को ऐसे कैसे बोल दिया. भाई यू नो, कई बात ऐसी होती है जो टेक्निकल हम ही समझ सकते हैं, वो फिर पैथोलॉजिस्ट नहीं समझ सकते हैं. एक है टोटल नंबर ऑफ केसेस. मुझे पता तुम लड़ने आ जाओगे, अरे सर आपने ऐसे कैसे बोल दिया मैडम को. सो टोटल नंबर ऑफ केसेस जो है, एक है टोटल नंबर ऑफ केसेस इन द वर्ल्ड. सो इफ ही सेज टोटल नंबर ऑफ केसेस, देन if I take into consideration the total number of cases, then it is hepatitis B. But I wish is not there. But if it says chances of progression to chronicity, then it is hepatitis C. This is the data to be remembered, guys. This is the data to be remembered. हो सकता है वो मतलब आ गया हो, अभी नए वर्जन में करेक्ट हो गया हो. मतलब what last time some students sent me a photo की सर आपने ऐसे बोला था, मैम ने ये बोला था, तो क्या सही है. तो ऐसा नहीं यार, वो हर सब्जेक्ट के देखो, मैम इज वेरी गुड एट स्लाइड्स ना. तो वो डेटा वाले पॉइंट में कई बार होता है कि भाई वी वुड बी मोर स्ट्रॉन्गर, है ना. तो एवरी सब्जेक्ट हैज इट्स प्रॉन्स एंड कॉन्स एंड एवरीबॉडी इज गुड एट सम ऑफ द डेटा. तो ये डेटा वाला है. तो द डेटा इन दिस पर्टिकुलर केसेस टोटल नंबर ऑफ केसेस. बेटा ध्यान से समझ भी लो ना, चिट चैट तो चलती रहेगी, सुनो भी तो सही ध्यान से मैं क्या समझा रहा हूँ. एक है नंबर ऑफ केसेस. जैसे इंडिया एंड चाइना आर द बिगेस्ट रिजर्वायर्स ऑफ हेपेटाइटिस बी इन द वर्ल्ड. सो मैक्स जो केसेस मिलते हैं जिनको लिवर खराब हो जाता है वायरस हेपेटाइटिस से, दोज आर बेसिकली गोना बी हेपेटाइटिस बी के केसेस. बट वन इज कौन से वायरस के साथ में ज्यादा ताकत है क्रॉनिक में जाने की. जैसे हेपेटाइटिस सी इज मोर कॉमन इन यूरोप एंड अमेरिका, एंड बी इज मोर कॉमन. इंडिया हैज मोर पॉपुलेशन, China has more population, so max number of cases that are seen are hepatitis B virus. But एक है कि कौन से वायरस में ज्यादा ताकत है, क्षमता है, virulence है, right? Get my point? Capacity to get converted into chronic, that is gonna be the C virus. So that is the basic difference which is present in this patient. Yes, Anjali, this is the standard data. Hepatitis B is a condition which is very prevalent in Southeast Asia. C something that is common in Europe. So more cases are B virus, and when it says किस में ज्यादा क्षमता है chronic करने की, then it is the C virus. और मैं एक और बात बोलूंगा which I will move down in the slide, and I would like you to appreciate that hepatitis B is not really so dangerous. It is media that makes it so dangerous. Harrison says 90% cases of hepatitis B अपने आप से ठीक हो जाते हैं. Their jaundice will go away. They will not come for follow-up visits. आपके रिसेप्शनिस्ट ने फोन करके बोला भी ना कि डॉक्टर साहब बुला रहे हैं, तो कह रहा क्यों आऊं, मैं ठीक तो हो गया. Hepatitis B 90% केसेस में spontaneous resolution होती है, but in hepatitis C 90% patients they will come back. They will come back because the virus is more aggressive. It will cause conversion. It will cause conversion to chronic hepatitis. These figures I am telling you from textbook of medicine, Harrison, to justify the statement that I said. B वाला तो बेटा जैसे कैरियर भी है. Yes, exactly, कैरियर वाला भी, क्योंकि जो कैरियर है वो तो यार उसको खुद को कुछ नहीं हो रहा ना, उसका लिवर तो सेफ है, डिजीज स्प्रेड कर ही जा रहा है कम्युनिटी में, वो भी बी वाला हो जाएगा. सो यू कैन सी hepatitis B, it is media that makes it appear more dangerous कि यार बड़ा खतरा. देखो, everything is dangerous. I understand who will suffer from the disease. He will say this is dangerous for me. But if I look at it from the whole perspective, then B has spontaneous resolution and patients don't come back for follow-up. But 90% of C patients will come back to the follow-up in the hospital. This is the reason why this question is asked, and that is why the student knows, the examiner knows कि भाई बच्चे इसके बीच में हमेशा confused रहते हैं. That is the reason why these kind of questions are come, and they have to, like, you have to work out this information on the basis of logic. Then is what is the most common viral cause of fulminant, most common viral cause of fulminant viral hepatitis or fulminant hepatitis. इसमें थोड़ा इंग्लिश वाला कंपोनेंट थोड़ा सा इंप्रूव कर लेना. Like instead of writing the word fulminant viral वर्ड एक ही बार रहे तो ज्यादा बेटर रहेगा. मोस्ट कॉमन वायरल कॉज ऑफ फुलमिनेंट हेपेटाइटिस इन अ पेशेंट. यस बेटा, जो ई बोल रहे हैं ना, वो आप क्या कर रहे हो, जल्दबाजी कर रहे हो कि अच्छा सर हमें आता है, वो प्रेगनेंसी का आंसर है. इफ आई वुड हैव आस्क्ड यू इन द सब्सिक्वेंट एमसीक्यू what is the most common cause of fulminant hepatitis in pregnancy, your answer of E would have been perfect. But I never asked you what in pregnancy. The answer in this particular case is hepatitis D virus. The D virus जो होता है वो अकेले नहीं काम करता. D virus always works with B virus. Like D and B virus होता है, उसके साथ में there could be a co-infection that is developing in a patient. So D in combination with B. It is D alone नहीं करता. D alone तो D alone जो है, that alone cannot cause a damage. It is an incomplete RNA virus. But when it is with B, तो फिर दो यार मिल गए और मिल के मारेंगे, है ना. एक आदमी को मार रहा है, समझ में आता है. दो आदमी मिलके मारेंगे तो फिर बॉडी रिएक्ट नहीं कर पाएगी. So the incidence of fulminant hepatitis will be relatively more if it's a combination that is present. The figures which are given for this is D and B का जो combination है. Mark my words there. I said it is a combination. I never said alone. The combination has 20% chances of hepatitis, and with E it is 30% chances. These mathematical values are basically being, not that they are like to be remembered. The mathematical values are just to tell you that in pregnancy it is E, but otherwise it is hepatitis D super infection. Yes, that would be responsible. Exactly. The combination, the super infection component, as you guys are saying, because there can be two patterns of infection. One can be co-infection, second can be super infection. So the super infection cause can contribute to this. Yes, exactly. Perfectly right. Next is, what is the most common cause of hepatocellular carcinoma? Overall, what is the most common cause of hepatocellular carcinoma? So hepatocellular carcinoma is again because of hepatitis B virus more as compared to hepatitis C virus. Most common cause of hepatocellular carcinoma is hepatitis B virus more as compared to the C virus. How it causes it, I will explain to you subsequently, but at the moment this is how the data is present. Then is, what is the drug of choice for hepatitis B? You can quickly comment in the chat box, drug of choice for hepatitis B. And C also, and D also. फटाफट से कमेंट कर देना. For hepatitis B, we can be using tenofovir. Tenofovir works against HIV also. So this was a question that was asked in FMJ exam की HIV और hepatitis दोनों पे कौन सा असर करता है, तो tenofovir है. Another drug we can use is entecavir in the patient. So these are drugs for hepatitis B. For hepatocellular carcinoma, man, that's gonna be like the B virus. And like I said, D virus alone does not cause a damage. But with when two मिल जाते हैं, दो यार मिल जाते हैं, तो फिर मिल के मारते हैं. Super infection, that would be 20% chances that is responsible. Okay, for C virus, yeah, for C virus we will be using sofosbuvir. No, TLD नहीं बेटा, TLD तो HIV के लिए होता है. वो तो TLD तो HIV के लिए होता है. यहाँ पे तो सिर्फ हम बात करें हेपेटाइटिस बी की. So either the two drugs can be used in a patient. हेपेटाइटिस सी ज़्यादा होता है HIV के साथ. No, it is not the case. Now, sofosbuvir, ड्रग ऑफ चॉइस फॉर हेपेटाइटिस sofosbuvir. उसके साथ में बताओ और क्या ड्रग देते हैं? Velpatasvir. This is the combination that is used for management of patients of hepatitis C. आपको याद करना है ब्यूवीर और फिर याद करना है एसवीर. ये नॉन स्ट्रक्चर्ड एंटीजन बी के अगेंस्ट होता है और ये नॉन स्ट्रक्चर्ड एंटीजन ए, जो कि जीन्स होते हैं, प्रोटीन्स बनाते हैं जो वायरस के रेप्लिकेशन में हेल्प करते हैं. देयर आर जीन्स विच फॉर्म प्रोटीन्स एंड द प्रोटीन्स आर बेसिकली हेल्पिंग अगेंस्ट द प्रोडक्शन ऑफ द विरियॉन्स. सो sofosbuvir acts against NSB and velpatasvir acts against non-structured antigen A and it will control the replication of the virus. Then is the drug of choice for hepatitis D. The डेल्टा वायरस के लिए हमें एंटीवायरल ड्रग नहीं देना होता. डेल्टा वायरस तो इनकम्प्लीट आरएनए वायरस है, अलोन तो कुछ करता भी नहीं है. पर जब बी और डी मिल जाते हैं तो फिर उनको किल करने के लिए वी शैल बी यूजिंग इंटरफेरॉन इंजेक्शंस. इंटरफेरॉन एक्चुअली इज नॉट अ एंटीवायरल ड्रग, इट इज अ इम्यूनिटी बूस्टर. अनलाइक इन टेनोफोविर और सोफोस्बुवीर जिसमें भी वीर आ रहा था, वो तो सब एंटीवायरल ड्रग्स थे ना. दिस पर्टिकुलर ड्रग इज नॉट अ डायरेक्ट antiviral, it's not like a virucidal drug, it is a immunity booster. Yeah, we can use pegylated interferon also. This drug is a immunity booster. It will pump up the immunity of the patient and then the immunity will kill the virus. So ultimately virus will die, but like one is a direct virucidal drug, antiviral drug, virucidal drug. So this is not a virucidal drug. And then comes the question of, because liver is damaged, we go for liver transplantation. The word is orthoptic liver transplantation. The question that I have for you people is that since we are dealing with orthoptic liver transplantation, we will not, like here you have to remove the old liver and put a new liver. In kidney transplantation, we don't remove the old liver, we put the new liver in place of the previous one. But in orthoptic, like you remove the old one and you place the new liver. What is the number one cause? Very good. I'm having good answers also, so I'm waiting for other people to comment. What is the leading cause of orthoptic liver transplantation? I'm waiting for more answers. Yes, your answer will be MASH. MASH is the new term for non-alcoholic fatty liver disease, NAFLD. And then is obviously the viral causes. अगर वो वायरस पूछता है इसके साथ में लिवर खराब हो जाएगा और उसकी वजह से ट्रांसप्लांटेशन की नौबत आएगी, तो क्योंकि सी ज़्यादा डेंजरस होता है, क्योंकि वो कन्वर्जन कर देता है क्रॉनिक हेपेटाइटिस के हो, तो ये जस्टिफिकेशन है कि क्योंकि ये ज़्यादा डेंजरस है तो इट इज़ द वायरल कॉज बट इट इज़ नॉट द ओवरऑल मोस्ट कॉमन कॉज. तो ओवरऑल मोस्ट कॉमन कॉज इज मैश. मैश वुड स्टैंड फॉर मेटाबॉलिक डिसफंक्शन एसोसिएटेड. मैश वुड स्टैंड फॉर metabolic dysfunction associated steatohepatitis. The word is steatohepatitis. And when I say steatosis, तो स्टेटियोसिस का मतलब क्या होता है? तो स्टेटियोसिस का मतलब होता है ट्राइग्लिसराइड डिपोजिशन. स्टेटियोसिस मीन्स व्हाट? इट इज ट्राइग्लिसराइड का डिपोजिशन इन द हेपेटोसाइट. It is triglyceride deposition in the hepatocytes which is responsible for like the damage in the patient. A question to everybody, कितना प्रतिशत लिवर, more than how much percentage of the liver is liver cells, मान लो लिवर में 1000 सेल्स है, तो कितने परसेंट से ज्यादा सेल्स इन्वॉल्व हो जाएं बाय स्टेटियोसिस कि हम फैटी लिवर बोलेंगे? व्हाट इज द हाउ मच परसेंटेज ऑफ द लिवर cells should be involved to cause development of fatty liver in a patient? Steatosis, yes guys, yes, more than 5%. अगर more than 5% of the total hepatocytes, ये एक जनरल स्टेटमेंट है, if more than 5% of the hepatocytes are exhibiting a steatosis, then I will say that the person is suffering from fatty liver. What is the most common cause of fatty liver, by the way? सर 70% तो बहुत ज्यादा हो जाएगा ना, तब तक तो इरिवर्सिबल डैमेज हो जाएगा, हेपेटाइटिस हो जाएगा. If it is more than 5% of the liver hepatocytes getting involved, then we call it steatosis, that is fatty liver in a patient. Yes, it is mostly obesity. It is mostly syndrome X in a patient. It is metabolic syndrome which is responsible. Fatty liver क्यों होता है? तो उसका mostly जो cause रहता है वो obesity रहता है, diabetes mellitus रहता है, lifestyle disorder रहता है. And then obviously like fatty liver can occur due to alcohol also. But my point is चाहे वो fatty liver alcoholic हो या non-alcoholic हो, ultimately more than 5% of the liver getting involved in the patient. And would it be like reversible or irreversible? और अगर रिवर्सिबल है तो कैसे करेंगे? फैटी लिवर ग्रेड 1 आया, ग्रेड 2 भी आया, तो इज इट रिवर्सिबल और इरिवर्सिबल? या इट इज रिवर्सिबल. कैसे, क्या करोगे? वेट लॉस. सिंगल आंसर इज वेट लॉस. अगर 7 to 10% का वेट लॉस होता है तो वी विल बी एबल टू रिवर्स इट. सिंपल एक्टिविटीज पेशेंट को बोलना है, रेजिस्टेंस ट्रेनिंग करनी है. रेजिस्टेंस ट्रेनिंग मतलब जैसे टायर उठाते हैं, बैंड्स वैंड्स को स्ट्रेच करना. So weight loss, 7 to 10% of weight loss reduction would help in the patient. हाँ, वो जो नई वाली दवाइयाँ ना यार, रेस्मेट्रॉम और वो सब, वो रूटीनली रिकमेंडेड नहीं है. वो सारे ऑफ लेबल ड्रग्स. सो मेन आंसर इज वेट लॉस इन अ पेशेंट. तो फार्मा में आपको दवाइयाँ बताई होंगी, रेस्मेट्रॉम एक्सेट्रा. द पॉइंट इज दैट दोज मेडिसिन्स आर नॉट लाइक द स्टैंडर्ड prescriptions that can be given to the patient. Okay. Next we will talk about hepatitis B. Hepatitis B is a, yes guys, the comment is, what you have to comment is it a single stranded DNA virus, is it a double stranded DNA virus, or is it partially single stranded, partially double stranded DNA virus? Yeah, the route of transmission को भी कर लेते हैं अभी. Fine. Is it single stranded, is it double stranded? Yeah, it is partially single stranded, partially double stranded DNA virus. इसको ऐसे ही लिखते हैं SS/DS. It is partially single stranded and partially double stranded DNA virus. This virus can be seen easily inside the hepatocytes. I mean, जैसे अगर ये hepatocyte होगा तो inside the hepatocyte this can easily be seen. And most of the time like जो cytoplasm होता है वो थोड़ा ground glass appearance हो जाता है. So you would have done that question saying ground glass appearance of hepatocytes is a feature of, the answer would be given as hepatitis B. That's just a pathology correlate which I wanted to say. This partially single stranded, partially double stranded DNA virus will cause a ground glass appearance of hepatocytes. I will talk about ground glass appearance in X-ray also subsequently, but at the moment the word is ground glass appearance. MASH is there in a skinny person. Yeah, very common. Diabetes, man. Metabolic syndrome. Skinny तो है, पेट निकला हुआ है ना भाई. It is not subcutaneous obesity से फैटी लिवर नहीं होता है, टमी फैट से होता है. हम इंडियंस को क्यों है कि हमारा सारा फैट यहाँ साइड पे आता है ना, यहाँ टायर निकल जाते हैं ना हम सबके. पेट तो निकलता ही है, टायर निकल जाते हैं साथ में, है ना. तो दैट इज द प्रॉब्लम. इट इज, पर्सन कैन बी स्किनी ऑल्सो, but still metabolic syndrome can be present in the patient. Ground glass appearance of hepatocytes would be present in a patient, and it's a single stranded DNA, single stranded, partially single stranded DNA virus, or single stranded / partially single stranded, partially double stranded DNA virus. Okay, what is the commonest root of carbohydrate rich diet? Yes, roti, paratha is the reason. What is the route of transmission? Sexual contact, blood transfusion. Select one. What is the most common? You can type the word sexual contact, you can type the word blood transfusion for transmission. The most common route of transmission is sexual contact. If the question just says what is the most common transmission route of hepatitis B virus, it is sexual contact. So there can be like transfusion associated hepatitis also. That is primarily because of the corruption issues in our country. उसको मैं नीचे लिख देता हूँ. बहुत बारी क्या होता है कि जो ब्लड बैंक वाले होते हैं वो टेस्टिंग ही नहीं करते. बहुत बारी जो ब्लड बैंक वाले होते हैं वो टेस्टिंग ही नहीं करते हैं. वो लाइक पैसा तो ले लेते हैं बट दे डोंट डू टेस्टिंग, या एक्सपायरी डेट के किट्स को यूज कर दिया. सो दिस इज मोर ऑफ अ करप्शन इशू इन अवर कंट्री. इसको टेबल के मिडल में लिखना कि ब्लड टेस्ट किया ही नहीं या एक्सपायरी डेट की किट यूज कर ली. तो ट्रांसफ्यूजन एसोसिएटेड हेपेटाइटिस इज गोना बी हेपेटाइटिस बी, एंड बोथ स्टेटमेंट्स आर नॉट द सेम. आई मीन वन इज द कॉमन रूट ऑफ ट्रांसमिशन, the second one is transfusion associated hepatitis. I mean both in literal sense don't mean the same. या अमिताभ बच्चन को भी हेपेटाइटिस बी ब्लड ट्रांसफ्यूजन से मिला, उनको कुली मूवी की शूटिंग हो रही थी, तो उनको पेट में लग गया, लाइक वो गाय हु प्लेड दुर्योधन इन महाभारत, पुनीत नाम है उसका, तो ही पास्ट टाइम अमिताभ बच्चन इन द टमी, दे वर एक्टिंग ओनली एंड द गाय फेल ऑन अ ग्लास टेबल, तो उसके पेट में ग्लास लग गया, तो ब्लीडिंग हो गई लिवर से। तो ऑल पीपल इन मुंबई लाइंड अप कि सुपरस्टार को ऐसे ब्लड लॉस हो गया, हम देंगे हम देंगे। तो उनमें से एक जो फैन था अमिताभ बच्चन का, वो हेपेटाइटिस बी पॉजिटिव था, ये पुनीत हिसार एग्जैक्टली। So he ultimately ended up with like a blood transfusion. He ended up with hepatitis B. And Amitabh Bachchan, like normally, like it's good that we are discussing it. Amitabh Bachchan like was vocal about the fact that I have hepatitis B, and he like normally celebrities ना they hide their illnesses. Like कोई भी होगा बोलेगा भी मैं अपनी बीमारी बताऊंगा, लोग मेरे फॉलोअर कम हो जाएंगे, है ना। तो but like he was vocal, no no I have to be telling people about my illness, and he has only 40% of his liver functioning, and still he does shooting for KBC and works 10 hours every single day, more than any actors, more than all of us। 10 घंटे तो हम भी काम नहीं करते। And then the point is he was made the global ambassador for Hepatitis B Foundation for whole life. But that itself is an achievement, because like being a celebrity and a superstar, everybody knows Amitabh Bachchan's name, so people will at least not feel taboo about the disease, and at least they will try to seek treatment. Okay, a fan ने fielding set कर दी, वही हुआ। Yes, now is the antigens. The antigens would be hepatitis B surface antigen, then is the core antigen, then is gonna be the E antigen, S for Singapore, C for Calcutta, E for England. Can you help me with the fourth antigen in this patient? And a good comment, Prana. Big B, small liver. I like that comment. Yes. Surface, core, E antigen. What more? It is the X antigen, Christmas wala X antigen. And then is hepatitis B DNA. There are total of 5 antigens seen with the virus: surface, core, E antigen, X antigen, and hepatitis DNA. And then there is gonna be like one parameters which are present for each one of them. If he says what is the earliest serological indicator of hepatitis B infection, then the earliest first to appear in the blood, the earliest serological indicator is surface antigen. At this moment I also want to tell you that actually में जो blood में पहले आता है ना, वो तो आता है hepatitis B DNA। उसके लिए पीसीआर करना पड़ता है, और रूटीनली तो पीसीआर करते नहीं है ना भाई, पीसीआर तो एक्सपेंसिव होता है, पहले हम सरफेस एंटीजन करते हैं। आई वांट टू क्लैरिफाई द फैक्ट दैट इट इज ड्यू टू द लेबोरेटरी स्ट्रैटेजी, बिकॉज कोई भी पेशेंट आता है तो पहले हम हेपेटाइटिस बी सरफेस एंटीजन करते हैं, बाद में पीसीआर करते हैं। दैट इज व्हाई व्हाट हैपेंस इज दैट द आंसर बिकम्स फर्स्ट टू अपीयर इन द ब्लड इज सरफेस एंटीजन। बट एक्चुअली में देखा जाए, टेक्निकली देखा जाए तो ये गलत स्टेटमेंट है। टेक्निकली स्पीकिंग व्हाट इज फर्स्ट अपेयर इन द ब्लड इज हेपेटाइटिस बी डीएनए। बट कोई भी 3500 रुपए का टेस्ट तो नहीं लिखेगा ना कोई भी डॉक्टर। अगर आप 3500 रुपीज का टेस्ट लिख दोगे कि पीसीआर करा के लाओ, पेशेंट आएगा ही नहीं वापस। बट इफ यू राइट हेपेटाइटिस बी सरफेस एंटीजन तो मे बी 300-400 रुपए का होगा तो पेशेंट करवा लेगा। तो इट इज अ लेबोरेटरी, इट्स अ लेबोरेटरी एरर दैट विल बी लेबोरेटरी स्ट्रैटेजी व्हिच इज द रीजन व्हाई दैट द क्लैरिफिकेशन इज अर्लीस्ट सीरोलॉजिकल इंडिकेटर। इफ ही इज गोना गो हार्डकोर और बोलता है सबसे पहले क्या आएगा ब्लड में, तो फिर सरफेस एंटीजन मत बोलना, फिर आप बोलोगे डीएनए फॉलोड बाय सरफेस एंटीजन, दैट वुड बी कमिंग। एंड यूजुअली टेक्स अबाउट 2 to 3 वीक्स फॉर सरफेस एंटीजन टू टर्न पॉजिटिव। लेकिन 2 हफ्ते से पहले क्या पॉजिटिव हो जाता है तो हेपेटाइटिस बी डीएनए। कोर एंटीजन अंदर छुप के बैठा रहता है, कोर है ना तो अंदर रहता है, तो नेवर टू अपीयर इन द ब्लड। विच ऑफ द फॉलोइंग इंडिकेटर, विच ऑफ द फॉलोइंग एंटीजेंस विल never to appear in the blood with respect to the course of this particular illness? Then never to appear in the blood is the core antigen. E antigen is always for replication. E antigen is always for replication of the virus. E antigen is always for replication of the virus, and because I've said the word replication, I can also say that the infectivity of the patient will be more, like the person will be more infective to the doctor and nurse who's handling the blood sample of the patient. The infectivity will be more to the doctor and nurse who's handling the sample, and also to the sexual partner of the patient. I mean क्योंकि वायरस ज़्यादा मल्टीप्लाई कर रहा है तो the infectivity of the patient will be more. When it comes to the X antigen, the X antigen will cause the patient to develop liver cancer. How? It will inhibit apoptosis. When you read about apoptosis, there is a CD marker CD95 which plays a role in apoptosis. एपोप्टोसिस क्या होता है? वो प्रोग्राम सेल डेथ होती है, तो सेल की डेथ ही नहीं होगी तो फिर अनकंट्रोल्ड रिप्रोडक्शन होती रहेगी। If the cell will not die, it will cause uncontrolled reproduction. So X antigen causes inhibition of CD95 and hepatocellular carcinoma. And lastly, we gonna go talk about PCR for hepatitis B DNA. यहाँ पे they will give you a report. The report will be written as 20,000 international units. To make it sound sophisticated, he will write in the question 20,000 international units of DNA per ml of blood. The question will say 20,000 international units of DNA per ml of blood with doubling of SGPT. Like the question will basically mention regarding high viral load and doubling of SGPT, which means that there is a cytopathic effect. SGPT doubling का मतलब क्या है कि जो हेपेटोसाइट्स हैं उनकी डेथ हो रही है, क्योंकि SGPT जो होता है वो हेपेटोसाइट्स के साइटोप्लाज्म में होता है. सो when the hepatocyte will burst, then the virions will escape and will infect more hepatocytes. So it's telling you that the virus is active. So virus is active means I have to be aggressive. And what do I mean by aggression? I have to give medicine to the patient. So I will be giving to the patient tenofovir in this particular case. So tenofovir देने के लिए we don't just rely on person is having hepatitis B, we check the viral load. We will use our firepower where the enemy is strong. अगर virus load is less, like 200 viruses, 20 viruses per ml of blood, immunity will kill the virus. हमारी इम्यूनिटी इतनी सक्षम है, ह्यूमन बॉडी सो स्ट्रॉन्ग दैट हेपेटाइटिस बी को बोलते हैं हट क्या चीज है तू. अभी तो मैं बोल रहा था 90% केसेस रिकवर, दे नेवर कम फॉर फॉलो अप बिकॉज आवर बॉडी सो स्ट्रॉन्ग दैट इफ वायरस लोड इज लो, 20 viruses, 200 viruses, then our body will kill the virus and like there is no need for the patient to take medication. But if you notice that the viral load is high and patient is going towards chronic hepatitis, that means the virus, in fact, infection was high dose virus infection came in the body. Then immunity will not be saksham or not capable. So now you need to give support. Support is from outside, kill the virus. So you give tenofovir. So in high viral load, we are like you see, हथियार कब यूज करना है, डॉक्टर के लिए सबसे इंपॉर्टेंट चीज होती है हथियार कब यूज करना है, दवाई कब लिखनी है, राइट. सो यू डोंट राइट ट्रीटमेंट टू एवरीबडी विद हेपेटाइटिस बी, यू चेक द पीसीआर से वायरल लोड कम हो गया तो बोलेंगे नहीं यार जरूरत नहीं है. यही क्रॉनिक वायरल हेपेटाइटिस है एंड द वायरस लोड इज इंक्रीजिंग. सपोज लास्ट मंथ आया था रिपोर्ट थी 20,000 इंटरनेशनल यूनिट्स, इस साल होगी, इस महीने होगी 2 लाख, है ना, फिर हो जाएगी 20 लाख, नहीं इलाज करेंगे. उसको बोलेंगे यार तेरा पीसीआर का ना वायरल लोड बढ़ रहा है देख, और तेरे को लिवर में डैमेज स्टार्ट हो गया है, तो अब आप दवाई खा लो चुप करके बिकॉज योर इम्यूनिटी इज नॉट गोना वर्क. सो वो भी बोलेगा हाँ जी सर ओके फाइन, जस्टिफाइड है ना, बिकॉज यू डेमोन्स्ट्रेटेड दैट द वायरल लोड इज हाई. अदरवाइज या लो वायरल लोड वी डोंट नीड एनीथिंग. सर एक्यूट वायरल हेपेटाइटिस में कोई दवाई नहीं देते. इट कम्स एज अ शॉक टू डॉक्टर्स की सर हेपेटाइटिस बी हो गया, कह रहे हो दवाई नहीं देंगे. हाँ जी, एक्यूट वायरल हेपेटाइटिस वी डोंट ट्रीट, जरूरत ही नहीं है. पेशेंट विल रिकवर बाय हिमसेल्फ विद इन 4 वीक्स. जॉन्डिस ठीक, LFT will come back to normal. मोस्ट पेशेंट्स जो हमारे पास आते हैं ना, जैसे कॉलेज स्टूडेंट आया कह रहा है वो सर मेरे को ना जॉन्डिस हो गया है, तो आपको बॉडी लैंग्वेज समझ में आ गया कि भाई कुछ ना कोई गलत काम तो किया होगा. अब हम पूछते तो है नहीं, कि बताने वाला तो है नहीं. अब उससे पूछेंगे तो ड्रग्स लेता है, बताएगा नहीं, है ना. बोलेंगे ड्रग्स लेता है तो वैसे ही हाइपर हो जाएगा, पता नहीं पुलिस में बता देंगे, मेरे मम्मी पापा को बता देंगे. तो हम पर्सनल हिस्ट्री पूछते ही नहीं, है ना. वैसे ही सेक्सुअल कॉन्टैक्ट का आप पूछोगे उसकी सेक्सुअल हिस्ट्री के बारे में तो झूठ ही बताएगा, अनप्रोटेक्टेड सेक्सुअल एक्सपोजर के बारे में नहीं बताएगा आपको. तो वी डोंट इवन आस्क बिकॉज मोस्ट ऑफ द टाइम आप पूछोगे उसने झूठ ही बोलना. तो आप उसको बोलोगे कि यार ठीक है तू फॉलो अप में रह मेरे एंड विल गिव कंजर्वेटिव मैनेजमेंट. अब आपको मॉनिटर करना है और वो मॉनिटर में तुमने बुलाया, आए ही नहीं, वो आपको लगाया पता नहीं कहाँ चला गया, ठीक हो गया ना. बट सम विल कम बैक एंड द गाय हु कम्स फॉर अ सेकंड विजिट मींस देयर इज अ प्रॉब्लम. हाँ वो ठीक है, वो ट्रक ड्राइवर या कुछ भी बोलो, मतलब कॉलेज स्टूडेंट्स नो लाइक दे गो टू दिस रेड लाइट एरिया. लाइक ये हुआ ना चेन्नई में, दिस गाय ही वेंट टू रेड लाइट एरिया एंड ही गॉट HIV. और उसके बाद वो विंडो पीरियड में था, ही वेंट टू स्टानली मेडिकल कॉलेज एंड ही डोनेटेड ब्लड. कैन यू बीट दैट? A college student, he went to red light area under the influence of his friends ki, you know, we have to man up and stuff like that. He had unprotected sexual exposure. He turned HIV positive. He was in the window period. He donated blood. The blood bank could not pick up the guy was HIV positive because he was in the window period. And his blood was given to some lady who subsequently developed features of HIV and AIDS. And when they did testing, they found, oh, this guy was the donor and he had suffered from HIV. You know, I mean that became a huge scandal. No, कि the testing is not being done properly. Window period में तो वैसे ही टेस्ट नेगेटिव आ जाएगा. ELISA test would be negative. X antigen guys, X antigen is like X है ना, तो mystery है. And what is the mystery? It knocks out apoptosis. You know, every cell कहते जो भी बना है, भगवान ने बोला जो भी बना है उसका विनाश होगा. right? Everything is formed, it's gonna die. If you switch off that Vinash, if you switch off that, you know, CD95, which is one of the steps involved in apoptosis के step तो पढ़े हो ना, caspases होते हैं ना, caspases mediated destruction, intrinsic pathway, extrinsic pathway, caspase 8, 9, 3, 6, 7 मैडम ने बताया होगा। तो वो जो caspases वाला जो प्रोसेस है, आप उसको टर्न ऑफ कर दो ना। पहले CD95 होता है, फिर caspases वाले प्रोसेसेस होते हैं, इंट्रिंसिक और एक्सट्रिंसिक, इतना तो याद है ना। CD95 caspases वाला प्रोसेस, you turning off the switch which is producing caspases, the whole thing, the normal जिसे कहते हैं विनाश होना है, that विनाश will not happen, the destruction will not happen, and ultimately and then ultimately like the cell is not gonna die and it will continue multiplying. Okay, now we will talk about antibodies which are seen here. The antibodies which can be seen here are antibody against the surface antigen, antibody against the core antigen, and antibody against the E antigen. So these are the antibodies which can be seen. Antibody against surface, core, and E antigen. S for Singapore, C for Calcutta, E for England. We're ready for the question. Comment in the chat box 1, 2, 3. One is surface antigen against antibody, and like this is the answer you need to give me. My question comes now. Which of the following is called as seroconversion antibody? Seroconversion का मतलब है, सीरो कन्वर्जन का मतलब है कि मतलब अगर वो एंटीबॉडी आ गया तो गारंटी है द पर्सन विल नॉट डाई. Which is the seroconversion antibody that if the antibody will appear, then it is guaranteed that the guy will not die. वोटिंग कर दो, ऐसे ऐसे गलत भी हो सकता है. 1, 2, 3 कर दो एक बार फिर से. डोनर का नाम नहीं लिखा होता ब्लड बैंक पे. Guys, the answer is 1. It is antibody against the surface antigen. It is the security system वाली antibody जो होती है वो seroconversion antibody होती है. The answer to the question that I asked you is 1. Seroconversion antibody is the antibody against the surface antigen. If this will appear, it's a guarantee that the patient is not going to die. Seroconversion antibody is antibody against the surface antigen. For antibody against the core antigen, there can be two varieties, IgM and IgG class. For the IgM class of antibody against the core antigen, needless to say, IgM class of antibody can say the word acute hepatitis B. But in some MCQs, you will notice that the answer will be given as gap period. I will explain to you after precisely 3 to 4 minutes how in the MCQ will you distinguish in 30 seconds whether it is gap period or acute hepatitis B. But at this moment, I want you to remember that for IgM class of antibody to the core antigen, there can be two possibilities in the MCQ. How differentiation will be done will be explained in few minutes. For the IgG class of antibody, one possibility can be that the guy is having chronic hepatitis B. But in some MCQs, the answer will be given as remote infection. After 5 minutes, I will be in a position to explain to you how to differentiate in 30 seconds whether it is remote infection or chronic hepatitis B. So point number 2 is slightly tricky, but I will simplify the data that you will be able to understand immediately. At this moment, it might look overwhelming, but believe me, after listening to me for a couple of minutes, this will become super easy for you guys. So wait out for a couple of minutes and I move to the next point. Antibody against the E antigen. Antibody against the E antigen means that now the infectivity of the patient will become less. See, I told you E antigen basically means infectivity, infectiousness. Now there is an antibody against the E antigen, so the infectivity of the patient will become relatively lesser. The infectivity or the ability of the patient to infect others will become relatively lesser. So at this moment, I have covered 8 MCQs on this page. That is 5 with respect to the antigens and 3 with respect to the antibodies. And once you are able to understand this antigen and antibody data, now we will see how questions are framed on this particular topic. I'll come back to these diagrams in like a couple of minutes. First, let's come to page number 170. And on 170 in the patient, we will be doing a simple interpretation. I would like you to at this moment desist from commenting, stop commenting and listen to my words very, very carefully. This is a college student who came to the clinic today. He was having jaundice. I did not ask him much history and I got his surface antigen turned out to be positive. Must be high risk sexual behavior, IV drug use, something high risk behavior is there. The security system at the moment is absent because just now the infection comes, so security system will not come immediately if the infection come in recent times, one week, 2 weeks ago. The class of antibody here is IgM class of antibody to the core antigen. If these two things are given in the question together, if you read surface antigen present and you read IgM class of antibody present, if these two data are, mark my words there, if these two data are present together, the combo of the two, you will say you are dealing with acute hepatitis B infection. This is interpretation of acute hepatitis B. And if I add the word E antigen positive, then as I explained to you, E antigen talks about replication. So I will also write on the case file that the patient is highly infectious. This is acute hepatitis B patient and he is highly infectious. That is why the E antigen is turning out to be positive. Now, if the same patient is coming back, security system is still sleeping, like in government hospital when people will come to beat you and me, security is sleeping half the time, मारने आ जाते हैं, सिक्योरिटी सो रही है, वैसे ये एंटीबॉडी के सर्फेस एंटीजन सो ही जा रहा है, इसको उठना चाहिए था, द गाय शुड हैव वोकन अप, द सिक्योरिटी सिस्टम इज स्लीपिंग. Now the class of antibody to the core antigen will change to IgG. If this is the situation, two things present again, surface antigen positivity plus IgG class of antibody to the core antigen, the combo of the two is what is called as chronic hepatitis B. It is chronic hepatitis B. If E antigen is also positive, I will once again say highly infectious, but if I wanted to change the question, I would have made the E antigen negative also. Then you would have said lowly infectious in the patient. If E antigen is negative, then the infectivity risk is less, low infectivity. And if it is present, then it is high infectivity in the patient. So very straightforward data. Two interpretations should be there. Surface antigen should also be there. IgM class of antibody to core antigen should also be there. If both things are present together, that is when you say acute hepatitis B or chronic hepatitis B based on the antibody. Suppose in this question, like you asked low infectivity, yes, I'll modify. You don't need to modify. Don't modify anything. Suppose in this question I made it negative, then I will just change the word. Then I will say this patient is having low infectivity, so lowly infectious, exactly the same thing. I'm just reverting back to my original situation. Like I explained to you, most of the time the cases given are highly infectious. So Supreet, you said low infectivity, yep, E antigen negative, it will change. Now I will be giving you a case presentation of a person where everything is negative, only the security system is present. If alone security system is present, in a patient, that means this person is vaccinated. A lot of you would have taken the vaccine. So if you've taken hepatitis B vaccine 3 shots, you would be having antibody against the surface antigen. So this is again an easy interpretation for single input. I mentioned with a separate color just to highlight the contrast there, that earlier we were talking about an infection, but now the person is vaccinated. There was a question in the paper where my student said that boss, everything was negative except for IgM class of antibody to the core antigen. He said everything was negative except for the IgM class of antibody to the core antigen. If that is the case, if everything is negative and only IgM class of antibody is present in a patient, then this is early infection. This is window period. Because window period be most students are able to answer. No, window period you still understand. Early infection, he might write the word gap period. Yes, Supreet, you're right, window, but I would just like you to modify that word into gap period, the way the examiner would put up the question for single input of IgM class of antibody. Last entry antibody here, last situation here, all report was negative. All report was negative. The only thing that was present in this particular case was, the only thing positive in this patient was IgG class of antibody. Now, before I write the answer, and lot of you have commented also, I would just like to say that suppose in 2021 you had COVID. You had it twice in 21, twice in 22, then COVID went away. So the COVID antibody आज भी हो सकती है ना आपकी बॉडी में. मान लीजिए आपको कोविड का इन्फेक्शन आज से 4 साल पहले 2-3 बार हुआ था, तो हो सकता है कि IgG क्लास पता IgG एंटीबॉडी कोविड आज भी आपके ब्लड में प्रेजेंट हो. Similar spirit here, this particular patient may have had infection earlier. Now, like this antibody, infection was either treated by drugs or it resolved on its own. It can be 2 possibilities. या तो दवाई से ठीक हो गया, खुद ही ठीक हो गया, हेपेटाइटिस बी खुद भी ठीक हो जाता. Then it is remote infection that would be present, क्योंकि अगर infection आया था तो body में antibody तो बनती है ना. So the inputs I want you to remember at this moment is, if in any question only the security system antibody to surface antigen is present, it is vaccinated. If only IgM class of antibody present, gap period. But if it is gonna be 2, yes Pranav, we will do that. But if 2 are present, IgM antibody and surface antigen, it is acute hepatitis B. If it is alone IgG antibody, listen to that very carefully. Focus your eyes at the lower lower part of the slide, if alone in any question IgG class of antibody is given remote infection, but suppose I change the output and I give you a combo of surface antigen and IgG class of antibody, then you will say chronic hepatitis B. I'll say this again. If alone in any question IgG class of antibody is given, say that to yourself, remote infection. But if you get a combo, then say to yourself, chronic hepatitis B. Usually in these questions of combos versus single, people tend to mix up the data. Obviously you won't, because I know you are intelligent people, but yes, if you're listening to this first time, there is a high probability you may get this wrong. So my suggestion to this patient is that make this table once again by yourself. नाम ही लिखना है, इन चिट ऑन पैड राइट द नेम ऑफ एंटीजेंस, और ये एक्टिविटी खुद से करना. अगर आप इसको 1-1.5 मिनट में कर लेते हो बिना इसको देखे हुए, दैट मीन्स आपके थॉट प्रोसेस में दिमाग में डेटा ऑर्गेनाइज है कि डबल एंट्री एक्यूट वर्सेस क्रॉनिक, सिंगल एंट्री, देन द इनपुट्स व्हिच आर प्रेजेंट. रिमोट मतलब लॉन्ग टाइम अगो. यस. And all of these patients, and there are a lot of patients who would ultimately, because they don't take treatment, then they'll end up with possibility of cirrhosis in a patient. So before I talk about these drugs for cirrhosis, and these drugs I was talking, resmetirom, they're usually not given. No, that usually passes off, man. In remote ना, the antibody के surface जो security antibody, वही तो कह रहा हूँ ना कि security वाली antibody तो resolve हो गई थी. कोविड में तो एक ही एंटीबॉडी बनती थी, राइट. ये तो मल्टीपल एंटीजेंस वाला वायरस है, तो सिक्योरिटी वाली एंटीबॉडी क्लियर ऑफ हो गई है, बट वो पहले जो इन्फेक्शन हुआ था उसका जो मार्कर होता है दैट इज स्टिल प्रेजेंट इन द पेशेंट. ओके जी, ग्रेट. चलो एक और पॉइंट पूछते हैं, एक और पॉइंट, राइट. पेज नंबर 176 आई एम क्रिएटिंग. हाँ बेटा, जस्ट गिव मी, आई वांट ऑल ऑफ यू टू गिव मी 3 minutes, 3 minutes of your precious time, 3 minutes of your precious time, and I will come back, right. The differentiation is based on antibody. Rishikaran, that co-infection, super-infection dissolve is simply by checking up this antibody, right? अगर वो IgM antibody है और IgG है, उससे differentiate करते हैं. Okay, खैर, at this moment, accidental needle stick injury. Like today, I'm describing a case of a young doctor. He has just finished his final year or his exams, and then he's starting his internship. और ये अनवैक्सीनेटेड है, और ये आज सैंपल लिया पेशेंट का बेड साइड. द नोन पेशेंट इज सरफेस एंटीजन पॉजिटिव, एंड द डॉक्टर इज डूइंग रीकैपिंग ऑफ द नीडल. You take a sample from the forearm, you take a sample from the cubital fossa, he has withdrawn the needle. He knows that the patient is surface antigen positive, तो क्योंकि उसको पता है तो उसने डबल ग्लव्स यूज करे. He is using double gloves, बट जब वो रीकैपिंग कर रहा था उसे नीडल स्टिक इंजरी हो गई. Never do recapping of the needle. Always carry a portable needle cutter. हम सब सैंपल लेने के बाद में कैप के ऊपर ढक्कन लगा रहे होते हैं. आपको कैप मतलब नीडल के ऊपर ढक्कन नहीं लगाना है. आप कितने भी केयरफुल हैं, थोड़ा सा भी ध्यान इधर उधर हुआ तो हाइपोडर्मिक नीडल से आपको प्रिक हो जाएगा. Never put cap on the needle. You always have to carry a portable needle cutter. Even you're doing bedside sampling, put the needle in that needle cutter, cut the needle. Then you can handle the up and the remaining sample, never an issue. But then that sharp needle should always be discarded. But unfortunately, इस डॉक्टर ने डबल ग्लव्स यूज करे थे, इसको प्रिक हो गया. तो जब प्रिक हुआ तो ऑब्वियस बात है कि ग्लव्स निकालता है आदमी. जब ग्लव्स निकाले तो ब्लड आ रहा था. उसने पेशेंट की शक्ल देखा तो पेशेंट स्माइल कर रहा है हल्के हल्के, कह रहा वेलकम टू द क्लब. पेशेंट भी बदतमीज है, कह रहा वेलकम टू द क्लब. कह रहा मुझे बोलते हो HbSAg पॉजिटिव, अब तुम्हें समझ में आएगा बेटा HbSAg पॉजिटिव क्या होता है. पेशेंट भी ऐसे होता है. What are the chances that this guy will get infected? Comment in the chat box. Some people have already done that. 0.3%, 3%, 30%. 0.3, 3%, 30%. Chances of transmission. The chances of transmission will be 30%. Because the chances of transmission are 30%, this guy called you, you are his senior, right? He's calling you bhaiya, sir, whatever. And you asked him, he asked you, sir, what are the chances? You said 30%. उसके हाथ से फोन ही छूट गया. फाइनली फोन उठाया उसने, हेलो हेलो कर रहा है वापस, हेलो बॉस आर यू देयर. आपने कहा हाँ भाई मैं हूँ ना. कह रहा है सर करना क्या है, राइट. साथ में ये भी कह रहा है सर मेरी गर्लफ्रेंड को मत बताना. कह रहा है सर प्लीज डोंट टेल माई गर्लफ्रेंड. विल यू टेल हिज गर्लफ्रेंड? He got infected with hepatitis B surface antigen positive. Please comment in the chat box everybody. I know you want a tea break. I'm making you laugh. Will you be telling his girlfriend? Yes or no? I want more comments. Will you tell his girlfriend? Sir, there is something called as patient confidentiality. There is something called as patient confidentiality. ऐसे थोड़ी ना half the comments are yes, yes, yes. You will not tell, sir. सर ऐसे थोड़ी ना कि कोई भी आके कुछ भी बोल देगा तो बोले मैं भाई ब्रदर हूँ इसका या मैं इसका बॉयफ्रेंड हूँ गर्लफ्रेंड हूँ तो बता दोगे ऐसे. You will not tell, sir. We will not. Sir, what you're mixing it is with STD. Suppose a man or a woman is having gonorrhea, syphilis, chancroid, and like you are diagnosing a patient with a STD, तो ये तो STD नहीं है ना यार. I'm not saying syphilis, gonorrhea. वहाँ पे you are supposed to tell the spouse of the patient that the person is having a STD, but not here. And anyway, girlfriend is not a legal relationship, right? Is girlfriend a legal relationship? No, na. Live-in is not. Nowadays, people do a lot of things, right? That's a separate issue, but then it's not a legal relationship, one. And the second point is patient confidentiality, man. Ideally, you cannot even be sending WhatsApp report to the patient just like that. It has to be password protected. Lots of us, our hospitals might be sending reports directly to the WhatsApp of the patient. No, sir. Ideally, it should always be password protected because data privacy issues are to be taken care of. And then subsequently, now what will be doing the patient? So the answers have already come that you will be giving hepatitis B immunoglobulin to the patient parentally as soon as possibly. The healthcare worker in this particular case will always be saying, the question will say recapping of the healthcare worker. The question is that this guy is unvaccinated. He just finished his final year. His internship has started. This is unvaccinated guy. Hepatitis B immunoglobulin as early as possible, preferably within first 24 hours. Obviously, it should be as early as possible. It should be as early as possible. But yes, this is a concern that you need to remember. Now I'm giving you version 2 of the MCQ. So hear me out for another 1.5 minute, which is that the healthcare worker is partially vaccinated. This doctor has taken maybe one shot, maybe two shots of hepatitis B. So he says that, boss, I'm already vaccinated. In those circumstances, the situation will change. If the healthcare worker, HCW means healthcare worker, he is partially vaccinated. In those circumstances, if he's partially vaccinated and the question says, what is the next best step in the management of the patient? Your answer will be that I will be checking for the security system antibody titer, that is antibody against the surface antigen. Check the titer of antibody against the surface antigen. If the antibody titer is less than 10 or more than 10, that will change the answer and the response in the question. If the answer is less than 10 or more than 10, it will change the answer in the question. At this moment, I want to tell you that no gynecologist will ever take even normal delivery. Patient surface antigen report and HIV is not there. Because nowadays patients come without any testing. If on humanitarian grounds you will take a delivery, during delivery doctor can get infected. Because suppose you are stitching an episiotomy, it was a primary gravida unbooked patient. अब आप रात को 3 बजे उसकी episiotomy स्टिच कर रहे हो तो episiotomy की जो नीडल होती है तो कर्व्ड होती है. That curved needle will a double-edged blade that will cause even more transmission of the virus. No, एक तो hollow bore needle hypodermic. I'm saying episiotomy needle is a double bore needle that will cause even more damage. So surgeons, gynecologists, they don't touch patients if HIV, hepatitis B is not there in emergency cases, in elective cases. Okay. Now the aspect to be understood is if the titer of the antibody is less than 10, if the titer of the antibody is less than 10 international units per ml, then you will say that this guy will require a single dose of vaccine. The person will be requiring a single dose of hepatitis B vaccine that is given to the patient intramuscularly. The subunit vaccine will be given intramuscularly to the doctor. But if the person is not revaccinated will also be in the option. Then it will be single dose of hepatitis B vaccine that will be given to the patient. But if the value is more than 10 international units, then you will say no need. You will say, buddy, you are well protected. No need of further intervention. These are again two questions that I have currently highlighted. So I would like you to be very clear about them. One is that you have to give hepatitis B immunoglobulin within 24 hours. But if it is security system evaluation, then it is single dose of Hep B vaccine or no need of further intervention to be done. So I will talk more about these aspects when we start again. Let's go for a tea break. And we can start at 6 o'clock, right? So it's almost 5:30. At 6 o'clock, I'll start again. And then we go for the next session for today. Okay, guys. See you. Yeah, I'll come to that, man. I'll come back to that. Sairaj, wait. Otherwise these guys will get too restless. So I'll talk about the vaccine non-responder and what is to be done. I'll come back to that. Okay. No, nothing to be done, man. If patient is negative, nothing to be done. Okay, ji. guys, welcome back. Let's get started. There's no voice, surprisingly. Could be voice. Okay, give me a second. Sound check, sound check, sound check. Sound check. Okay, fine. Fine, guys. So, fine. We have a test also lined up tomorrow. The test will be conducted at 6 p.m. onwards, and that will give you the day to study also. And then subsequently, like in the evening around 8 o'clock, I'll be taking a discussion. I'll repeat my statement. I'll say it at the end also. The test that is scheduled for tomorrow will be conducted in the evening so that at daytime you can study the subject. The test goes for 75 MCQs. That would be like 6 o'clock onwards. And then about 8 o'clock onwards, we shall be going ahead with the discussion for the same. Okay. Now I will be addressing, I hope everybody has joined back. I will be addressing a question to you guys, though somebody asked it, but I'm just putting it as a counter question. How many shots of hepatitis B vaccine should be taken? Like all of you would have taken the shots of hepatitis B. So what is how many shots would be taken? And at what gap? Can you just quickly comment the gaps there? It is 3 shots of subunit vaccine. The vaccine that is taken is a subunit vaccine. Yeah, it is total of 3 shots, sir. It's a subunit vaccine. उसमें कितना एंटीजन का डोज होता है वो भी पूछा हुआ है. तो जो एंटीजन का डोज होता है दैट इज 20 माइक्रोग्राम. बच्चों के लिए 10 यूनिट होता है, एडल्ट्स के लिए 20 माइक्रोग्राम होता है. एंड द प्राइमरी कोर्स विल बी 0, दैट इज टुडे, देन आफ्टर 1 month and then at 6 months. So let me say you have cleared your exam and you have to join internship fast. You can do 012 also. So there are 2 regimens, 012, 016 and 012, but 012 is for faster immunity, but usually recommended is 016. After taking the primary course, the protection antibody titer should be more than 10 international units per ml. But if in the patient the value is less than 10, then you will repeat the course. And unfortunately, you have given the vaccine 2 times. You have given it at 0, 1 and 6. Like there was no problem with the dosaging also. There was no problem with the brand also. Proper, proper like the chain of production to the consumer chain was basically maintained. And unfortunately, after like 2 courses, if the titer of the antibody is still less than 10 international units per ml, then the technical word we will use for the patient is a true non-responder. What I mean by the word true non-responder to hepatitis B vaccine is that 2 courses are being given. The word is true non-responder. Meaning of the word true non-responder is that 2 courses have been given to the patient. In spite of giving 2 courses, I'll repeat my statement, 2 courses of vaccine has been given to the patient, and in spite of that, there is no security system inside. So we will say is a non-responding to hepatitis B surface antigen. And in these circumstances, if he says, what will you do if the person will be developing occupational exposure? Like usually we will not keep this patient. Ideally, like this guy should not be a healthcare worker, and ideally this guy should not be handling at least emergency cases, especially related to blood sample. Like the person can be assigned to a desk job also. So the hospital can do internal arrangements also, and the guy can be given administrative work and not doing sampling work. I mean, like suppose it's a doctor, then it's not necessary always that you prick the patient, na? That you could be doing routine examination, routine care of the patient without having to do any interventions in the patient. But suppose if he has to do intervention and if there is occupational exposure, then there is hepatitis B immunoglobulin to be given in the patient in 2 dosages. This is a question of, this is a PYQ that I'm covering, that the question in the paper said the patient is a true non-responder, and like what intervention should be done in a non-true responder. So in all cases, you don't need to give immunoglobulin. It is only if there is an occupational exposure. I have highlighted that statement. Routinely you don't, if somebody is a non-responder, let it be. Assign a desk job to the guy. Put him on non-critical care. Don't put him on critical care management. We can do that internal arrangements in the hospital. But if there is a occupational exposure in the patient, then you have to give 2 dosages, that these 2 dosages of hepatitis B immunoglobulin passive immunity should be given 1 month apart. I mean, this is one clinical scenario that was asked in the exam, that what will you do for a true non-responder? It is 2 shots of hepatitis B immunoglobulin now that should be given 1 month apart in the patient. This is one question that I have covered at the moment. I'll do it again in 30 seconds. If they give you a case like this, true non-responder, 2 shots, 2 courses covered. 016 antibody less than 10. What do you do? Assign him a desk job, non-critical care. But if occupational exposure occurs, what will you do? Immunoglobulin, 2 dosages, 1 month apart, that is one. Second question that was asked was that, sir, what will happen if somebody is having a co-infection or super infection? The meaning of the word co-infection is that acute hepatitis B is also there and acute hepatitis D is also there. So what is the main antibody that will help in identifying? It is IgM class of antibody to the core antigen. If this antibody is present, it means it is a co-infection. And if this antibody is absent, then we say it is a super infection. Simple answer in the question. If there is gonna be IgM class of antibody to core antigen present, you will say co-infection in a patient. Now let me explain this to you also. Explanation part you don't need to note down. I have a patient who is a IV drug user. The explanation part just to be listened to. I have a IV drug user. This IV drug user, to fund his drug habit, he operates at Green Park Metro Station in South Delhi, and he does pickpocketing and mobile snatching and stuff like that. And because of IV drug habit, he recently got infected with IgM class of antibody to the core antigen. So this is his serological status. His surface antigen is positive, his IgM class of antibody core antigen is positive, and therefore this guy who came to my hospital and is diagnosed as acute hepatitis B, I've also found out that the guy happens to be, like, to fund his drug habit, doing illegal job. Now, because the crime in the Green Park area was increasing, so the SHO called all his constables and he scolded them that what are you doing? The crime in the part is increasing. I'm getting calls from ACP, DCP that they'll suspend me. So you immediately act. So the constables, they picked up all the IV drug users, because cops, they get commission from all these kind of illegal activities, and therefore they rounded up all these guys, and this particular guy was beaten back and blue. They beat him, put him in police lockup for 1 day. After next day, they did not register a case also. Next day, they told him, get lost from this area, go anywhere, but don't be seen in Green Park area. Half the time cops are hands in glove and they'll not arrest these guys, no court case, nothing, no police case. And the guy was not told, just get lost, get out from the South District and go to East District. So now he's gone to, let me say, East Delhi. Now this guy has gone to East Delhi, some district like Shadra or Mayur Vihar or some other place. Their metro station, he's committing crime. So this is the status of this patient, let me say, in the month of May 2026, that this particular guy, let me say, this is the status of this patient in April 2026, that this IV drug user was having acute hepatitis B. The cops beat him, and now he has moved on in the month of May. This particular guy has gone to East Delhi area. Now in the East Delhi area, he's also doing IV drug use. And there, from that group, that's a closed group of IV drug users. They do that needle popping, that Kurta Punjab kind of a scenario. So this particular guy got infected against hepatitis D, and the antibody against hepatitis D is IgM class of antibody to the Delta virus. Now this particular guy from a different group has got another acute infection, that is Delta virus. If somebody will be having two varieties of acute infection, somebody is having two varieties of acute infection, then I will say it is a co-infection. If somebody will get two types of acute infection in a span of let me say 1 month में body में दो infections आ गया, he's having B infection also and he's having D infection also, the same guy, then I will say that this is a co-infection that has occurred in a patient. So this is what I'm saying, that how does a doctor determine it is a co-infection? Obviously D antibody titer will be done, but the main thing for differentiation will be IgM class of antibody will be present only in co-infection. In super infection, the acute infection has resolved, the guy will go into chronic, and therefore the IgM class of antibody would be absent. If you don't want to get into all this logic and what happened earlier, what happened in April, what happened in May for the co-infection part, just understand two infections together. English is co, and what is the antibody which will help in diagnosis? IgM class of antibody to core antigen. The same thing is what I write here at the moment. The question was, how do you differentiate co-infection from super infection? That is what I've highlighted. And another question I covered was, like, if there's a true non-responder, how many shots of immunoglobulin should be given? 2 shots, and these shots should be given 1 month apart. Obviously the dosages would be given intravenously. For HIV transmission, the chances of transmission are 0.3%. There it is TLD. What I write next, it is optional if you want to note down. I think the PSM teacher, even the pathologist would have covered it, but I will just take 1 more minute into describing this, and then I'll come back to cirrhosis of the liver. If a person is having an accidental needle stick injury, If a person is having an accident needle stick injury from a HIV positive patient, like this doctor had ensured that he is using double gloves, but the patient is HIV positive and he got a prick. So what are the chances that the doctor can still get the infection? The chances is 0.3%. Usually the HIV virus is a very fragile virus. It dies the moment body temperature decreases less than 37 degrees Celsius. The moment is blood is out of the body, HIV virus dies. That is why in this particular case, the chances of transmission is very, very less. This guy, when he asked you, what are the chances? You said 0.3. He said, buddy, like, even this is sufficiently, I mean, 0.3% is less, but still transmission can occur. So what will we do in this patient? That is TLD, that is tenofovir, lamivudine, and dolutegravir will be used in this particular patient. This is the same medicine. This is the same medicine which is used as once a day pill for management of AIDS. Tenofovir, lamivudine, and dolutegravir, which is an integrase inhibitor, are the medicines that we will be using for these patients. And like he has asked, these medicines should be started within how many hours should you be starting the medicine? Can you quickly comment here, like within how many hours will you start the medicine? Options are like within 4 hours, 8 hours, 24 hours, 72 hours. Yes. Tenofovir, lamivudine, and then dolutegravir are the 3 medicines that would be used in this part. वो ना basically dose की तो जरूरत ही नहीं थी, क्योंकि all the options that were given were having different drugs that are present. So it is tenofovir, lamivudine, and dolutegravir. Yeah, we should start within 4 hours. No, the 72 hours is answer for a different MCQ. That is, he will say that this is gonna be not effective after. If the question says, like I got answer is 72 hours also. So the question, if he says with this algorithm is not effective after, then your answer will be 72 hours. If he says start within, then answer is within 4 hours or as early as possible. Then another question that they've asked is, what is the duration for which the doctor or nurse or healthcare worker will be given this medicine? So the duration of treatment will be for how long, guys? Yes. How long? And what will be the duration part, right? Yes, guys, the duration part. The duration part will be 28 days. No, 28 days, guys. I think this is very simple MCQ. This you are already aware of. 4 hours, 72 hours, and then it's gonna be, this is 28 days. 4 weeks के लिए the treatment will be given to the patient. Yeah, 1 month is the treatment that will be giving to the patient with respect to accidental needle stick injury in a patient. Chances of vertical transmission are obviously high, but then the needle stick injury is only 0.3% hypodermic needle temperature sensitive virus, so the virus will die relatively early. Just to finish this, with HIV, the chances of transmission are already discussed with you. For needle stick injury, the chances of transmission are 0.3%. Can you tell me for C virus, please? What are the percentage of chances of transmission? Accidental needle stick injury, revisited fast again. Accident needle stick injury, what is the percentage of transmission for hepatitis C virus? Answer is 3%. And for hepatitis B, it is 30%. These are the values which are to be remembered. Please don't jumble them up. This is 0.3%, 3%, and 30%. These are the mathematical values which are to be remembered. If somebody will get C virus, then there is no post-exposure prophylaxis. Wait for the person to turn positive, and then subsequently you will be starting C ka ilaj. That is the C ka ilaj that you will be starting will be in the form of sofosbuvir and velpatasvir for management of the patient. The next question, the last one before I go back to cirrhosis, is addressed to all the FMG students. This question said that patient got infected with HIV today. It could be blood transfusion, sexual contact, whatever. After how many days of getting infected? Like suppose he got a needle stick injury today. It's a nurse, sister G, she got infected. And like after how many days ELISA test will turn positive? After how many days of getting infection will the ELISA test turn positive? Somebody gets exposure today. This is the exposure date, day 0 to HIV. The ELISA to HIV will turn positive after how many days? 10 days, 2 weeks. Okay, can I have better answers, please? And I think that's not a difficult question. And this is frequently asked in the paper. Sir, the infection, like I expect you guys to know this from microbiology, that it will turn positive. The fourth generation ELISA will turn positive on day 22nd. It is on day 22nd that the antibody titers will come in the range of being detectable. Antibody titers are rising like this, na? Antibody titers are rising like this. So you will notice that by 22nd day, the antibody titers will be sufficient for detection. So I wanted to bring to your attention the concept of window period, that during this particular period, if you will be doing ELISA for the person, if you will be doing a ELISA for HIV for the patient, the report will turn out to be negative. And if you at this point of time take blood transfusion for this patient, like if he will donate the blood in the window period, serum ELISA for HIV turns positive on day 22. Serum ELISA for HIV will turn positive on day 22. So a patient will be coming to me in the first 22 days and donating blood in my blood bank. My blood bank will receive that blood, and now this blood given to somebody, that person will turn HIV positive. That person will turn HIV positive. So I'm not supposed to allow that to happen. So therefore, a question in the paper said, what test will be done for early detection? Now this is a different year question. He changed the question. He said a nurse got exposed to HIV infection during her posting, and like she's saying that help me identify the infection early, because ELISA test is gonna be positive later. So what test will we do in the patient? Yes, your answer is PCR HIV RNA. PCR HIV RNA will turn positive something around 7 to the 10 days. So the test that should be done for early infection, that is the question that I basically wanted to address. It is a PCR HIV RNA levels that should be done in this patient. When I was a student your level, when my consultant on the rounds asked me the same question, we had a different answer. This answer is valid even today. Even if you go through the PYQs of the FMG exam, you will notice this question is very much there, that P24 antigen will turn positive on which day usually. So P24 antigen report usually turns positive by something like 42 days. Yes. P24 antigen turns positive by usually the usually the 14th day, and therefore the exposure to HIV, if it has occurred in anybody, then it is P20. Then the answer, like the sequence is like this. First answer is PCR HIV RNA, because it will turn positive by 7 to the 10th day. It will turn positive by 7 to 10th day. So this is recommended. If it is not in the options, answer will be given as P24 antigen. If this is also not in the option, then the answer will be given as serum ELISA for HIV, which will turn by day 22. So remember, 7 to 10 days, 14 days, day 22 for the 3 testing that I've highlighted before at this moment. Yeah, that guy is a billionaire, no? Dan Bilzerian. Yeah. Crazy people. Americans are crazy people. Exposure to HIV, PCR HIV RNA, then is P24 antigen, and then is serum ELISA for HIV. This is the sequence that you basically need to remember. First is PCR, then is P24, and this is serum ELISA for HIV with respect to exposure to HIV. Whether the MCQ is mentioning occupational exposure, sexual exposure, whatever, then in those circumstances, like we will be like, we'll have to stratify the answer here. And if nothing is given, he says what is best, then like exposure to HIV, then the first answer would be PCR HIV RNA. Okay, so I think we sorted for these miscellaneous kind of questions, and let's go back to the theory component. Some easy stuff coming your way even further. And next is, okay, yeah, these graphs are also left. So graphs are very simple, guys. I just want to say that they will give you a graph which will be biphasic. What I mean by biphasic is, this is one graph, right? If I do markings here, like this is one graph that is given for surface antigen turning negative, and then is the security system graph which is given here, that is antibody against the surface antigen. So if they give you a biphasic curve like this, where you are noticing that at the bottom Week's word is written, then you will say acute hepatitis B. This question actually came in INICET exam, that they gave a biphasic curve like this, where there was mentioning of surface antigen and the security system, and it was Weeks written at the bottom. So people were able to figure out that this is acute hepatitis B. But if you look at the inferior graph, you will notice that it is more flat. It is more flat curves. Like, all the curves are very flat. Like, it's not very biphasic. And you can notice that at the bottom, months is written. So you will say chronic hepatitis B. So though I can get into the technicals of each one of those, but ultimately speed is important in answering the questions. If I save time here, I will be able to invest this in a different question. the learning part for you guys is that if you get a graph in which the viral markers are given, but the graph is more flat, right? Surface antigen, antibody is the core antigen. You can see like it's a very flat curve that are given, and months is also written. Then you will say chronic hepatitis B presentation. But suppose I change it and bring it to the attention of yours once again. I will remove the marking so that it's not so obvious. I'll remove the marking here also so that it's not obvious. Like you can see here, two graphs given, different colors were given, right? The way I've shown two graphs, two different colors, red, green, red, green. So if it's a flat curve, answer chronic. And if it is a biphasic one, then you will say that the person is suffering from acute hepatitis B. So these graphs are like just, I think they just need the treatment that they deserve from like nothing to be worried from the mathematical perspective. Like normally graphs are like which sends shivers up our spine कि हमें graph interpret करना पड़ेगा. The message is simply biphasic versus uniphasic, and you are sorted for acute hepatitis B and chronic hepatitis B. Now once that is done, we will now focus on the topic of liver cirrhosis. I've already explained to you that the most common cause is non-alcoholic fatty liver disease with more than 5% of the hepatocytes undergoing a steatosis. Can you tell me a test that is done for diagnosis of cirrhosis? The gold standard is liver biopsy. The gold standard is liver biopsy because in pathology you will hear about stellate cells which are causing fibrosis, and then you read about various stains for fibrosis. No, that the various stains for like reticulin stain for fibrosis can be used. My question is like why to go for liver biopsy in an era of non-invasive test? What is the non-invasive test that will be done? Yes, the non-invasive test is FibroScan. Non-invasive test is FibroScan. Nowadays, like you will notice lot of doctors writing this test for the patient, that is FibroScan, because ultimately there is a fibrosis in the liver of the patient. So if whether person is having fibrosis due to non-alcoholic fatty liver or due to alcoholic fatty liver, the answer is still the same. FibroScan will be done, and the drugs which are approved but not routinely used are, one is resmetirom. Resmetirom is a thyroid hormone. This is for pharmacology. Please remember it is a thyroid hormone receptor beta agonist, and you can very well understand thyroid hormone receptor agonist means it will cause burning of calories, and today we are burning fat. Yeah, other name is transient elastography. Ashok, you had a good input there. FibroScan is like more of a brand name. He can also give this name like you would have done questions where this word came in, so that was a welcome comment that you gave me. Transient elastography is the other name for FibroScan that can pick up the fibrosis in the liver of the patient. Now the drug we are using in this condition is resmetirom. How it works, it stimulates the thyroid hormone receptor, and thyroid hormone basically burns calories, so it will burn the fat in the hepatocytes for you guys also. Or the other drug that is available is semaglutide, which is universal drug for diabetes. It is drug for patients having heart disease with diabetes, and now even for fatty liver it is being used. And the latest one that has been introduced, it is only phase 3 trials. This is only for INISET people, like it's just recently approved, that is lanifibranor. That lanifibranor is only phase 3 trials because they randomly put up at least one question on some kind of new drug. So there's no limit to how much you can remember. But yeah, if we are lucky, maybe we might score one there. So it is Ozempic and resmetirom, which are the main weapons which are used only in selected cases. Otherwise, it is weight loss, which is the main intervention that we'll be doing. Now, the problem with cirrhosis is that the liver will become smaller and person will go to end stage liver disease. So we will need transplantation. So there is a scoring pattern that you are studying in pathology also, that is called as child score. There's a scoring pattern in pathology that is called as child score. Yeah, used for weight loss also. Yes. Now the aspect is severity of cirrhosis. Like how do you decide the severity of cirrhosis? Answer is child score. The parameters in child score are as follows. One of the parameter will be bilirubin. Another parameter will be international normalized ratio. But then there are a couple of parameters that begin with alphabet A. It is those that begin with alphabet A that I wanted to remember for child pug score. Parameters are bilirubin and international normalized ratio. But there are 3 parameters beginning with alphabet A that I wanted to remember. The first A will be for serum albumin levels, because liver is responsible for synthesis of albumin. So albumin will become less. ALP nahi beta, albumin. Then if albumin will become less, person will get ascites also. If liver will be damaged, ascites also. And another feature that will be seen in the patient is development of flapping tremors. The flapping tremors will be because ammonia will be rising in the body, that is asterixis would be developing. Asterixis is flapping tremors. You will ask the patient to extend the hands like this, and you will notice the flapping tremor coming up on extension or you get flapping tremors on extension of the wrist joint in the patient. So it is three components that would be present: albumin, ascites, and asterixis, because when the liver will fail, ammonia will rise. Ammonia causes ammonia intoxication. It damages the brain, and that's why these tremors in the form of asterixis can be occurring in a patient. And with this child pug score, if the value of the score is more than 8, if the value of the score is equal to more than 8, then we will register the patient for orthoptic liver transplantation. It's a brain dead donor who will be donating. See, family members will also donate, but the same issue, like we discussed in kidney, they'll refuse. So person will be dependent on availability of a brain dead donor. So we will register for orthoptic liver transplantation. That registration does not mean that we are doing transplantation immediately. That transplantation is dependent on the availability of the organ. That may become available after 6 months, 1 year, 2 year, 3 year, or the person may die waiting for a liver transplantation as well. So at this particular point, I want to bring to your attention is that you have to register the patient for orthoptic liver transplantation at a value more than 8, and there are 3 A's here: albumin, ascites, and asterixis. Classes are also given, but at least minimum I expected to remember is class B, and B also looks like 8 now. Number B, like when you write alphabet B, तो थोड़ा सा 8 जैसा लगता है. So there are 2 points I said: class B / number 8 on child pug score. It's an online calculator. Just feed the bilirubin, INR, albumin, ascites, asterixis, and you would be able to get the final result whether you need to go in for transplantation in this patient. Now, nowadays, because we have evolved, we are using a MELD score also. MELD score is model for end stage liver disease, where the 3 parameters which begin with alphabet CBI. Like today, CBI is not the Central Bureau of Investigation. The parameters which we are taking into consideration are serum creatinine, then is gonna be serum bilirubin, and then the subsequent one is, the patient is going towards decompensation, and then would be international normalized ratio. A query that I get from lot of doctors is, sir, why are you using creatinine when the liver is failing? It is because of a complication by the name of hepatorenal syndrome. You would have seen the fact that when liver will fail, then subsequently even the kidney of the patient will fail. So though they will not ask you this, I just wanted to sensitize you to the fact that if the liver will fail, the toxins that will accumulate will damage the kidney also. So therefore, hepatorenal syndrome is a complication, which is why creatinine is taken into consideration in the MELD score. In MELD score, the minimum value is 6, maximum value is 40. And if a person is scoring more than these values, even if you don't remember, I am telling you these values only to sensitize you to the fact that why are we doing this hassle? Why are we using an online calculator? Why are we feeding the bilirubin, INR of the patient, and unnecessarily making our life difficult and the patient life also difficult? No, we are not making life difficult. We're trying to make it simpler. If the value is more than 17, we will be registering the patient for orthoptic liver transplantation. So the older guidelines that I have been studying for, like when I was a student your age, then I used to study only one child pug classification over 3 A's and bilirubin and INR. Now it is CBI, that is creatinine, bilirubin, INR, and then it's MELD 3.0. When it comes to MELD 3.0, CBI components are already there. In MELD 3.0, like we have versions in the app now, 3.0, 4.0. Similarly, you can say this is the version. So CBI component is on. The additional components here will be one, sodium, and the additional component which is present here is albumin. So now there are 5 parameters in the MELD score. If he mentions the word MELD 3.0, then you will say creatinine, bilirubin, international normalized ratio, sodium as well as albumin is to be considered. If they will ask you questions on this topic, they will all just jumble the data and say all of the following are components. All of the following are components. And most of the time, what I have seen is a trick played by the examiner. You see, international normalized ratio is also called as PT. INR, international normalized ratio, is also called as prothrombin time. So what he will deliberately do is, he will write a wrong parameter here. Obviously, you will pick it up immediately, but जल्दबाजी में तो PT और APTT में गलती हो सकती है. So I just wanted to remember the parameter is INR, also called as PT. I'll tell you the meanings of these also subsequently. But then INR and PT is the parameter, that is the one which is gonna be used. And this is obviously going to be the wrong thing in the question. This is deliberately introduced in the question to introduce an error. He will say which of the following is not a component of MELD 3 score. Answer is APTT, obviously, because I'll discuss PT and APTT separately. Otherwise, this becomes too clumsy, because at the moment you need to remember like 3 details on the left, 2 additional details on the right. That is total of 5 already. So already the load is on which parameter is there or which is not there. So if I move my slide up at page number 170, what you can notice is the 3 A's that are striking. And at this moment, it is CBI with serum sodium. That is important. We are basically trying to grade the severity. We are trying to say who will be getting transplant early, who will be getting a transplantation later. Yes, yeah, doctor, you're right. It is an FMG exam question repeated in NEET PG also. It is like, I forgot what I was saying. Yeah. The parameter to be remembered is 3.0, where albumin and serum sodium is always a component, and that helps you strategize, right? Which patient will be given a priority, right? It's not about who came first, who came later. It's about the score value so that we can strategize and plan treatment of the patient. And now, because ascites is a universal manifestation of liver damage, so they always put a questions on SAG, serum albumin ascites gradient. Just like we have studied the word transudate in respiratory system, and we have studied exudate in the respiratory system, in the same spirit, it is transudate and exudate only. The only thing is that they just want to make our life miserable, so they will write mathematical values like SAG less than 1.1, SAG more than 1.1. We will try to remember these. That is, SAG less than 1.1 is for TPN. TPN, yeah, just like Light's criteria. TPN is like routinely for us as doctors, TPN is total parenteral nutrition. But I want to write a cause like TB at the moment, TB of the peritoneal cavity. Just like I was teaching you exudate, now I told you TB and lung cancer, same spirit. I will write the cancer here also. What is the cancer I'm writing? It's not directly cancer, it is peritoneal carcinomatosis. You see, any cancer that goes to the peritoneum will irritate the peritoneum and will cause ascites in a patient. So the word is peritoneal carcinomatosis. I can draw parallels here. Yeah, Nadeem, I'm coming to pancreatitis. Give me a second. The point I want to draw is a parallel. When I was teaching you exudate, जब मैंने exudate पढ़ाया था, तो मैंने वर्ड बोला था टीबी एंड लंग कैंसर, और यहाँ पे भी तो वही है, टीबी एंड कैंसर, बट लंग की बात नहीं कर रहे हैं ना, पेरिटोनियल कैविटी की बात कर रहे हैं, तो पेट के कैंसर की बात करूँ. The cancer which is going to be talked about in this particular case are two. One is ovarian cancer and the second one is stomach cancer. Ovarian cancer and stomach cancer are the causes of development of peritoneal carcinomatosis. So TPN may at the moment it is like two down. Now P alphabet is also to be remembered for pancreatitis. Pancreatitis can contribute to pleural effusion. Yes. Left-sided sympathetic effusion. But today pancreas is inflamed. You can have a ascites in the patient also. Pancreatitis can cause ARDS, it can cause a pleural effusion, and it can result today in a ascites component also. So as such, when you deploy the components which are present, nobody I think will ever miss this out, including the N component here, which is called as nephrotic syndrome, where there is a proteinuria component present, where like you are having loss of proteins in the urine of the patient. So TPN mnemonic is the one that if you remember, then questions that are asked on the topic will be of the all except variety, that is SAG value. What you need to remember for today is SAG value less than 1.1. Now I will teach you the transudate scenarios of SAG more than 1.1, where standard answers are there: alcoholic liver disease, Budd-Chiari syndrome, sinusoidal obstruction, sinusoidal veno-occlusive disease. So as such, I don't think so. If you remember right, left can be worked out. But there is a slight trick which is specially of interest to NEET PG and INISET examiners, which is this word by the name of late Budd-Chiari syndrome and early Budd-Chiari syndrome. Like you can notice slight difference which is present here. Like for early, I will tell you what is Budd-Chiari also in like about 2 minutes from now. But Budd-Chiari syndrome, if it is early, then there will be good amount of protein. There will be good amount of protein in the peritoneal cavity, more than 2.5 gram. But in the late Budd-Chiari syndrome, because there will be fibrosis, alcoholic liver disease, there would be fibrosis. Portal vein thrombosis, long standing, there will be fibrosis. So the protein will not be able to come. I'll repeat that again. In early Budd-Chiari syndrome, there is no fibrosis in the liver. So therefore proteins can come in the ascitic fluid. But on the other hand, if I say late Budd-Chiari syndrome, then there will be bound to be fibrosis present, and because of this fibrosis component, this would be having less proteins present. So especially if you're a NEET PG or INISET aspirant, just take care of the fact that Budd-Chiari is a transudate. SAG value will be more than 1.5. What you need to understand or remember, minimum I expect you to remember is कि आप सोच के देखो, अगर फाइब्रोसिस होगा तो प्रोटीन आ पाएगा क्या? नहीं आ पाएगा ascitic fluid में, तो प्रोटीन की मात्रा ascitic fluid protein value will be less than, that's what is written here, less than 2.5. इसको एक बार लिख के प्रैक्टिस कर लेना SAG value में. चलो लिख देता हूँ so that this you are able to retain this. This is what they expect. He will say which is correct about late Budd-Chiari syndrome. तो आपने क्या करना है, दोनों एरोस को उसने कॉम्बिनेशन बना दी है. सैग इज मोर देन 1.1, वो तो हो ही गया ना, सैग इज मोर देन 1.1. सेकंड इज वो लिखेगा यहाँ पे असाइटिक प्रोटीन because of the fibrosis component acidic protein is less than 2.5 gram per deciliter. उसने कॉम्बिनेशन बना दिया, both more less more less, जैसे वो हर बार मैं बताता हूँ आपको. दिस इज द फीचर दैट इज सीन विद लेट बर्ड-चियारी सिंड्रोम. एफएमजी में उसने ये नहीं पूछा है, इतना टेक्निकल भी नहीं किया उसने, बट हाँ एक बार सुन जरूर लेना ताकि एटलीस्ट आपको ओरिएंटेशन हो जाए कि यार किस टाइप के क्वेश्चंस वो फ्रेम करता है. क्योंकि देखो अभी तो मैं बोल रहा हूँ तो आप बोलोगे हाँ सर याद हो गया, मोर देन 1.1 लेस देन 2.5, लेकिन अब आज से 10 दिन के बाद में तो नहीं याद रहता. तो इसको जो भी पॉइंटर्स मैंने लिखे हैं ना, जो मैंने बोला यार ये पीवाई क्यू है, तो ये पीवाई क्यू इंपॉर्टेंट क्यों है कि वो चेंज करके अर्ली मार देगा यहाँ पे, वो जानबूझ के अर्ली कर देगा तो वैल्यू चेंज हो जाएगी ना. फिर एसिटिक फिब्रोइड प्रोटीन वैल्यू विल बी मोर देन 2.5. कैन आई गेट अ क्विक नॉड फ्रॉम नीट पीजी एस्पिरेंट्स? कैन यू जस्ट गिव अ थम्स अप और लाइक कमेंट अंडरस्टूड और नॉट? Yes guys, no, that is just Siva Balan, like I'll not get into that exudate thing. It's just a way of explanation. You will notice अभी थोड़ी देर बाद में ना I will remove that exudate and transudate, because when I was talking about transudate exudate I was not doing any subtraction. यहाँ तो gradient है ना, serum albumin ascites gradient. This is just a way of understanding. So Siva Balan, you have a very good point there, but I think that I've been able to explain this. And now I'm going to remove the word transudate exudate because that is not the accurate way. देखो, I have to give you hacks how to remember this. So I was on the verge of saying कि यार transudate exudate मैं हटा दूंगा, because yeah, that causes error, because here what we are doing a calculation. Here what we are doing is we are doing a calculation, that is a gradient that is being created. In the previous one there was no calculation being done. So I hope that gives justification, man, and this is clear. And now once we have understood this table, TPN versus the causes that I have highlighted, देखो अल्कोहलिक लिवर डिजीज कोई चैलेंज नहीं कर पाएगा. अल्कोहलिक लिवर डिजीज में फाइब्रोसिस होता है, तो सैग इज मोर देन 1.1, एसिटिक फ्लूइड प्रोटीन लेस देन 2.5. उसमें कोई डाइकोटोमी वाला डेटा नहीं है, बट लाइक डाइकोटोमी इज अर्ली एंड द लेट, सो जस्ट गेट द लेट वाला कंपोनेंट राइट. एंड आई ऑल्सो वांट टू से दैट अ लॉट ऑफ यू माइट बी ड्रिंकिंग ग्रीन टी हर्बल टी थिंकिंग इट इज गुड फॉर हेल्थ. हर्बल टी इज गुड फॉर वेट लॉस. नो गाइस, these herbal teas cause damage to the liver. These herbal teas cause damage to the liver and they cause veno-occlusive disease. Even yesterday, the liver doctor, I think you're aware, there's one doctor in Kerala, he's a hepatologist. He's a DM hepatologist, and he has been given police summons to appear for a court case by a Ayurvedic company. Because ultimately, like, see, you and me are scientific people. We go by randomized control trial, meta-analysis. If do a randomized control trial, randomly give a drug to a patient and see whether it is effective or not. You just can't say this medicine has no side effects, right? So this doctor, sir, fibrosis will again cause portal vein thrombosis in long run will cause fibrosis. I said that, Sairaj. I already explained that. That liver doctor was given summons by a Ayurvedic company, and he's having a criminal case filed against him, and it's non-bailable. So obviously it becomes a very hassle, because will you practice silently, or would you be like in peace, or would you be fighting all these people? But I just want to tell you guys that these, like, they market it as without a side effect, and they say this causes weight loss. There is no documented study regarding it, right? So sinusoidal obstruction or veno-occlusive disease would be occurring, and that can cause definitely issues in the patient. And I can also add one more statement here from the topic of PSM. If you study about food adulterants, have you read about the term endemic ascites? Have you read about pyrrolizidone alkaloids? Comment in the chat box, yes or no, guys. Have you read about endemic ascites, pyrrolizidone alkaloids? Right, that's due to a weed that's called the Junjunia. And there's a weed called the Junjunia. Yes, I know. PSM में food adulterants में दिया हुआ. Yes, very good, very good. I just like that comment. So I just want to say that even in that endemic ascites, where is the damage present? In endemic ascites, the cause or damage is veno-occlusive disease. That is the small hepatic vein sinusoids that will be getting in the patient. That would be Junjunia. Yeah. No, not epidemic dropsy, beta. Epidemic dropsy to is Argemone mexicana. Epidemic dropsy is Argemone mexicana. वो तो मस्टर्ड ऑयल होता है ना, जो जैसे आप देखोगे ना, हम लोग तो सेफ्लावर ऑयल यूज करते हैं, बट जैसे पुअर पीपल जो होते हैं वो गाढ़े पीले रंग का ना मस्टर्ड ऑयल यूज करते हैं. तो दैट कंटामिनेटेड मस्टर्ड ऑयल इज epidemic dropsy. That contaminated mustard oil is epidemic dropsy that causes heart failure. कि जो कुकिंग ऑयल है ना, जो मस्टर्ड ऑयल होता है, उसमें वो अर्जिमोन मैक्सिकाना के सीड मिला के, उसका मतलब उस अर्जिमोन मैक्सिकाना से निकाला हुआ तेल मिक्स कर देते हैं. And when somebody will eat that contaminated mustard oil, he will go into heart failure. That is called as epidemic dropsy. Yeah, in this particular case, it is like pyrrolizidone alkaloids, endemic ascites as a manifestation can be occurring in a patient. Yeah, exactly. The toxin is that sanguinarine that would come up, and therefore, I just wanted to say that this would also be having is a VOD, a vein-occlusive disease in the patient. So herbal teas really have not been able to demonstrate any significant benefit, but this table is called as SAG and serum albumin ascites gradient, so it must be studied at least once. If any patient is having ascites, then we also need to go for ascetic tap. Like in all patients who are having ascites, first we will try with medicines. Spironolactone is the drug of choice. Like I'm showing a patient, this patient was very thin and skinny, but today this person is having like, you know, extreme abdominal distension. There is like fluid filled up in the peritoneal cavity of this patient. There is fullness in the flanks of this patient, and there is a lot of fluid in the peritoneal cavity of the patient. This is the shrunken liver. This is the shrunken liver. The liver is like small. This is a small, shrunken, irregular contour liver. It's like having nodules also present, and the reason for this is that there is ascites component which is present, free fluid in the peritoneal cavity. You guys can comment by looking at the slide or without looking at the slide. What is the preferred site for abdominal paracentesis? What is the preferred site for abdominal paracentesis? Like yesterday evening around this time, I was teaching you regarding site for pleural tapping. Today, I am asking you the site for abdominal paracentesis. My patient is not responding to spironolactone and the conventional diuretics. So what will I do here? I will be putting a needle in this particular area. If I do a diagrammatic line representation here, we will usually be going about 2 centimeter, about 1 inch below the umbilicus. We will be going 1 inch below the umbilicus. That is the site in the midline. This is linea alba. This is linea alba. This is rectus abdominis muscle. This is rectus abdominis muscle. So what I want to do is I will go in the midline and I can be taking a sample. Or another part can be that I can be using anterior superior iliac spine as a landmark, and I can be putting a needle in the flanks of the patient also. Like I can put a needle in the flank also. There are two sites for prank. There are two sites where I can be going ahead and do a paracentesis in a patient. There are two sites where I can be doing is a paracentesis in a patient. One site is obviously that subumbilical site, or I can be using anterior superior iliac spine in a patient, that is 2 to 3 centimeter above and medial. So I'll just draw the cross a little more medial, slightly more medial, 2 to 3 centimeter above and then medial to the anterior superior iliac spine. I can put the needle in the flanks. The objective of mine is that I want to avoid injury to a blood vessel. There is a blood vessel that runs like this in the lateral border of the rectus abdominis muscle. There is a blood vessel that runs in the lateral border of the inferior epigastric muscle that I've shown in color green. I want to avoid injury to this blood vessel. So that is why either I'm gonna be medial or I'm gonna be lateral to the site that I have just shown of the blood vessel. And what is the name of this blood vessel which will be present in the lateral border? What is present in the lateral border of the inferior what is present in the lateral border of the rectus abdominis muscle? This blood vessel is called as inferior epigastric artery. If I put my needle a little laterally to in the muscle, then I can injure the artery and that will cause bleeding also, which will be very, very severe. So what I will do in the patient is either I will introduce the needle subumbilical or I can go in the flanks of the patient. When I introduce the needle, I will be using the Z method. Obviously, like I will not put the needle directly. If I will put the needle directly, when I withdraw the track of the needle will cause leakage of fluid from that area. So he always says that whenever you proceed, you should always be following what is called as the Z method. The advantage of Z method is that it will form a self-sealing tunnel. You know, you would have followed Z method for injection of Jactofer. Like in OBGY, when you are giving iron injections to a lady, it causes staining of the skin. So we use the Z track method to give intramuscular injections of iron. That is again a question of your exam. Z tracking is used to give which drug? It is intramuscular iron. And then Z method is used here to basically produce a self-sealing tunnel, which will prevent the leakage of fluid of the peritoneal cavity from the anterior abdominal wall, and we can do a paracentesis and remove the fluid and we can send it to the lab. The lab people will be doing testing for proteins, cells, sugar, All the routine components that are checked in the CSF, including CBNAT, will be done in this patient, and we want to find the cause why this kind of manifestation is occurring. The clinical information that can be given in this question can be, the clinical information that can be given in this question can be two signs. The signs that I'm writing here can be one, fluid thrill. The reason for the thrill is again because there is lot of fluid in the peritoneal cavity. Or another word that can be used to describe this fluid in the peritoneal cavity of the patient is called as shifting dullness. So if you get a question on ascites, he will not straight away say ascites, he will not straight away say refractory ascites. He will say patient came to the doctor, he was having gross abdominal distension, doctor found having fluid thrill, shifting dullness, then the doctor gave spironolactone, furosemide, doctor gave amiloride, multiple drugs were given. Like you went all out aggressive, spironolactone भी दे दिया, furosemide भी दे दिया, you gave epithelial sodium channel blocker, amiloride to the patient. So three drugs have been given: spironolactone, furosemide, amiloride. All drugs are supposed to remove water from the body, salt from the body, but in spite of that, the person is still having an ascites. So if I've tried my best for everything and still the ascites is present, I will go for a therapeutic paracentesis. This that I've discussed is therapeutic paracentesis, because the person was having even breathing difficulty. The fluid will be so much, the diaphragm movement will also be limited. So meaning of the word refractory ascites is one, that there is going to be, when I say the word refractory, I imply the fact that this means medicines are not working and there is a breathing trouble that will be experienced by the patient. Now I will discuss a question on a similar kind of a presentation that came in the paper. He said a patient of chronic liver disease with ascites presents with massive ascites. Obviously all CLD patients have ascites, massive ascites, that too. Now, let me say I was the only resident on duty. MI patient came, then pulmonary embolism patient came, then pneumonia patient came. So I was busy handling those patients, and there was a delay in doing abdominal paracentesis. So this patient came at 8 a.m. in the morning today in the emergency. He came from a village, he's an alcoholic, he came from a village, he came to my hospital at 8 a.m. when the shift is changing. The last shift was not planning to admit him, they were planning to send him away. I on the round said, koi baat nahi, isko admit kar lo. But then the whole day I was busy, you have emergency walk-in cases who are critically sick. Now this guy has already spent almost close to 10 to 12 hours in the casualty. The bad news is right now his wife has come. And she's saying, sir, my husband is having high grade fever. Please have a look at him, sir. He's coming in the casualty since morning. We are thankful that you admitted him. Normally doctors don't admit ascites patient. They just do tapping and send them back home. So she says, I'm happy because at home there was a lot of difficulty. She has to cook food, how she takes care of her husband and children also. So she was like, okay, at least, hospital mein khana to milta, at least you get food. So at least she's happy that, okay, so, doctor was considerate. But now she's saying, doctor, my husband is having fever and his abdominal distension has worsened. I was like, what? I immediately realized my mistake. I will tell you the mistake also, but the moment she said that my husband is having a fever, and along with that, he is also suffering from worsening of the ascites. I did not expect a person to deteriorate so fast, but this particular chap, the unfortunate bad news is deteriorated fast. There is a development of fever, there is a development of worsening of ascites, and I know things have gone bad. What I mean by going bad is that unfortunately the bacteria of the intestine are now migrating into the ascitic fluid. Bacteria are hungry. What is the hungry bacteria in the intestine? The bacteria in the lumen of the intestine is E. coli. This guy is a greedy fellow. He always wants more nutrition, and the ascitic fluid is full of nutrition wala fluid. So the bad news what has happened in this guy is that there was a transmigration of E. coli. This is a horrible thing to happen in a patient, that there is transmigration of bacteria via the edematous bowel wall. There is a transmigration of bacteria by the edematous bowel wall. So the bad news that is happening is that now there is pus in the peritoneal cavity. This presentation is called as spontaneous bacterial peritonitis. This presentation is called as SBP. If you ever read a question that in a diagnosed case of massive ascites, there is fever and worsening of the already pre-existent ascites, it means bacteria have gone in the peritoneal cavity, and now there will be a fight between the bacteria and the security system, that is neutrophils. Now neutrophils will be coming in the ascitic fluid. See, neutrophils have no business to be in the peritoneal cavity. Neutrophils are not present in a peritoneal cavity. Now there is lot of neutrophils that are coming in. So one he asked कितने से ज्यादा न्यूट्रोफिल्स या सेल्स प्रेजेंट होंगे कि we will set a spontaneous bacterial peritonitis. What I'm doing in this patient now is I should have done it earlier. Now I'm doing a diagnostic paracentesis. I took a 20 cc syringe. I followed the Z technique after asepsis and like basic precautions, sterile precautions. I ensured giving local anesthesia also. I didn't want him to feel discomfort. I took out the fluid. It was turbid. And if it is more than 250 cells, most guys have commented very rightly, more than 250 cells in the ascitic fluid, neutrophils have no business to be there. This means things have gone bad, things have gone south. What will I do in the patient now? This is a two-step question of NEET PG. NEET PG said क्या करोगे? Cefotaxime should be started. And ideally मुझसे गलती क्या हुई? I realized my mistake कि बेचारा सुबह से पड़ा हुआ है. At least मुझे क्या करना चाहिए था? I should have started this patient on fluoroquinolones, which is active against the gram-negative organism. What is that fluoroquinolone? Active against gram-negative organism? Norfloxacin. So अगर मैंने इसको norfloxacin सुबह सुबह भर्ती करके चालू कर दिया होता, तो chances of this occurring would have been significantly reduced. It can still happen. It can still happen, but if you start antibiotic prophylaxis in a massive ascites patient with breathing trouble, you are trying to reduce the chances of development of SBP. Why we are calling it spontaneous? Because there is no there's no duodal ulcer na. Like for a duodal ulcer, the technical word used is secondary perfusion. For duodal ulcer, the technical word we use is secondary perforation, but in this particular patient, it's like secondary peritonitis. It is a spontaneous bacterial peritonitis. There is no bursting of the, there is no bursting of the intestine. It is just migration of the bowel via the edematous bowel wall, and now the bacteria and the neutrophils are fighting, and because of the fighting between the bacterial and security system, obviously there would be pus because some neutrophils will die. What is pus? Dead neutrophils. What is pus? It is dead neutrophils. So you'll be able to see more than 250 cells per cubic millimeter in the ascitic fluid of the patient. So at the moment, the data to be remembered is SBP is an unfortunate complication in massive ascites patients, especially if they start having fever. That means things have gone south, because if I don't intervene, he'll go into sepsis, and that is not the end of the story. If he will go into sepsis and septic shock, yeah, early paracentesis is done. No, absolutely not. You, Dr. Khan Nida, you said like, will it occur? No. If I remove the fluid, there would be no risk of SBP. That is why when he came in the morning, I should have done. He was having massive ascites. Now he was having breathing difficulty. I should have done a therapeutic paracentesis. If I will remove the fluid from the perineal cavity, the chances of this happening will significantly come down, because fluid is rich in nutrition and the bacteria want to grab onto that opportunity. So now what we are doing in this patient is that if we do abdominal paracentesis, we can reduce the chances of this happening. You remove the fluid, there is no chances. Now things have gone south. What I mean by south is sepsis will occur, septic shock will occur, and two complications will occur, because under perfusion of kidney will also occur and lungs will also occur. Hepatorenal syndrome, HRS. In hepatorenal syndrome, the usual question will say, what is the type of renal failure that will occur in a patient? I yesterday explained the different types of renal failure to you: pre-renal, renal, and post-renal. Here it is under perfusion of the kidney. So your answer is pre-renal. That's the main question to be remembered. There's a lot of theory given: splanchnic vasodilation causing effective arterial volume to become lesser. The simple thing is, just remember there is a pre-renal acute kidney injury of the patient. So the kidneys are now beginning to shut down. It started off as massive ascites, then went into SBP, and now is causing HRS in a patient where oliguria and acute kidney injury will occur. He has asked in the exam, actually, what will you use for this patient? There are two approaches. Obviously, the main treatment is liver transplantation. If the liver is transplanted, albumin production will come back to normal. Ascites will stop. Na? Reason for ascites is deficiency of albumin. Reason for ascites is deficiency of albumin. So liver transplantation is the best way, but now it is very late. Surgeon will refuse because of the complications. If somebody is having multi-organ failure, liver is failing, kidney is failing, electrolyte imbalance will come because of kidney failure. Surgeon and anesthesia people will say, no sir, we don't want to operate, sir. Please get it operated from somewhere else. So now it is medical management only, and that is what I want you to remember. There are two drugs which are used for management of this condition: terlipressin and albumin. Obviously albumin, because liver is damaged, so what will happen? Albumin will be less, so albumin is anyway part of the algorithm. But then we are using some drugs to decrease the portal hypertension component in the patient to basically neutralize this splanchnic vasodilation. The basic problem from physiology perspective is space splanchnic vasodilation. Just think logically. If your all intestinal blood vessels will dilate, if abdominal blood vessels all will dilate, what will happen to blood supply to the kidney? Because pressure will become less. Now, when you dilate blood vessels, then pressure becomes lesser, and therefore the perfusion of the kidney will become less. The problem with this guy is splanchnic severe vasodilation. Because of vasodilation, when blood vessels will dilate, the pressure that is required to force the blood into the kidney will become less. Under perfusion of kidney is what I told you is pre-renal failure. I will say this again. When you dilate the blood vessels, thought process some people is more blood supply. No man, when you dilate blood vessels significantly, then the pressure will decrease. And if pressure will decrease, there is a under perfusion of the kidney, and that is why there is a pre-renal acute kidney injury. So he will waste your time with oliguria, creatinine rising 1.5 times, urine output decreases by 50%. Remember that stage 1 of AKI? So the question will be long stem. He will talk you about, like, the thought process of any doctor is कि यार liver damage का patient है तो he should talk about liver ना. He will go on and on about the kidney because ultimately this is the victim. The blood supply to the kidney has been compromised. So how do you counterbalance the splanchnic vasodilation? The drugs available are either terlipressin, or we can be using is midodrine or octreotide in a patient. So I would suggest you to remember at least one for today. Terlipressin and albumin is the first mainstay of treatment for this patient. Or if this is not given, then we give midodrine, octreotide as well, along with albumin. Albumin to dena hi dena. Albumin is universal in all cases of liver damage, but additional drug required is terlipressin that will help in counterbalancing the portal hypertension component of this patient. So at this moment, the word is HRS. What I want to minimum remember, you to remember is, what is the type of renal failure? Pre-renal variety. What do you give for it? Albumin, obviously liver is damaged, plus what is extra drug? Terlipressin. If not in the options, then 2. M and O, MO, right? MOT, TMO, whichever way you want to remember it. Midodrine combo with octreotide, MO medical officer, right? Midodrine octreotide or terlipressin would be used for management of these patients. So at this moment, I've covered HRS, hepatorenal syndrome. Now I move to the right side. Things are turning bad. Lung is also getting affected. Lung is also getting affected. So the lung involvement is called as hepatopulmonary syndrome due to intrapulmonary vascular dilation. Now the query is, sir, blood vessels when they dilate, will they not increase blood supply? No, the pressure gradient is becoming less. Blood vessels are dilated, agreed, but if you dilate all blood vessels, then the pressure gradient for forward flow of blood, lungs के अंदर blood चलता रहना चाहिए. Now the pressure gradient is becoming lesser. That is why there is a decrease in like saturation of the patient. There will be breathing difficulty, and two very peculiar terms will come which you don't read routinely in your medical career. One of the terms that they want you to remember for this condition is, now if you want to get into why this is happening, it's main videos, right? At this moment, I want you to remember what will happen to the patient. The word is platypnea. The meaning of the word platypnea is that the breathing difficulty of the patient, shortness of breath of the patient is accentuated in a sitting position. Why this is important is because all through our discussion over the previous few days, I've always said the word orthopnea. Orthopnea means the breathing difficulty of the patient will worsen in supine position. Why it is asked is, you can understand orthopnea is a feature of heart failure. Here he wants you to remember the word platypnea, that is breathing difficulty is worsening in sitting position. Two medical disorders which somebody commented also where this should be remembered is, one, a benign tumor of the heart, atrial myxoma, and second is the topic of interest, hepatopulmonary syndrome, are two causes of platypnea. The peculiarity of this condition is breathing difficulty is worsening in sitting position. Normally breathing difficulty is worsening in supine position. The second is orthodeoxia. It is not orthopnea, orthodeoxia. That simply means that whenever the person will change his position, the saturation will decrease. I mean, normally, like, you know, on like if you and me change our position from supine to sitting or sitting to standing or whatever, then on position change our saturation does not affect. But here the problem is the blood vessels are super dilated. There is no actual flow that is happening. The flow is very sluggish. So the saturation tends to drop on a position change, that is called as orthodeoxia. For this condition, obviously, there is no definitive treatment. We will give ventilator support. Obviously, we will give oxygen to the patient by ventilator support. But obviously, in this patient, lots of time the surgeon will refuse. वो बोलेगा मैंने पहले ही बोला था करवा लो ऑपरेशन, तब तो करवाया नहीं. अब लास्ट मोमेंट में जब पेशेंट सिक हो गया, सैचुरेशन ड्रॉप कर गई, तो सर्जरी का रिजल्ट भी पूरा होने वाला है. So most of the time, these patients may not get a liver transplantation. But yeah, what is the treatment of choice for both of these conditions? The treatment of choice for both of these conditions is OLT, orthoptic liver transplantation. So overall, I can say कि liver transplantation कब करते हैं. Liver transplantation is done when the person is having fulminant hepatitis. You will do liver transplantation when the patient is having fulminant hepatitis, that is, liver is totally destroyed. The definition of fulminant hepatitis is that the patient can be having any of the two, because when the liver will fail, the person will start developing bleeding. And along with that, the patient will also be having encephalopathy. If any of the two is present, you don't need both of them. If any one is present in a patient, if any one is present in a patient with liver insult, you say fulminant hepatitis, like paracetamol toxicity is a cause of fulminant hepatitis. Halothane is a cause of fulminant hepatitis. Antitubercular drug pyrazinamide, rifampicin, they are a cause of development of fulminant hepatitis. If any of the two will develop coagulopathy, encephalopathy, we call it fulminant hepatitis, and this is an indication for liver transplantation. Another indication is worked out right now, hepatorenal syndrome. Another one is worked out right now, that is hepatopulmonary syndrome in a patient. So I just wanted to bring to your situation, or just bring to your attention, that when do we do a liver transplantation? When the liver is not able to perform, and along with that, it is also like the ship is sinking, the captain is dying, and when the captain will die, the remaining soldiers or the remaining remaining staff members will also give up. The kidney and the lungs, they are the other members of the team which keep the ship afloat. Now all the systems are shutting down. The engine room is shutting down, the boiler room is shutting down, the electrical systems are down, the computer systems are down. So you can imagine like that, the computer systems, like the lungs are shutting down. So that's why multi-organ failure is occurring in a patient. Orthoptic liver transplantation will obviously be required in conditions that we'll discuss on the next slide, like Wilson disease, hemochromatosis, toxicities, obviously. But then what I just wanted to bring to your attention is routine situations where we require a liver transplantation in a. The minimum that I expect you to remember in the lower part of the slide is at least 2 points. First point, platypnea, seen in hepatopulmonary syndrome. Second point, how do you treat hepatorenal syndrome? It is a combo of albumin plus either terlipressin or MO medical officer, that is midodrine with octreotide in the patient, to counterbalance and offset the splanchnic vasodilation, improving the renal perfusion, offset the splanchnic vasodilation and improve the renal perfusion of the kidney to manage the pre-renal variety of acute kidney injury in the patient. So these are a couple of complications that will occur in a patient. Next comes the aspect of portal hypertension. What do you mean by the word portal hypertension is that the hepatic venous, you guys help me out here guys. What is portal hypertension definition? Hepatic venous pressure gradient more than how much? Yeah, it is there. Okay. But anyway, yes guys. What should be the pressure in the hepatic vein and the portal vein gradient? Hepatic venous pressure gradient should be more than how much? To say that the person is suffering from portal hypertension. Yes guys, HVPG value more than how much? Yep. If hepatic venous pressure gradient values more than 5 millimeter of mercury, you will say that it is portal hypertension in a patient. On this, the query I get is, no sir, the surgeon told something else. He said portal vein pressure more than 10 millimeter of mercury. Which definition is right, sir? You are saying 10 millimeter of mercury. The surgeon is saying, you are saying 5, then the surgeon is saying 10. Both of us are correct. When I say that, sir, what will we answer in the MCQ? Why you will answer on the value that is given? Nah, if he says measure in the portal vein, then 10. And if you are measuring at the junction of the hepatic and the portal vein, then it is 5. In the MCQ, either he will give portal vein pressure more than 5, 10, 15, 20. Answer is more than 10. Portal vein more than 5, portal vein more than 10, more than 15, more than 20. All portal vein, portal vein. Or he will say hepatic venous pressure gradient. Hepatic venous pressure gradient is a more accurate way. Hepatic venous pressure gradient is a more accurate way because you have to measure the pressure exactly at the liver interface where the hepatic veins and the portal veins are meeting. That's how the liver will be, blood will be flowing in the liver. Then he gave 4 options here. There are 4 options here. He said, which of the following will indicate portal hypertension? Then the answer is the first one, because you can see dilated veins in this condition, that is called as caput medusae. Only point number 1 is portal hypertension. If you look at B, C, D, they are signs of liver cell failure. If you look at B, C, D, they are signs of liver cell failure. They are not findings of portal hypertension. One of the findings that you can see here is spider angioma, spider nevi. These are dilated veins. These are dilated veins that you will be encountering. sorry, these are dilated arterioles, they're not veins. Caput medusae is veins. Caput medusae is dilated veins, but these are dilated arterioles. Most of the time spider nevi कहाँ पे देखते हैं, तो they are seen in superior vena cava distribution, गर्दन पे देखते हैं. You will ask the patient to remove his shirt, तो आगे कंधे पे, आगे शोल्डर पे, आगे छाती पे, पीछे बैक पे, on the SVC distribution this particular finding would be present, and this is usually due to estrogen excess. He asked in the paper what hormone is responsible for spider nevi. Estrogen. When you check out the nails of the patient, you will notice that the nails of this person are very white and distal part is pink. This is what is called as Terry's nails. Terry, yeah, it's visible. Terry's nails. It may also be called as leukoonychia. Leuko means white. Leukoonychia. I'm not writing, it's obvious. Leuko means it is white in the proximal part. That is leukoonychia. The extreme right hand side manifestation in the patient is what is called as palmar erythema. The point to be understood is, like you can see that hypothenor eminences of bloodshot red. Hypothenor eminences of bloodshot red क्योंकि जो cirrhotic liver होता है ना वो nitric oxide बनाता है. The cirrhotic liver produces nitric oxide that causes blood vessel dilation. The splanchnic liver produces nitric oxide that causes dilation of blood vessels. So here what you are noticing is B, C, D are features of liver cell failure. Which of the following indicates portal hypertension? Portal vein में pressure बढ़ेगा तो venous system में बढ़ेगा, and then collaterals बन जाते हैं which are called as caput medusae. In caput medusae the blood supply is always away from the umbilicus. It is not towards the umbilicus. The flow of blood, if he says, then the flow of blood in the veins will always be away from the umbilicus. The overall most common complication of chronic liver disease. Overall most common complication of chronic liver disease is the topic that I've explained to you, that is portal hypertension. If you say what is the earliest and the most reliable examination finding of portal hypertension, it will be splenomegaly. Because अगर पोर्टल वेन में कंजेशन होगा तो स्प्लेनिक वेन में भी कंजेशन, और अगर स्प्लेनिक वेन में भी कंजेशन होगा या कोलियोनिकिया एंड आयरन डेफिशिएंसी एनीमिया का, एंड यहाँ पर देयर वुड बी अ स्प्लेनोमेगाली. व्हाई? बिकॉज पोर्टल वेन का प्रेशर ट्रांसमिट हो जाएगा स्प्लेनिक वेन. द प्रेशर इज ट्रांसमिटेड, you get an enlargement of the spleen of the patient. Values I have already explained to you, that if the pressure is more than 5, it is HVPG, and if the pressure is more than 12, the guy will die. The guy will die because of vomiting of blood due to esophageal varices. The guy will die because of bleeding esophageal varices, hematemesis, crying blood. The first time when the person will vomit us, when first time the vomiting will happen, it will be bright red vomitus given. But due to gravity, some blood will go down and will accumulate in the stomach also. When the blood will accumulate in the stomach, it will come in contact with acid, and acid will destroy the hemoglobin. So when the person will vomit the second time, the vomitus will not be bright red in color, then it will be coffee, it will be like brownish in color. I'll say this again. When the person will vomit, all blood will not come out. No? Some blood due to gravity from the esophagus will go down into the stomach. It will trickle into the stomach. The stomach contains acid. So acid will destroy the blood, and therefore acid hematine is formed, and that gives a coffee ground vomitus. So don't be surprised that in a question of portal hypertension, he may mention coffee ground vomitus deliberately. You know, bright red vomitus, so anybody can understand it is hematemesis. So he will deliberately write the word coffee ground vomitus. That word basically means that the blood, like person vomited blood, so all blood did not come out. Some blood of the esophageal veins went down due to gravity, came in contact with acid. That's the point. Then is obviously the anatomy and surgery question. What is the source of bleeding? Obviously, you have to know the source of bleeding for any kind of bleeding that you are undergoing. Here, he will ask you what is the source of bleeding from the portal side and the systemic side. So the portal side is obviously the left gastric vein. But if he will say systemic vein, then your answer would be azygos vein. Guys, if it is portal side, then it is the left gastric vein. But if it is the systemic vein, it is the azygos vein. So that is the source of bleeding that is occurring in esophageal varices. Specifically to remember is left gastric vein. Artery nahi beta, LGA likh rahe ho, it's not an artery. LGV. It's a venous bleeding. It's not an arterial bleeding, right? So it's a mistyping that you guys have run. It is LGA. वो गलती से हो गया होगा, मैं समझता हूँ कि आप LGV लिख रहे थे, LGA हो गया. But I hope it was only a typographical error and it was not in your mind. आपके mind में left gastric artery नहीं सोच रहे थे. Because we're talking about varices. Varices means a venous bleeding in the patient. Then वो बोलेगा, what is best to prevent this from happening? But if you know that the guy is gonna deteriorate like this, what is best to prevent this from bleeding? Your answer is endoscopic variceal ligation. Best to prevent this kind of a profile from occurring is EVL. EVL is called as endoscopic variceal ligation is the best way to manage this patient. Endoscopic variceal ligation is overall the best way to manage this patient. If he will not be ready for ligation, I can put this patient on the longest acting beta blocker. The longest acting beta blocker is nadolol, and that can do good to this patient, but उसने करवाया ही नहीं. If the question says best management for prevention of bleeding, then it is endoscopic variceal ligation or nadolol. Next, I want you to do a task कि prevention word हटा देना इसमें से. Just make a cut over the prevention, and the question will say what is the drug of choice of bleeding from esophageal varices. Like the prevention is already handled. Like I've already told the drugs. I'm एक ही साथ बता दिया ना, तो prevention word हटा देना. Okay, चलो रहने देते हैं. अगर काट दिया तो काट दिया, कोई बात नहीं. अगर like the point is अगर prevention लिखा है, अगर काट भी दिया, हाँ propranolol भी दे सकते हैं बेटा. Your point is right. See, if you have cut it, let it be. I hope it is clear to you that if I change this question into, if you cut it तो फिर easy हो जाएगा. Now note, drug of choice of bleeding esophageal varices. See, prevention is what I've already told you. Nadolol or propranolol in the previous question also. But if he says drug of choice for bleeding esophageal varices, then your answer would be given as like octreotide or terlipressin in a patient. तो बस question में ये देख लेना कि prevention word है या नहीं है. Just check out in the question if prevention word is there or not. कि ऐसा ना हो कि जल्दबाजी में आप क्वेश्चन का आंसर octreotide कर दो. तो because octreotide is like a faster reflex कि drug of choice of bleeding varices, octreotide / terlipressin. Yeah, any other two can be used. My only request to you guys is this word should not be missed. This word prevention should not be missed. Nadolol or propranolol. Nadolol is more long acting, na? That is the reason. And if he says what is the drug of choice for bleeding varices, absolutely cool. That is octreotide and terlipressin that can be used in the patient. Moving ahead, what is the management of acute variceal bleeding where the BP is very, very low? So you will put a wide bore cannula in the patient. Wide bore cannula in the patient. Let me know when you put this wide bore cannula in this chap. When you put this wide bore cannula in this patient, would you be putting like what color cannula? Okay, I will give options. Blue, pink, green, gray. Select one. What is the color of the cannula that you will be using in this particular patient? Yes, guys. Quick answers, please. Yeah, we will be putting a wide bore cannula. That is a gray cannula to be ensuring that you are able to rush fluids into the body of this patient. So gray cannula will be put. Very good. After putting a wide bore cannula, you will take the sample for blood group and cross matching and send it to the lab so that you can start blood transfusion of the patient. That is massive transfusion. For massive transfusion, the definition is 6 units of packed RBC, because nowadays we give blood units to the patient. So it is 6 units of packed RBC, it is 6 units of fresh frozen plasma, and it is 6 units of platelet rich plasma that we give to the patient. Take care of the fact that what you are doing for this patient is packed RBC, 6 units fresh frozen plasma, and then subsequently it is like platelet rich plasma that can be given to the patient. Yes. In some MCQs, to trick me, he will be writing word like 1 unit of SDP. This is a jumbo bag of platelets. So while attempting questions, do take care of the fact that is it written platelet rich plasma? I'll write the word once again. Is it PRP, platelet rich plasma, or is it SDP, the single donor platelet? Because the answer in the both situations is bound to vary. What I mean by variation is for the superior entry, the ratio at which the blood transfusion, packed RBC and other components is given is 1:1:1. Packed RBC 1 unit, FFP 1 unit, and PRP 1 unit. But if it is gonna be SDP written, then the ratio will change as 1:1:0.25. I will repeat the data once again. Suppose it says 6 units of packed RBC, 6 units of fresh frozen plasma, 6 units of PRP. How will you give? So you will give 1 unit of PRP first. Then when it is completed, FFP, then PRP. It is repeated in cycle of 1:1:1. The same thing will be repeated even in the inferior data, but the jumbo bag of platelet is equivalent to 6 units of PRP. 1 unit of SDP is equal to almost 6 units of platelet plasma. So the ratio is only for the sake of just discussing that it is 1:1:1. The second definition of massive transfusion is what I was a student. When I was a student, it used to be told that if a person is having requirement of more than 5 liters of whole blood, because earlier blood components were scarce and it was mainly whole blood that is being used. So if somebody is getting a blood transfusion of 5 liters over 2 hours, we call it massive transfusion. There is another unit here also, more than 2.5 liters of whole blood in a 4-hour period. So what I've tried to explain to you is total of 4 definitions. I will say them again. 2 definitions are blood components, BC, and 2 components are whole blood, WB, whole blood components that are given to the patient, WB, whole blood components. Whole blood definitions are older one, yeah, massive transfusion protocol. It is 5 liters of whole blood or 2.5 liters in 4 hours. But usually nowadays in hospitals, you would have seen we are using either like PRP, SDP, FFP, packed RBC, those blood components are being used. So the answers would be in accordance to the units that I said 666 or 661. That mathematically changes the ratio to 1:1:0.25. Yeah, 5 liters in 24 hours and more than 2.5 liters in 4 hours. Exactly. Everything is over 1 day period only. But specifically, I've given answer over 4 hours for the patient. I will deliberately not increase the BP. I will deliberately not increase the BP to 120/80 because it will then increase the chances of bleeding. So if he says what is the target blood pressure of the patient, the target blood pressure will be 90/60 millimeter of mercury. Like he came with a BP of 70/50, 60/40. So if it is gonna be like unrecordable BP, you just have to make it recordable. The data that I'm teaching you is uniform. The patient came with cold, he will say, patient came with cold, clammy extremities, unrecordable blood pressure. What will you do? You will put a wide bore cannula, start the patient on IV fluids till the blood transfusion will be coming, and main treatment is blood transfusion. I mean, खून के बदले खून. What is the target blood pressure that should be given to the patient? It is 90/60 millimeter of mercury. Don't increase the BP to 120/80. It will increase the chances of bleeding. It will increase the chances of bleeding. Once the BP is stable, what will you do? You will give octreotide or somatostatin to the patient. This is the drug of choice for management of this patient. Once the blood pressure is stable, then you can take the patient for EVL, which is the treatment of choice for this patient. So what I've tried to explain to you is basically cover 3 MCQs here. What is the first line management? What is the drug of choice for bleeding varices? And what is the treatment of choice for bleeding varices? In all the 3 situations, it is bleeding that I'm talking about. Bleeding varices. First line management for bleeding varices is that we should start the patient on massive blood transfusion. Drug of choice is octreotide/terlipressin. Any of the 2 can be used. If he says what is the treatment of choice, endoscopic varicose ligation. Guys, we told this guy earlier also. इसको तो पहले से ही बोला था कि भाई करवा लेना इसको endoscopic varicose ligation. उसे करवाया नहीं था. इसको 2 साल पहले के भी नोट्स होंगे ना, उसमें भी मैंने उसको बोला था कि भाई तू करवा ले. उसने करवाया नहीं था. That is why in this particular patient the deterioration happened and his whole family, his daughter, his son, they're so disturbed कि sir my father is alcoholic. एक तो ड्रिंक करते हैं, ड्रिंक करके मिसबिहेव करते हैं. ऑब्वियसली यू नो अल्कोहलिक ही विल लूज कंट्रोल, सो ही विल मिसबिहेव. गाली दे रहे हैं, मेरी मम्मा को गाली दे रहे हैं, पड़ोसी. लाइक alcoholics have very bad relations, right, with relatives, with husband wife relations are spoiled, and with relatives and then neighbors also. So like the family is already distressed, and today the guy was having vomiting of blood. So all of this could have been prevented in a patient. And especially खून के बदले खून मैंने इसलिए बोला because I want to avoid what is called as triad of death. Yes, it is the treatment of choice for both prevention as well as therapeutic management. Exactly. It is EVL is the treatment of choice for both bleeding as well as non-bleeding varices. आप prevention मत बोलो, आप बोलो non-bleeding varices. भाई पहले prevention जब करेंगे तो non-bleeding ही तो होगा. It is the treatment of choice for both non-bleeding varices as well as bleeding varices. I'll write it here since the query came up. If he says bleeding varices, how do you manage treatment of choice? EVL. If he says non-bleeding varices, it is still EVL because I want to prevent the conversion. No, the pressure is, when the pressure is 5, it is non-bleeding. When the pressure will become 12, it will become bleeding. So liver will progressively be shrinking. The fibrosis part in the patient will increase. So I don't want to take a chance in this case. And then comes obviously the aspect of morbid jealousy is also there. Triad or death. वो हमेशा, you know, they'll always be fighting that you are cheating on me, he's checking her mobile phone again and again. So those are like, you know, you routinely see those kind of cases in the hospital. Tried or death? Yes, guys, quick answers, please. Components or tried or death? Only one component has come. Only one component has come. Yeah, hypothermia. Very good. Maria was quick in that. Hypothermia is right. After hypothermia, because the body temperature will decrease, because when you lose heat from the body, when you are gonna be bleeding, when you lose heat from the body, there is a coagulopathy that is coming, that is bleeding, that will be occurring in a patient. And after hypothermia and coagulopathy in a patient, the next thing that will come up in the patient, hypothermia and coagulopathy, that will be coming in the patient. The next thing would be metabolic acidosis, because there is a underperfusion that is happening. So triad or death is basically what we want to prevent in these patients. Triad or death is what we want to prevent. That is why we were never give chilled blood. Never give chilled blood. If you will give chilled blood to the patient, giving chilled blood to the patient will cause hypothermia, and that will increase the bleeding. So how will you warm the blood? How will you warm the blood? Never give chilled blood to the patient. If you give it, the guy will bleed. So how would you warm the blood? Yes, guys. How would you warm the blood? Quick answers, please. Always give using a inline warmer. Obviously, you can't put the blood in a microwave, na? You can't put the blood in the microwave and tell the nurse that, okay, microwave it to this temperature and give it to the patient. Okay. But there's a no, not warm cloth. No, sir, via inline warmer. Whenever you are giving massive transfusion, it is via no desi jugaad. All of you are doing desi jugaad inline. Desi jugaad is kangaroo mother. No, वाया बॉडी में लगा के गर्म करोगे अपने ऐसे ऐसे लगा के, है ना? नो, वाया इनलाइन वार्मर. ये स्पेशल जो इन्फ्यूजन सेट्स होते हैं ना यार, उसमें दे वार्म द ब्लड टू नॉर्मल टेम्परेचर 37 एंड देन दे गिव टू द पेशेंट. सी, इंडियन डॉक्टर्स आर वेरी रिसोर्सफुल. मैं गारंटी दे रहा हूँ, राइट? आई एम टेलिंग यू एम्प्लॉयमेंट अपॉर्चुनिटी राइट नाउ. Saudi Arabia, Dubai is saturated now, right? People are going to Saudi, man. Right, and now like Saudi is totally different from what it was 10 years ago, 20 years ago, with lot of restrictions from the religious perspective. No, so like why I'm telling you this is because like Indian doctors are very resourceful, so they want Indian doctors. They want to work in like Indian doctors will create some system. If like American doctor will say I can't do anything, you arrange me a system, I'm gonna work, otherwise I'm not gonna work. Indian doctors are gonna be like resourceful, like you guys are suddenly resourceful. Yeah, citric toxicity can occur. MT in the first line. MT is massive transfusion, beta. MT is massive transfusion. MT is massive transfusion. So, I mean, like, Dubai is getting saturated. DHA exam, Dubai Health Authority exam, if you want to give. And USMLE, if you clear, then Dubai will take you directly. But obviously, Dubai is saturated, So, it is like the other Emirates where opportunities are there. And then Saudi is another opportunity where people would be ready to work. Okay. No, if you clear USMLE, then it really doesn't matter. Sir, it's not Indian PG. No. They will make you clear your exam, sir. You have to clear their exam and then work. No? It's not about Indian post-graduation or Indian graduation or anything. Every country is having their own system, but because the currency is good and the country is growing at the moment, the job opportunities are there. भाई सब में एक ही रोना है, गोरे लोगों के साथ एक ही रोना है. गोरा डॉक्टर will never let you do surgery ना. मेडिसिन भी मिल जाए तो बहुत बड़ी बात है. They just will take you periphery वाली branches. So if you want to go abroad, then you have to first get registered in India, obviously, like your ECFMG will ask you always like your Indian registration. But if you're registered in India, you've done a degree. Sir, I know so many students who have cleared NEET PG. नहीं लिया उन्होंने आगे. They're taken physiology, biochemistry, and they're preparing for USMLE. And then the ultimate objective is to move to Gulf. Obviously, they would be having some family there, so somebody would have guided them कि ऐसे कर ले. Like what they're doing is that they're clearing NEET PG. Now they're getting, maybe payment seat पे उसको मिल रहा है, मेडिसिन मिल रहा है या मिल रहा है, ले नहीं रहे. कह रहे सर पैसा खर्चा क्यों करना, 50 लाख 1 करोड़ कौन देगा इसके, है ना? फिर से ग्राइंड में जाना है. तो उठाया अपने आराम से, पैरा क्लिनिकल प्री क्लिनिकल ब्रांच उठाया, 9 से 12 का ड्यूटी किया, एंड दे सिट फॉर USMLE, दोनों एग्जाम क्लियर किए, एंड देन दे शो द सेम स्कोर्स इन सऊदी एंड इंटरव्यूज एंड अदर वाला इंटरव्यूज, एंड दे आर हैप्पी टू टेक यू एट द मोमेंट. ओके, ऑटोक्लेव भी आया था. चलो जी, नेक्स्ट ऑन द एजेंडा इज विल्सन डिजीज. अरे पिन पॉइंटिंग मत किया करो. नेक्स्ट ऑन द एजेंडा इज विल्सन डिजीज. I think I spoke about Wilson in bits and its, but anyway, let's do it at the moment. What is the problem in Wilson disease in a patient? The defect is in a gene by the name of ATP7B. In Wilson disease, the defect is ATP7B gene. The chromosome that is involved in 13, you guys can hit the comment button. What is the pattern of inheritance here? Yeah, it is autosomal recessive. The defect is ATP7B gene. No, beta, not 7. That is cystic fibrosis. It is chromosome 13 that is involved here. It is autosomal recessive. Right? Gene is 13. The gene is ATP7B. Chromosome is 13. I'll write it once again because people are making mistakes at the moment. ATP7B. तभी मैंने रखा है इसको 2 बार ही रखा हुआ है. Kept it 2 times. Don't mix it with ATP7A gene for Menkes, obviously. Please comment in the chat box quickly. What is the chromosome involved in Menkes disease? In Menkes disease, what is the chromosome that is involved? Seven is not the answer. 17 is not the answer. Yeah, I am asking you the chromosome, man. I'm asking you the chromosome. Yes, Rajesh. And there was one more Dr. Parayat. Nadeem now came up with the correct answer. Shashi has already answered, but he answered second time also. Shashikant. Sai is right. Height is chromosome X. थक गए हो. It is X-linked recessive disorder. So it will begin by saying a boy, and then it will say mental retardation with kinky hair. The chromosome that is involved in this particular condition is chromosome X. It is ATP7A gene. It is a boy, and the boy, all XLR are going to affect the boy only. The boy will be having mental retardation with kinky hair. The main defect in this condition will be effective hepatobiliary excretion of copper. If he says what is the pathology defect here, then the pathology defect in Wilson disease is defective hepatobiliary excretion of copper. It is defective hepatobiliary excretion of copper. Defective hepatobiliary excretion of copper. Don't answer ceruloplasmin deficiency. Ceruloplasmin deficiency is not the pathogenesis. This is the wrong data that a lot of people think and study. Ceruloplasmin deficiency is not the feature. It is a lab finding. Main problem is defective hepatobiliary excretion of copper. What I mean by defective hepatobiliary excretion of copper is कि जो हम खाना खाते हैं उस खाना में जो भी हम खाना खाते हैं उसमें कॉपर तो होगा GI tract में. So what will happen in this case is that the absorption of copper from the intestine is normal, but excretion of copper out of the liver is defective. Like copper has to go out of the body because it's a component of electron transport chain. You can draw a cross like this to signify that जो प्रोटीन इसको excrete करता है उसके लिए जो जीन कोड करता है that is defective. ATP7B gene is defective, and therefore the excretion of proteins is defective, and because the excretion of proteins is defective, what will happen is copper will accumulate in the liver. That is the reason why the earliest manifestation of this patient is chronic hepatitis. Due to hepatitis, if you ever do LFT in these patients, SGPT will always be elevated because the liver is injured. Now what will happen in the patient is that the blood will flow over the liver. When blood will flow over the liver, liver is one of the largest organs of the body. Liver is one of the largest organs of the body. So RBCs will now dissolve away the copper. Like I modified the diagram to say that now RBCs will remove the copper from the liver and take it to different tissues, including the eyes. The damage in this patient, the second one will be the ocular manifestations that will start happening. In the first 10 years of life, in this case, it is only chronic hepatitis with occasional SGPT elevation that may be detected on a routine medical checkup. But after 10 years of age, you will start getting neurological features and ocular features, which is in the form of Kayser-Fleischer ring, KF ring, which will always be given in the exam. This KF ring cannot be visible to the naked eye initially, so it will be evaluated on a slit lamp examination. The finding on a slit lamp examination in this particular patient would be involvement of the Descemet's membrane, as somebody has answered very correctly. Subsequently, to waste your time, he will mention psychiatric manifestations in this patient. He might mention psychiatric manifestations, bizarre behavior. Because of this bizarre behavior thing, you might be starting to think in terms of schizophrenia in this patient also. Then he will say the main thing, basal ganglia involvement. So some people have already commented. Those who have already commented, don't comment. Remaining people, which basal ganglia is damaged in Wilson? What is the basal ganglia that will be damaged in Wilson disease? The basal ganglia that will be damaged in this case is lenticular nucleus. And when lenticular nucleus will be damaged, that is when Parkinson disease like manifestations and extrapyramidal syndrome will start occurring in this patient. The lenticular nucleus damage, that is why the question will now begin to say things like, the neurological features that will start coming up in the patient. He will say this boy is having development of, due to damage to the basal ganglia, the boy will be having dystonia, rigidity, bradykinesia, like I was teaching you trap manifestations. So dystonia, rigidity, bradykinesia, those are the kind of manifestations that would be present in this particular patient as well. That's because the bodies become very, very stiff in this patient. Yeah, tremors can also be described. Then again, to trouble you a bit, he can mention renal tubular disorder manifestations. In the morning session, when I started the class, I talked about proximal tubular damage. That proximal tubular damage that I explained to you will be causing manifestations like amino aciduria. Normally, any doctor, when he's studying Wilson disease, the thought process is कि यार liver की खराबी होती है, यहाँ पे kidney की involvement पूछ लेगा. Amino aciduria, glucosuria, phosphaturia, those kind of manifestations can be written in a question. Normally, glucosuria occurs in diabetes. Blood sugar is normal, but still the glucosuria is common. That is renal glucosuria. Yes, guys, I'm talking about renal tubular acidosis type 2 that can be given in a question. What I want you to understand at this point of time is that if they give you a question where he mentions that in first 10 years of life, only lab tests were showing derangement of SGPT. And after 10 years of age, there is mention of Parkinson disease like manifestations, then you call it hepatolenticular degeneration. That is the word that most guys were commenting in the chat again and again, that Wilson disease is a condition of hepatolenticular degeneration. If you get these two words right, you are sorted for the topic. First 10 years of layer, only lab reports will be able to tell that there is something wrong with the liver. What is wrong with the liver? Diagnosis will not be made. But after 10 years of age, when KF ring will start appearing, psychiatric manifestations will appear, PD manifestations will appear, renal tubular manifestations will appear. By that time, the diagnosis will be certified or will be cleared in this patient. He will say, what is the screening test for this condition? The screening test that you will do in this patient would be, the main screening test that you have to do for these patients would be, two tests are done. One is serum ceruloplasmin. One is serum ceruloplasmin. It will obviously be less, but it can be less in multiple other conditions. So what we will do is that we will combine this with another imaging modality, with another test, that is 24-hour urinary copper. Normally, when I discuss a condition with you, for one condition, I discuss only one test. This is the first time that I'm mentioning two tests for one condition, that is serum ceruloplasmin plus 24-hour urinary copper. In especially those cases where there would be family history present, ceruloplasmin low will be helpful in diagnosis. So we usually do two tests for diagnosis. Why ceruloplasmin is low is because liver is damaged. Liver is damaged. Now we will talk about investigation of choice of this condition. The investigation of choice for this condition is liver biopsy. This is again a question which has been repeatedly asked in the exam. How do you confirm the diagnosis? Your complete statement is liver biopsy with estimation of hepatic copper content. It is estimation of hepatic copper content per, like he will mention the statement, estimation of hepatic copper content per gram of the dry weight of the liver. This is the complete statement to be remembered. How do you diagnose Wilson disease? The diagnosis is liver biopsy with estimation of hepatic copper content. Yes, hepatic copper. Yeah, we can do PCR also, but the standard answer is still liver biopsy. If he says what is the first line drug for this condition, or if he says what is the drug of choice of this condition, the answer will remain the same. We will be giving a copper chelator. The name of the copper chelator that we'll be using in this patient is trientine, and trientine will help us identify, trientine will help us treat KF ring also, because KF ring is partially reversible. KF ring is partially reversible, so that's a copper chelator that can be used in a patient, or instead of copper chelator, we can be using D-penicillamine also, but like nowadays in the books, it is trientine that is usually recommended. Then to finish the topic, lastly, I would like to say that for these patients, CNS manifestations are there. For CNS manifestations, if he says what is the drug that is used, then there's a new drug for this condition which has a very long name. The name of the drug is tetrathiomolybdate. Tetrathiomolybdate. Because CNS features are there, we also need to do MRI in the patient. Again, because why MRI? Because anybody with neurological features, I want to do an MRI. MRI finding is what you mentioned very rightly, that is giant face of panda appearance. So what we will do in the patient initially is that we will be decreasing the copper levels in the patient, and we will be able to take care of even the neurological manifestations. Now the last question in the topic will say, what is the drug of choice for maintenance in Wilson disease? Initially, it was trientine because it is a chelator. First, we want to decrease the levels of copper. First, you want to decrease the levels of the copper towards normal. Now he will say, what is the drug of choice for maintenance in Wilson disease? Now copper has become normal, but it will again rise because there's a defective gene in the body coding for defective protein. So the copper will still not be excreted out of the liver. So for maintenance in this patient, your answer would be given as that I will be giving zinc to the patient. You read about zinc 2 times. One in pediatrics for management of diarrhea, acute gastroenteritis, where they say zinc ki goli, Jeevan ki goli, like that they say ki zinc should be given in all children with acute gastroenteritis. But today I'm telling you that if he says maintenance in Wilson, then it is zinc. So question dekh ke karna, is it in the acute presentation of the disease or maintenance? Maintenance means chronic phase, when copper will decrease to normal, when the KF ring begins to reduce, when the patient neurological symptoms begin to reduce, that means you have taken the acute toxicity part. And once the acute toxicity part has been handled, yeah, zinc was also given for acrodermatitis enterohepatica. Rohit, you have a good point there, because diarrhea की वजह से ही होता है वो भी. Diarrhea causes acrodermatitis enterohepatica that you read in pediatrics, but today I'm discussing it for management of Wilson disease. Because the liver is getting affected in the patient, so he will say, what will you do for liver transplantation? Well, we will be doing a orthoptic liver transplantation. We will be doing a OLT in this patient. For liver transplantation will be done, but liver transplantation decision in this patient will not be based on MELD score. It will not be based on MELD 3.0 score. It will not be based on child score. It will be based on Naser score or Naser's index. Another statement to be remembered, how do you decide for liver transplantation in Wilson disease? The decision making is not based on the basis of MELD score. Decision making is not based on MELD 3.0 child pug score. It is Naser's index. So you can see in the treatment, I've said lot of technical points. 4 to be precise, I'm going to repeat them again. What is the drug of choice for the initial presentation? The first line drug trientine, because this is a copper chelator. कॉपर को बाइंड करके एक्सक्रीट कर देता है किडनी के थ्रू. तो मुझे तो कॉपर चिलेटर चाहिए कि कॉपर के लेवल पहले नॉर्मल करो. Because brain is getting involved also, so a CNS active drug is given which is removing copper from the basal ganglia, that is tetrathiomolybdate. Trientine from the tissues, and here it is tetrathiomolybdate for the brain. The MRI finding is animal inspired sign, giant face of panda. अब रेडियोलॉजी वाले तो रैंक 1 होते हैं, उन्हें रूम पे बैठे बैठे इंस्ट्रूमेंट्स में देखते देखते उन्हें एनिमल्स दिखाई दे रहे होते हैं, विजुअल हॉलुसिनेशंस हो जाती है ना. तो कभी पांडा दिखाई देता है, कभी आई ऑफ द टाइगर दिखाई देता है, कभी टाइगरॉइड अपीयरेंस दिखाई देता है, राइट. एंड देन दे स्टार्ट राइटिंग दोस टर्मिनोलॉजीज आल्सो. कभी रेसिंग कार दिखाई देती है. तो हो जाता है खाली बैठे हैं, बात करने को कोई नहीं होता, हम तो पेशेंट से बात कर लेते हैं, अगर आप स्क्रीन के सामने बैठे हो सारा टाइम, कोई बात करने को नहीं, तो फिर हॉलुसिनेशंस होते हैं, इल्यूजन भी हो जाते हैं, है ना. So anyway, that's just a way to remember animal inspired signs which are usually present there. भाई रैंक 1 होते हैं तो भाई सभी ये बोलते हैं कि हाँ जी आप तो भगवान हो, तो हम तो बोलते हैं भी भगवान है, नो डाउट अबाउट इट. बुरा तब लगता है जब वो बोलते हैं प्लीज कोरिलेट क्लिनिकली, है ना. सारी रिपोर्टों में लास्ट में क्या लिखा होता है, प्लीज कोरिलेट क्लिनिकली. हाँ, निकिता मैम इज अ टॉपर मैन. I mean, I think she has been she started teaching even earlier than me. I started teaching at 26. She started teaching at 25 years of age. She just completed her MBBS, and I think Maharashtra mein she got rank 1. निकिता की बात कर रहे हो ना, निकिता मैम की अपने प्रेप में. Nikita got rank 1 in Maharashtra. But the, जो भी था rank 1 2 3 4 I've forgotten, but she is telling me she was a single digit ranker. So she started teaching even 1 year earlier than me. ना 25 years की एज पे आई मीन वो अभी है ना डॉक्टर पुनीत भुजानी सर, है ना, जो ओबीजीवाई पढ़ाते हैं, है ना. तो पुनीत भुजानी सर का पहले ऐप आता था, ही इज द लेजेंड भाई. उनके एक्चुअल ऐप तो उनकी आती थी पहले. तो निकिता started teaching in his app, and I saw those videos, right? So it was just awesome, no? A thin, skinny girl, चश्मा वश्मा लगा के, and she's like teaching पूरे पूरे facts बता रही है. तो very like fortunate to work with like super intelligent people all these years. Yeah, absolutely. No, तुम तो भाई अनअकैडमी तो बहुत लेटर आया यार. अनअकैडमी तो लॉकडाउन के टाइम की बात है ना. मैं तुम्हें बात कर रहा हूँ 2014 की, right? I'm telling you not about Unacademy. I'm telling you 2014, right? That's 6 years prior to that. So she was literally a baby girl at that point of time, and she's teaching. So I mean, like phenomenal, right? To teach all the things. Yes. Okay, guys. So at this particular point of time, I have mentioned regarding the treatment algorithms which are used for management of this patient. मतलब 2014 में तो यार तुम्हें आइडिया भी नहीं होगा कि तुम कभी डॉक्टर बनोगे. कभी सोचा था तुमने अपनी जिंदगी में कि तुम डॉक्टर बनोगे? फिर ऑनलाइन इतने 8 घंटे बैठोगे ऐसे, है ना, और ऐसे बैठ के मेरी बकवास सुन रहे होगे. तो ऐसे सुनना पड़ेगा. कभी सोचा भी था? है ना, मैंने कभी सोचा नहीं था पढ़ाना पड़ेगा. मेरी तो मॉम कहती है कि तू तू पढ़ता नहीं था ना, इसलिए तुझे पढ़ाना पड़ता है. My mom says you don't know anything about diabetes. My mom is a diabetic. She keeps on eating sweets all the time. She keeps on piling on weight. अभी grade 2 fatty liver आया, and she sends me WhatsApp messages about diabetes care. You know that पता नहीं यार कैसे कैसे juice, right? And she says you guys are like you guys are like standing all these medicines, and तुझे नहीं आता diabetes के बारे में. तो यू लाइक घर का डॉक्टर जो होता है ना, उसकी कोई इज्जत नहीं होती है. तुम्हारी भी नहीं होगी. आई कैन अंडरस्टैंड, योर मॉम एंड योर डैड व्हेन यू टॉक टू देम दे विल से कि बच्चा है तू, हट ना, तुझे क्या आता है, बच्ची है तू, तुझे क्या आता है, हट जा. वो हमने वहां से देखा, वो बाबा जी ने बताया लाइक दैट. तो इरिस्पेक्टिव ऑफ वट एवर एज ग्रुप यू आर, नो, your mom and dad are always gonna be treating you like baby kids and everything. like वो चेंज ही नहीं होता है. मतलब एक लिमिट के बाद कहते हैं भाई मैं अब तो डॉक्टर बन गया यार, लोग इज्जत करते हैं मेरी, कुछ तो इज्जत कर लो. तो दे आर लाइक हट पीछे. ओके फाइन. So anyway, what I've discussed at the moment is like Wilson disease, guys. This is an important topic which is to be remembered for the paper, and I have mentioned certain important parameters at this particular point of time. Okay, guys. So yeah, you guys would be going through the same thing, guys. घर पे तुम्हारे को कुछ नहीं, nobody will care, nobody will care. घर के तो डॉक्टर, घर का डॉक्टर पर. चलो ओके जी, फाइन. या फाइन. चलो कुछ स्लाइड्स और कर लेते हैं. द प्लान विल बी, चलो अभी प्लान भी बता दूंगा. फाइन. आई थिंक यू गाइज आर बिट रिलैक्स. आई वांटेड you guys to just take it a little easy because I've been just doing data at this particular point of time. Okay, first I will share the plan, guys. What we will do is, कल तुम्हारी क्लास तो नहीं है ना, right? I hope you don't have a class tomorrow, no? Because I kept a test for you guys. That is tomorrow evening. I hope you don't have a test you don't have a class in the morning. Yes or no तो लिख दो भाई. हाँ, okay. So guys, like if you want तो मैं I can pull this off today also, but it will be very taxing for both you and me. Keep because I want you to. No, I don't have a problem. Yeah, I will be taking a class tomorrow also for you guys because we can do rheumatology tomorrow also. Beta ICS. Coming back to the agenda. Okay, let me decide. The plan is we will be doing 2 hours of rheumat. 2 hours तो नहीं लगेगा, 1.5 hour ही है. Rapid revision उतना ही है. So the tentative time is 10 o'clock to 12 o'clock to 2 o'clock tomorrow. That we'll be doing मैं अभी one page I will do with you. 2 hours I will do rheumat, and then evening mein there would be a test that would be conducted. That would be at 6 o'clock. I will type down all the instructions for you guys in the Telegram group as well. Class will be 12 o'clock to 2 o'clock. Test will start at 6 o'clock. Discussion will be done 8 o'clock onwards because I think you guys need time, right? I mean, spend the whole time, turn the pages of medicine and like spend time on that. So this is the plan, the logistics that I have for you. And today what I will do is, now I will just take few minutes of your time. ये 4-5 point कर लो, right? This much of the half page is what we will do. The half page today. You can see on this moment the pop singer, her name is Serena Williams, and गाइस अब कर लो ना, लाइक 12 का टाइम बचा हुआ ना, मैं सिस्टम में भी चेंजेस करवाऊंगा, तो आई डोंट वांट टू टेक अ चांस। मैं 10 बजे बोलूँ, मान लो द स्टाफ, द टेक्निकल स्टाफ को कुछ देरी हो गई, डिले हो गया, आप भी बैठे रहोगे, सो लेट्स कीप इट एट 12 सो दैट दोस गाइज आर आल्सो कंफर्टेबल। So Selena Gomez is yeah, I have decided guys, 12 to 2 I'll type the message in the group also, so please now listen to me, just 5 minutes more and we are done for today. This is Serena Williams, Serena Gomez, sorry, Selena Gomez. Yes, Savita corrected me. Selena Gomez, and she lives in USA. She is a pop star, and she was diagnosed with lupus. America is a country where supposedly the medical healthcare is like supposedly number one, but in her case, she almost died because she was diagnosed with. She almost died because of lupus nephritis. She almost died because of lupus nephritis. So, like in this particular case, like I can say that, I mean, she was very, very lucky that the interventions could be done. So, SLE is the topic that we're studying at the moment, that is systemic lupus erythematosus, SLE. Systemic lupus erythematosus, SLE. And for the E component, I just want to say that we can just reverse it and say it is type 3 hypersensitivity reaction in the patient. Then is what is must-have criteria for diagnosis. Now focus guys, I just need 2-3 minutes more and we are done, so please focus. What is the must-have criteria for diagnosis of systemic lupus erythematosus? Because most questions that I'm discussing today are one-liners, then I'll discuss the cases separately. Yes, Justin Bieber left her basically. It's okay. I mean, ये लोग करते, ये हॉलीवुड वाले ऐसे ही होते हैं. Must have criteria for diagnosis. Okay. Yes, yes, guys. Now move on from Justin Bieber to this. Yes, very good. The must have criteria for diagnosis of this condition is ANA, that is anti-nuclear antibody. इसके बिना diagnosis बन ही नहीं सकता है. And then in the last times INICET exam, this question came that what is the most common body system that is involved in this condition. So overall the most common body system is not the skin, it is not the kidney. That is like one of the impression that we have, because यहाँ पे हम पढ़ते हैं photosensitivity. We read the word photosensitivity. So it is a musculoskeletal involvement that would be seen. So joint pain, myalgia are the kind of manifestations that are present in this patient. And then is what is the type of arthritis seen? Then it is non-erosive polyarticular involvement. Unlike when I will teach you rheumatoid arthritis, there it will be erosive arthritis, but this would be a non-erosive arthritis in a patient. Then the question said, yeah, it is arthralgia, it is non-erosive. Rheumatoid arthritis में तो deformity हो जाती है ना, swan neck deformity, and then you also get that boutonniere deformity. So none of the deformity is present here. What is the type of anemia that is seen in these patients? Then the type of anemia that is seen in the patient is called as normocytic normochromic anemia. The type of anemia that is seen in this patient is called as normocytic, because it is anemia of chronic disease. Why I said most common type of anemia seen in this patient, it is normocytic normochromic anemia, because it is anemia of chronic disease. But if I change the question, it says which anemia in SLE is taken as a diagnostic criteria, then it is autoimmune hemolytic anemia, because autoantibodies are attacking self RBCs. I'll repeat this question once again. If he says what is the common type of anemia, normocytic normochromic anemia, anemia of chronic disease is normocytic normochromic. But if he says what is the type of anemia that is taken as a diagnostic criteria, then normocytic normochromic anemia chronic disease नहीं बोल सकते, क्योंकि chronic disease तो rheumatoid arthritis भी है, inflammatory bowel disease भी है, Crohn's भी है, ulcerative colitis भी है. तो इतनी सारी बीमारियों में अगर normocytic normochromic होता है तो फिर हम इसको specific तो नहीं कर सकते. So if he says which is the part of the diagnostic criteria, it is autoimmune hemolytic anemia. And then comes the question, what is the leading cause of death after a decade? In the first decade of life and after a decade, right? After a decade and in the first decade. If the diagnosis is made early, versus late, then the answers will change. After a decade, the person will usually be like, having most of the time heart disease present. After a decade, the patient will mostly be having heart disease. It is accelerated atherosclerosis. Atherosclerosis would imply that there would be a increased cardiovascular mortality in this patient. He will write increased cardiovascular mortality for the cause of death if the patient is identified after 1 decade steroids पे लिए heart, and साथ में autoimmune disorder is attacking coronary arteries, so heart attacks are common. But if the diagnosis is occurring in the early part, that is in the first decade of life, then there are two reasons why the patient can die. One is कि diagnosis हुआ ही नहीं था ठीक से. Because see, diagnosis of SLE will require like multiple testing to be done. ANA lots of time turns out to be negative also. Without this, the diagnosis can be made. So it can be lupus nephritis, or it can be infections also because of the steroids that the patient is taking. Because of the steroids that the patient is taking at the movement, and therefore diagnosis of SLE is like a challenging task, and there's a proper diagnostic algorithm for it. Normally for SLE, the male to female ratio. Normally for SLE, the female to male ratio will be 6:1. But if I change my question to drug-induced lupus erythematosus, then the value will change. If he says, what is the gender ratio in a drug-induced lupus, then your answer is 1:1. Just remember that statement I said. If he says the word SLE, then it is 6:1. If he says the word DLE, then it is 1:1. And then comes an important question, that is renal involvement. A renal involvement and CNS involvement is rare. When I was describing just now, lupus nephritis was killing the patient, but now the lupus nephritis would not be killing the patient. It is renal involvement is not seen in drug-induced lupus. And then we have drugs. Yeah, this is the last slide. The drugs are HIP. The drugs are HIP-M, that is methyl dopa, minocycline, quinidine, and HIP, that is hydralazine. Then is isoniazid. Yeah, this is last 5 seconds. And procainamide. HIP is the mnemonic. Otherwise, the continuity lose hoti hai na. HIP word is hydralazine, isoniazid, and procainamide are the words for this particular question. And other drugs are also to be remembered: minocycline, methyl dopa, and quinidine. So we are sorted today, guys. I will be requiring your attendance tomorrow again at 12 o'clock. Not that it is a medical college, but yeah, if you attend, then you'll be able to finish the topic faster and quicker with me as compared to trying to doing by yourself. So I will see you again. The starting time is 12 o'clock, and then I see you for a test again. And a full message would be coming, and a full message on the same would be coming in the chat group very soon. So we started, guys. Thank you so much. It was really fun interacting with you for past 6 days. And though I would have said the parting speech tomorrow also, but then yeah, I just want to say that I don't know, that 6 days past went very well. We were laughing and we were enjoying and we were studying also. So it was a good experience interacting with you guys, notwithstanding that some of you keep on posting all kind of stuff in between. But yeah, we'll do the hammering part tomorrow. So yep, take care. Bye bye. नहीं completion कल करेंगे. Okay guys, take care guys, take care. Bye bye. Bye.
constantly gas panel issue.